with diabetes. Let us begin with the postgraduate paper presentation where our esteemed delegates will showcase their latest work and share new insights. I would like to welcome our judges for this session, Dr. Anisa Atif Mirza Ma'am, Professor and Head, Department of Biochemistry, Dr. Pragya Kapoor Ma'am, Associate Professor, Department of CTVS, AIIMS Patna, Dr. Pradeep Meena Sir, Associate Professor, Department of Orthopedics, AIIMS Rishikesh, Dr. Rajesh Kumar Sir, Associate Professor, College of Nursing, AIIMS Rishikesh. Before beginning, we would like to go through the guidelines for presentation. The postgraduate paper presentation of the 5th Annual Conference of Cardiodiabetic Society will be conducted in 2 sessions. First session from 8:30 to 9:30 a.m. and the next session would be at 12:20 to 1:20 p.m. The time allotted for the presentation is 6 minutes and the time allotted for discussion is 2 minutes. So let us begin with the first speaker of the day, Dr. Rahul Amoli from AIIMS Rishikesh.
Good morning everyone, myself Rahul Moli, and today I'm going to present my research work. The title is Impact of SOST Sclerostin Genotype Variant in Early Onset Type 2 Diabetes Mellitus among Young Indians. This is a case control study. Type 2 diabetes mellitus is a global health issue. The prevalence of diabetes has escalated to 9.6% in 2021, affecting around 135 million individuals. The WNT signaling pathway plays a crucial role in the regulation of various cellular processes such as proliferation, differentiation, and apoptosis. The sclerostin is a WNT signaling pathway inhibitor, was found to be the significantly increase in the pre-diabetic and diabetic individuals compared to healthy individuals. No study have explored the association between the SOST gene polymorphism and type 2 diabetes mellitus onset in the Indian population. This study aimed to assess the impact of this gene variant on early onset type 2 diabetes mellitus in young individuals from Uttarakhand. This is a schematic representation of WNT signaling pathway. On the right panel, this is showing the working WNT signaling pathway where the WNT binds with the LRP5 and LRP6 receptor, thus it leads the activation of gene transcription. On the left panel, they are showing the sclerostin, which is an inhibitor of WNT signaling pathway. First, the sclerostin binds with the LRP5 and LRP6 receptor, thus it blocks the WNT signaling pathway and it blocks the gene transcription further. Materials and methods. This study has been conducted in the Department of Biochemistry, AIIMS Rishikesh, in collaboration with General Medicine Department. Here is the algorithm of the study. This is a case control study where less than 40 years age group with diabetes mellitus was considered as cases. We have total 114 cases, and without diabetes mellitus till 40 years age group was considered as controls. We have 115 controls. The inclusion criteria for cases: the age of onset of diabetes mellitus should be 20 to 40 and T2DM with AD criteria from AIIMS Medicine OPD. Now the exclusion criteria for cases: those who have chronic disease like thyroid disorder, autoimmune disease and malignancies was excluded from the study. After collecting the patient consent form, we did the anthropometric measurements. We did weight, height, hip and waist circumferences, and we collect the 5 ml blood sample from each patient, through which the 3 ml serum sample was used for sclerostin by ELISA, and the biochemical tests like HbA1c, fasting blood sugar, lipid profile and intact PTH we did, and remaining 2 ml whole blood sample was done for DNA isolation and restriction digestion at the end gel electrophoresis. This is showing the patterns of digestion in PCR RFLP method. This is SOST gene RS865429G2A. We use the restriction enzyme, that is ANCO1, and the agarogel electrophoresis we did. In this picture you can see in the first line this is showing the DNA ladder, and in the second line this is showing the undigested one, and in the line third as well as in the line 8th This is showing the homozygous digested, which is giving us two different bands at 198 and 165 base pair. And in the LAN 4, 6 and 7, this is giving us the heterozygous digestion at the three different bands like 365, 198 and 165 base pair fragments. And in the LAN 5, this is showing the homozygous and digested band at the one single fragment, which is 365 base pair. Now the statistical methods. Statistical analysis was done by the SPSS 23 version. Whether the data is following the Hardy-Weinberg equilibrium was checked by the chi-square test, and the comparison between biochemical parameters were done by the Mann-Whitney U test and or T test, and the Kruskal-Wallis test or ANOVA, which is an analysis of variant depending on the normality distribution of parameters. Here are the results. The demographic and the biochemical parameters of all study participants. We had 114 cases and 115 controls, and all the cases and controls are equally distributed on the basis of gender. We did anthropometric measurement, and we did for glycemic index, we did HbA1c, we did lipid profile and calcium intake, PTH and sclerostin, but there is no relevant significant difference between the two groups. This is showing the genotype and allele frequency of RS 865429 G2A of SOST gene. Here we can see in the GG genotype has the highest odds ratio, but although it's not significant just because of a low sample size, because there's two cases and one control, but at the same time just because of this highest odds ratio, this is showing that the GG genotype has the highest tendency to develop early onset type 2 diabetes mellitus comparison to the AA and AG genotype. And the association between SOST genotype and clinical pathological variables with total study participants. There we can see the LDL is showing the highest significant values in the GG genotype, as well as other parameters like BMI, adiposity index, HbA1c, and the intake PTH and sclerostin also giving the highest value in the GG genotype. The association between the SOST genotype and the clinical pathological variables in cases, here we also can see there are most of the parameters like BMI, adiposity index, and the waist hip ratio, and the total cholesterol also giving the significant higher values in the GG genotype comparatively to AA and AG genotype. The discussion and the conclusion. Elevated Elevated glucose, lipid and bone metabolism levels in GG genotype suggest SOST variant may contribute to early onset type 2 diabetes mellitus and related complications such as cardiovascular disorder, osteoporosis. This finding highlights the importance of genetic predisposition in the T2DM, pointing to a need for personalized clinical approaches. The larger and multi-center studies are needed to confirm these initial findings. These are my references. Thank you. No sir, we want to just check कि मतलब basically the WNT signaling pathway is controlled by sclerostin inhibition. So we want to check basically it has already discussed कि in diabetic and pre-diabetic condition the sclerostin levels already very much high. So we want to check if there is any correlation between the SOST gene or not.
It was already established this point, or have you established this new?
This is the new in Uttarakhand population.
Okay. So in which type of population has this been described earlier?
This has been there is no such studies in Indian populations, but out of India there is.
Out of India, it has been established.
Yes, sir. Not in early onset basically. They already work with the type 2 diabetes mellitus, but not compared with the early onset.
So some of your data where you've studied your GG genotype has not reached significant levels. There is some p-value, but that has not reached significant values. So is there a way where you can screen and pick up specific set of patients and compare? Does your study help with that?
Yes, ma'am, because of we have also the low sample size.
Yeah.
Only the 3 sample shows only 2 cases and 1 control. So we can't say it's too much significant. We want to the furthermore studies are relevant when the sample size will large.
Thank you, Rahul. I think this is a wonderful job you have conducted. Just few technical issues just would like to ask from you. Did you check the this diabetes mellitus status in control as well?
Yes, sir.
Or it was just by asking them whether you are diabetic?
No, sir.
It was like blood sample?
Yes, sir.
Okay.
HB1C.
Okay. Yes, I think I don't know whether you have calculated sample size for this work or not, because it would have been better if this kind of work would come with the estimated sample size, so that it will be okay to say whether the study finding are significant or they are reaching to a level. But still I appreciate your courage to take such kind of work, which definitely can be taken as a pilot work and it can be extended to the larger study in the futures, and definitely will be helpful for the diabetic population. Thank you.
Thank you. For our next presentation, we would like to invite Dr. Tanya from AIIMS Rishikesh.
Good morning, everyone, respected faculty members, panel members, and my dear colleagues. I, Dr. Tanya Lalwani, junior resident from the Department of Burns and Plastic Surgery, would like to present a few of our cases from our ongoing study on PRP as an adjunctive therapy for treating diabetic foot ulcers. Introduction. PRP has been recognized as a method of treatment in medicine since the 1980s and has since had widespread use in many surgical fields. However, despite its decades of presence in medicine, it is still not widely utilized in wound treatment and does not have a standard formula for preparation. The standard procedure to prepare homologous PRP involves drawing the patient's blood, centrifuging the blood to get multiple layers, and extracting the buffy coat that contains PRP. Many clinics use different methods of preparing PRP that range from centrifugation to varying methods of administrating onto the wound site, such as topical versus injected. We have also tried to use the topical method. However, we haven't got significant results from the topical method, so we went on with the injectable method. Yet, the essential components are the same. As the name suggests, PRP is a concentration of platelets. It is primarily functions by releasing cytokines and growth factors, such as PDGF, transforming growth factor beta, vascular endothelial growth factor, FGF, epidermal growth factor, and these all growth factors stimulate cellular processes involving tissue repair, angiogenesis, collagen synthesis. This is this is a diagram showing the centrifugation of PRP to get centrifugation of blood sample to get PRP. Coming to the cases, our first case was a 69-year-old female. She received 4 number of PRP cycles. We gave PRP every 3rd day to the patient in injectable method. In the next slide, we can see that she has a significant decrease in the size of ulcer after 4 cycles of PRP. Second patient is Rajiv Agarwal, a 48-year-old male. He had gross ulcer and on the ankle of right foot, and he also had osteomyelitis. He received 6 number of PRP cycles administered every third day. This was the result after 6 cycles, VAC therapy and consecutive debridement. Shurveer, 71-year-old male, also received 6 number of PRP cycles. This was his ulcer after 6 PRP cycles. Next is a 46-year-old female, showed significant reduction in size of ulcer after 4 PRP cycles. This is the end result. Arshad, the 46-year-old male, came to us with the present ulcer. He also received 2 number of PRP cycles, and was lost to follow-up after. This was his ulcer after 2 PRP cycles. An interesting case, Udebhan, received from medicine OPD. A 42-year-old male had a diabetic ulcer on hand. He had raised blood sugars above 300, was receiving insulin therapy, came to us for PRP therapy. After 1 cycle of PRP and sugar controls, this was his ulcer, and which was grafted subsequently. This was a patient, Mamta, 36-year-old female, a housemaker, had a diabetic ulcer on her left thigh. She received 4 number of PRP cycles. This was her ulcer on follow-up after 4 cycles. Last case, Mukesh, a 40-year-old female. He received 4 number of PRP cycles, and this was his ulcer after 4 cycles, showing a reduction in ulcer size. To conclude, this case series suggests that PRP is a useful tool in reducing healing times and improving rates of complete wound healing in diabetic foot ulcers. This healing effect was also shown to be seen in patients with the comorbidities of hypertension, smoking, and older age. There is a room for further research, of course, in the application styles of PRP before conclusive statements can be made on the efficacy of injected versus topical PRP healing. The results of this review provide a baseline for further research on PRP use in diabetic patients. These are my references. Thank you.
Dr. Tanya, it
Yes,
was good presentation, but you have not clarified in the dosage, what amount, what volume was given.
Ma'am, depending on the ulcer size of the patient, we either take 2 ml or 4 ml of PRP.
Okay, so depending on the size
ma'am.
and severity of
Yes,
the
ma'am.
case.
Are you satisfied with your results?
Yes, sir. The study is still ongoing, and more patients are to come.
How do you decide the cycles of the PRP? It is
S-
totally subjective, I could see, and there is no criteria to prognosticate the effect of PRP. And I think there are many better ways conducted by your department, only HBOTs and
Sir, patients requiring HBOT, we administer HBOT also for a cycle of 7 to 10 days. But mostly the patients in this study have been benefited from the use of PRP.
I also have seen results with offloading cast, and they heal better than this actually. So I'm actually not very satisfied with the effects of PRP, and I don't think that can be attributed to PRP. 2 cases I would like to say that had shown good results. One was the hand one, and the next one you showed just after that the sinus. That got healed very good. But that is also very subjective. There is no objective criteria for wound healing. Can you put your point on that?
No, sir, we don't have any objective criteria in this study. The study is still ongoing and results are pending, sir.
So there are 2-3 things that I would like to point out, and I would like you to clarify on them. Multiple ulcers that you showed,
Yes.
there were some with still slough present,
Yes, sir.
and there were some with were red granulated, and those received PRP. So as pointed out earlier, you have to describe your ulcers in not just length and width, but they have to be described in depth also, because you did point out that one ulcer had osteomyelitis also. PRP has been around for a long time, and that might be a very good therapy. But whether we use that therapy, whatever we are doing, it has to be presented scientifically. So you have to describe your ulcers in size, length, width, and depth. That is one thing. And the next about presence of slough or not. What did you do for your cultures? And you went ahead and grafted one of those cases. So that has to be pointed out. Another thing I want to know is you said diabetic foot ulcers, but we showed 2 cases of hand ulcers.
Yes, ma'am. One hand ulcer and one ulcer on thigh, ma'am.
On thigh. So
Yes.
is it diabetic foot ulcer? I will still take it lower limb as foot ulcer. But if you're presenting foot ulcers, then you're presenting foot ulcers that should not include a upper limb ulcer. And then you have to be specific as to upper limb getting a diabetic ulcer. It's not something very well described or known commonly.
Ma'am, it was also a chronic non-healing ulcer.
So that is the next thing.
Yes.
As to what we are describing as diabetic foot ulcers, have you any study or details about their vascularity? Do they have peripheral vascular disease, and how associated diseases have affected? Because this is an excellent study.
Yes, ma'am.
You should be able to present it better.
Yes, ma'am.
Yes, and I understand that this is an ongoing study. So other comorbidities, you would be keeping track of
Yes,
those
ma'am.
comorbidities.
Gee, yes.
So since you are presenting that, you should come out with some comment on that.
Ma'am, some of our patients had CT angiography done and were found to have PAD. Ongoing treatment of PAD and along with sugar control and debridement had benefited the patients, ma'am. The patients who had slough on their ulcers, I have debrided them first for 1 or 2 cycles, followed by PRP and HBOT, ma'am.
Dr. Tanya, I think
Yes.
it's a good work what already expert talk about that. And more or less they spoke on all the comments. I'm quite agree with those comments. I think a little more meticulous planning is required to make it more effective, more objective, and more like in the form of either case control or in the form of RCTs, so that you must have objective criteria in your hand and you can exactly say, because as Dr. Pradeep and Madam also rightly said or point out, it's very subjective to say few things, because how much times like it has taken to heal overs, how large the wound was theirs, and definitely there are many confounder with those, because you have patient with different gender, different age groups, and different other comorbidity that can play a very significant role in the wound ulcer or this wound healings. So I think by taking all those points into the considerations, you can make it a better study.
Yes.
But it's a good work, no doubt about that. And hopefully you will take all the comments.
Yes,
Thank
sir.
you.
Thank you, sir. Thank you.
We thank our presenters and judges for this session. We'll continue with the postgraduate paper presentation in our next session at 12:20 p.m. Thank you, judges.
Good morning, respected faculties, delegates, and dear colleagues. I welcome you all to the official inauguration of 5th Annual Conference of Cardiodiabetic Society, headed by Professor Ravikant Sir as President and Dr. Mukesh Perwa Sir as Secretary of Cardiodiabetic Society. To begin with the proceedings, we would like to invite our dignitaries to the stage. We are glad to have among us our chief guest, Professor Meenu Singh Ma'am, Director and CEO, AIIMS Rishikesh, our guest of honor, Professor Jaya Chaturvedi Ma'am, Dean Academics, AIIMS Rishikesh, our special invitee, Professor Sanjeev Kumar Mittal Sir, Medical Superintendent, AIIMS Rishikesh, our organizing chairperson, Professor Ravikant Sir, Professor and Head, Department of Medicine, co-chairperson, Dr. V.S. Pai Sir, Additional Professor, Department of Medicine, and our organizing secretary, Dr. Mukesh Perwa Sir, Additional Professor, Department of Medicine. We invite you all on the stage.
I would like to request our organizing chairperson, Professor Ravikant Sir, to welcome Professor Meenu Singh Ma'am with a floral bouquet. I would like to request Dr. V.S. Pai Sir, Additional Professor and Head, Division of Rheumatology and Clinical Immunology, Department of Medicine, AIIMS Rishikesh, to welcome Professor Jaya Chaturvedi Ma'am, Dean Academics, AIIMS Rishikesh. I would like to request Dr. Mukesh Perwa Sir to welcome Professor Sanjeev Mittal Sir with a floral bouquet. I would like to request Dr. Darab Singh Sir to welcome Professor Ravikant Sir with a floral bouquet. I would like to request Dr. Anisa Atif Mirza Ma'am to welcome Dr. V.S. Pai Sir. I would like to request Dr. Pradeep Meena Sir to welcome Dr. Mukesh Perwa Sir. We'll now begin the event by invoking God's blessings. I would like to invite Professor Meenu Singh Ma'am, Professor Jaya Chaturvedi Ma'am, Professor Sanjeev Kumar Mittal Sir, Professor Ravikant Sir, Dr. V.S. Pai Sir, Dr. Mukesh Perwa Sir, Dr. Darab Singh Sir, and all our esteemed faculties to join for the lamp lighting ceremony.
I would now like to invite Professor Ravikant sir, organizing chairperson, to deliver the welcome address. We welcome you, sir.
So, a very good morning to you all. First of all, I welcome most honorable, respected Director AIIMS RISHIKESH, Professor Meenu Singh ma'am, for sparing the time for the inaugural ceremony. I welcome Madam Dean, Professor Jaya Chaturvedi madam, to the inaugural ceremony, and Professor Sanjeev Kumar Mittal, Medical Superintendent, AIIMS RISHIKESH. So we wholeheartedly welcome you, ma'am, and I welcome faculty members from across India, Professor Prashant P. Joshi sir, Executive Director AIIMS Nagpur, Professor Jyoti Prakash from AIIMS Patna, Dr. Pragati Kapoor from AIIMS Patna, Dr. Bala Murugesan from JIPMER, Dr. Himanshu from KGMU, Professor Vikas Agarwal from SGPGI, Professor Survi Vyas from AIIMS Delhi, Dr. Anirudh from AIIMS Raebareli, Dr. Rohit Rana from AIIMS Batinda, Dr. Kartika Bhargav from Medanta, and Dr. Arnab from Army. Dr. Jitesh from Bangalore, and there are in-house faculty members. I welcome you all, Professor Anisa, Dr. Rajesh, Dr. Pradeep, and those from my own department. It is in fact a very memorable event for the Department of Medicine to conduct this annual conference in the month of November. So I welcome the residents from other medical colleges from Gwalior, Batinda, and Raebareli from other medical colleges from Uttarakhand, guests of the dais, ladies and gentlemen, officers from administration, other sections, my own supporting staff, and dear friends. You are welcome for 2 days of academic extravaganza. The Cardiodiabetic Society is relentlessly working in the field of academics, awareness, public education, to further research in the field of cardiodiabetes, which is basically combination of cardiac disease and diabetes. They go hand in hand and they cannot be separated. Today, the person who is diabetic is definitely going to have a cardiac disease. Now there are so many, there are so many societies who are advocating a combined approach for having the treatment armamentarium going together to identify the risk factor well in time and to tackle them. So I welcome you all for this academic feast. Thank you very much.
Thank you, sir. Now I would like to invite Professor Sanjeev Mittal sir, Medical Superintendent, to address the gathering.
Respected Director Madam, Dean Madam, Organizing Secretary, Chairperson, Dr. Ravikant, all the faculty of the Department of Medicine, and all the other faculty members, the guest faculty from AIIMS Patna, Nagpur, and KGMC and other places, all the residents, other presenters, delegates, and all others. This is such a combination of cardiology and diabetes, and I know this society was framed a few years back, around 10, 11 years back, I think. And I had a chance to attend a session in the first founding year also, when Dr. Ravikant and others. And this is something like, it opens a new arena, like what is the significance of heart diseases in diabetes, like it is known, and diabetes, we know that diabetes is leading to heart disease. But cardiac disease, how it is going to affect the diabetes. So that thing, new things come up with all new research modalities. So with this all, my all the best wishes for this all 2 days consolidated program with best of wish everyone. Thank you very much.
Thank you, sir. Now I would request Professor Jaya Chaturvedi ma'am, Dean Academics, AIIMS Rishikesh, to address the gathering.
Good morning, everyone. Respected Director ma'am, all the dignitaries present here, and all the delegates. It is my pleasure to welcome you all here in this 5th annual conference of Cardiodiabetic Society, which is done regularly by collaboration with our general medicine department. And when something is done very regularly, it becomes a ritual. And ritual should be done always wholeheartedly, and we should gain from that. And because all the awareness campaigns are going on in the diabetic arena, we can see. So, lot of changes daily we are observing in the treatment, in the diagnostic modalities, and this is the disease which is affecting our life with many organs which are affected by the disease. So it is very necessary to work very hard on this and learn whatever is possible and change the lifestyle of the people. Thank you so much.
Thank you, ma'am. Now I would request Professor Meenu Singh, ma'am, Director and CEO, AIIMS Rishikesh, to address the gathering.
Thank you very much. And dignitaries on the dais, Professor Jaya Chaturvedi, Professor Mittal, Professor Ravikant, and Dr. Venkat, and Dr. Mukesh. And also many dignitaries who are there off the dais, who've come from different institutions, including AIIMS. We also have our Dean Examination, Dr. Patil, in the audience. So this particular congregation, I would say, and this collection of experts is focusing on cardiodiabetes. There was an era in medicine when medicine was getting divided into specialities or subspecialties, and some people call them super specialities. So there were cardiology, there was endocrinology, there was neurology, nephrology. Now again we are seeing a confluence of certain disciplines, and that is leading to a better approach towards medicine. And we know that most of the diseases people have now found a genetic basis. And it has been seen that in many of these cardiac and endocrine diseases, the genes play a lot of role. In fact, they have an overarching role over all other factors. Even the epigenetic forms and the gene-environment interaction which takes place, because environment is actually influencing the disease in a very, very important way. There also one can see that things are now becoming and getting much more personalized. And that is why we are talking of personalized medicine. And for personalized medicine to be effective and to be designed for a particular patient, because that is what it means, that it is one size doesn't fit all. So everybody has a different constitution, and that has to be looked at in a very particular way. So for that, if we indulge in various analysis, genetic, proteomic, even transcriptomic, so those things give us ideas about new drugs and new modalities for treatment of these diseases in a very holistic way. Because cardiac and diabetes are, we know they were interlinked. When we were students, we were told that, or even later, that diabetes is actually one of the cardiovascular diseases. In fact, I think in Davidson or Harrison, it comes under the heading of cardiovascular diseases, because it has such important bearing, especially type 2 diabetes has so much of bearing on cardiovascular system that many of these patients would actually die of heart attacks, and sudden cardiac death is something which is very well known in these patients. But then there are all other systems which are involved. And we were actually recently looking at a project for artificial intelligence in which people looking at fundus, and we have ophthalmologists with us, Dr. Sanjeev Mittal, that looking at the fundus and the retina, one can predict the diagnosis of cardiovascular disease as well as diabetes, using several means of artificial intelligence. Now there is a huge database which is there on, which is available, on which if you have fundus pictures and you upload them on that particular database, they will be predicting that this person is likely to get diabetes after so many years, and will also take into account other risk factors, and so it will also tell when this patient will also end up having a CAD or a stroke, because that is something which is a natural follow-up of these diseases. So what I mean to say is that following these two streams, one actually gets to learn the whole of medicine, and it is something which is also affecting our health services. We know that diabetes is producing so much of renal failure, and even hypertension would lead to so much of renal failure that there are so many people who are now looking for dialysis. And we were just discussing 8 to 9 in our statistical meeting, a patient who passed away because of renal failure, but also had hypertension and all other risk factors. So I think this integrated approach towards patient care is something which is emerging, and this is something which we must follow. And same is the thing that if we apply different kind of modalities of treatment, and as Rishikesh is known for yoga and Ayush, I mean, I am a very strong votary of that we must integrate that particular stream also into our management of patients, and not just rely on drugs and all other modalities. Of course, drug, diet, and exercise are very important. So with these words, I really want that all of you, the students and the residents especially, would learn a lot from this particular conference, and all the faculty would have very rich interactions to take some of the research projects, collaborative research projects, because we see there is a participation from different AIIMS in this particular conference. So we can set up actually a network of, you know, all AIIMS, because there are, we have so many AIIMS now, and we can set up a network for study, a rich study, so that we can come out with some very, very plausible results and conclusions. So thank you very much for inviting me. Thank you. Jai Hind, Jai Bharat.
Thank you so much, ma'am. We would now like to felicitate our dignitaries whose presence truly elevates today's event with a memento as a token of gratitude. I would like to request our organizing chairperson, Professor Ravikant sir, to felicitate Professor Meenu Singh ma'am. I would like to request Dr. Mukesh Berwa sir to felicitate Professor Jaya Chaturvedi ma'am. I would like to request Dr. V.S. Pai sir to felicitate Professor Sanjeev Mittal sir. I would like to request Dr. Rohit Raina sir to felicitate Professor Ravikant sir. I would like to request Dr. Arnav Chaudhary sir to felicitate Dr. V.S. Pai sir. I would like to request Dr. Jitesh sir to felicitate Dr. Mukesh Berwa sir. I would like to request Dr. Pradeep Meena sir to felicitate Dr. Darab sir. I would now like to request Dr. Mukesh Berwa sir to present vote of thanks.
Good morning to all. I like to thank our respected Director Professor Meenu Singh, who is always focused in the research as well as clinical work. I like to thank Professor Jaya Chaturvedi Madam to give all the permission for this mega events, and I like to thank our Medical Superintendent Professor Mittal sir, give all the opportunity to do these type of events. A special thank to Professor Ravi Kant, Head of Department, my colleague Dr. V.S. Pai sir, Dr. Darab Singh, for organize this type of very eventful or very successful event for the conference of 2 days of Cardiodiabetic Society. I like to thank all the speakers who came across the all over India, chairpersons, judges of all the sessions, in-house faculty as well, Professor Patil sir, who is the Dean Examination, all the residents who give me all the support to organize these events, all other my ex-resident who become now faculty in the various departments, Dr. Rohit Rena sir, Dr. Bala Murugesan sir, Dr. Jyoti Prakash sir, Dr. D. Himanshu sir. I like to thank all the media partners, offline and online. I like to thank the broadcasting agency, Sri Balaji Studios, and all the pharma companies who support us to organize this event. And finally, I like to thank all my teams, junior resident, supporting staff, nursing officer, who give me the support to organize this event. Thank you so much.
Thank you so much everyone. Now I would like to request everyone to join for the breakfast. I would request all the faculties to join for the group photograph. We'll join back after 15 minutes. Thank you so much.
फिर वो उसका कैसा करा? अरे यार ये भी परेशान ही है। हेलो हाँ हाँ बता, अंदर हूँ।
Our first series of session for the day is on infectious disease and critical care. We are excited to begin this session with a thought-provoking debate on a timely topic, the use of SGLT2 inhibitors in sepsis and multi-organ dysfunction syndrome. Today we have two esteemed experts who will present opposing views on this issue. On one side, we have Dr. Arnab Chaudhary sir, classified specialist in medicine and intensivist, Armed Forces Medical Services, and Associate Professor, Department of Medicine, Armed Forces Medical Services, who will argue in favor of using SGLT2 inhibitors in managing sepsis and MODS. On the opposing side, we have Dr. Jitesh, consultant Narayana Hridyalaya, Bangalore, who will present concerns regarding their use in these critical conditions. Please also welcome our chairpersons for this session, Dr. Nidhi Ma'am, Associate Professor and Head, Department of Emergency Medicine, Dr. Ajit Singh Bhaduria sir, Associate Professor, Department of Community Medicine and Family Medicine, AIIMS Rishikesh, Dr. Anirudh Mukherjee sir, Assistant Professor, Department of Medicine, AIIMS Rai Bareilly. Please welcome Dr. Arnab sir to present the opening statement.
Good morning to all of you. After a heavy and a hearty breakfast, I think our carbohydrate levels are high and we should be able to focus, albeit for a few minutes into this topic. The topic which I have been given to present today is SGLT2 inhibitors and sepsis, its role in sepsis. You know, SGLT2 inhibitors, I think a new drug in the market, it's quite old now. It's been quite some time now that this drug is there in the market. But yes, we all know its CV benefits, its renal benefits, its and other pleiotropic effects. But yes, its effect on sepsis and how does it fan out over a wide spectrum of sepsis and MODS patients, because we all know the variegate nature of patients who get admitted with sepsis and septic shock. So have we hit the magic bullet yet? Just a small background, we all know that there are a class of drugs which are primarily used to manage type 2 diabetes. Its use in heart failure, chronic kidney disease has expanded due to its cardioprotective and renoprotective effects. Their role in sepsis and multi-organ dysfunction has actually sparkled a lot of debate, and a lot of preclinical, anecdotal and studies are coming up regarding its use and its possible and plausible benefits in sepsis. I'll just run through it. We all know the renal glucose reabsorption in healthy individuals, what happens in hyperglycemia, and the effect of SGLT2. There is blockade, as a result of which there is distal sodium delivery into the distal nephrons, and it reduces the blood sugar levels. We all know the various pleiotropic effects of SGLT2 inhibitors, which includes weight loss, improved cardiovascular profile, and so on and so forth. We are all aware of all these features, and also various other pleiotropic and CV benefits. Various landmark trials which have studied the renal outcomes, the CVOT outcomes, I have just enumerated these, but the topic for today is not based on these trials. So actually, what are we debating about today? What next in SGLT2? Does it actually benefit in sepsis? And do we have any concrete evidence, or do we have any anecdotal evidence to support or to use it in patients who are actually sick and are admitted in ICU? Before this, I just want all of you, I'm sure all of my residents and all, they are well versed with the Surviving Sepsis Guidelines 2001. If you see the evidence of sepsis guidelines, most of this evidence, if you see, they are weak recommendations and low quality of evidence. Some of them are best practice statements. But if you see the resuscitation component of these sepsis guidelines, these are the guidelines which are followed all over the world, and we do also use all these guidelines in our ICU. So it doesn't mean that an evidence has to be a grade A or a class 1 recommendation to actually practice it in our ICU. It can be customized, it has to be user-based, and it depends from population to population. So my first argument comes, reduction of inflammation and oxidative stress. So what is the proposed mechanism? We all know that high glucose concentration in the body, it promotes pro-inflammatory signaling pathways such as nuclear factor kappa B, which is central to production of pro-inflammatory cytokines like TNF-alpha, interleukin-6, and all other host of factors, which includes the pathogen-associated molecular patterns, the pathogen recognition receptors, the DAMs, and the downstream signaling cascade, which leads to activation of the reactive oxygen species, the NLR and the ASC receptors, the caspases, and it eventually culminates into inflammation, which is the hallmark of sepsis patients. So what is the evidence? So this was a study which was published in Diabetology and Metabolic Syndrome as late as 2024, wherein it actually dwelt upon the advances in anti-inflammatory effects of SGLT2 in type 2 diabetes. We can see that SGLT2 inhibitors across the spectrum, be it canagliflozin, empagliflozin, dapagliflozin, it helps in reduction of the expression of inflammatory biomarkers. It affects the inflammatory signaling pathways and regulates the metabolic pathways to various downstream genetic, epigenetic, and other molecular pathways, which actually potentiates the anti-inflammatory effects of SGLT2. The second argument is, does it help in prevention of the dreaded capillary leak syndrome? We all know capillary leak syndrome in sepsis is a dreaded complication. There is intense vasoplegia which generally occurs in sepsis. And how does it generally occur? It occurs because of the lipopolysaccharide, which causes increased vascular permeability and a state of vasodilatation and vasoplegia. So how does SGLT2 inhibitors actually prevent this? The SGLT2 inhibitors, they actually activate a signaling pathway, that is the alpha-1 AMP kinase pathway in endothelial cells, which upregulates these pathways and mitigates the increased vascular permeability and may retard sepsis propagation. So this is the, the pathway and the downstream cascading effect of severe capillary leak, which leads to inflammation, and we try to tackle this capillary leak and downstream cascade by giving albumin, by giving vasopressors and whatnot. But nothing has been conclusively proven or effective in preventing this capillary leak. So this study, again, a very good study which was done with canagliflozin, which actually demonstrated that it protects this capillary leak syndrome by the thing which I just mentioned, by increasing the activity of alpha-1 AMP, which actually helps in binding the endothelial gap junctions and prevent the capillary leak. Again, a good narrative review of immunomodulatory and anti-inflammatory effects of SGLT2 inhibitors, unraveling novel therapeutic frontiers. Again, it's a busy slide, I understand. It's not to be read, but the gist of this slide is that there are multiple signaling pathways which have got multiple pleiotropic effects by which it has shown to help people in sepsis, or patients who are already on SGLT2 inhibitors can continue with sepsis until and unless there are compelling indications. The third argument, risk of sepsis and pneumonia in patients initiated on SGLT2 inhibitors. Again, this was a study which was done as a comparative statement using a propensity trial, in which a propensity trial is nothing but which is used in the study population in an observational study wherein it behaves like a RCT, and there are two arms wherein DPP4 inhibitors and SGLT2 inhibitors were used. And so this is ultimately, if you see the SGLT2 inhibitors and DPP4 inhibitors, these patients were included. The total number is mentioned in this slide. The result, I'll just come to the result. It says that those patients who were already on SGLT2 inhibitors had a 37% lower risk of incidence of pneumonia vis-a-vis to those patients who were on DPP4 inhibitors. Also, it also had a 48% decreased risk of sepsis with a p-value of less than 0.001 compared to new use of DPP4 inhibitors in an acute care setting. Again, if you see this forest plot, you can see there are two variables. Basically, those patients who were on insulin and on statins have got a better pneumonia prevention profile as compared to DPP4 inhibitors, which were included in this study. Now, this again, it was a animal study wherein which was published in the Cardiovascular Diabetology Journal, which showed that these SGLT2 drugs, they basically attenuate the cardiac fibrosis and improve hemodynamics in hypertensive heart failure rats. So if you see this diagram, so these are trichome, mesom trichome stained hearts of cardiac, wherein 3 varieties of mouse was used as a subject. The first one was the wild type, the second was the spontaneous hypertensive rats, and third was those rats which were treated with empagliflozin. So if you see, there is a significant reduction in the those spontaneous hypertensive rats who were treated with empagliflozin vis-a-vis not treated with empagliflozin, and it prevented the fibrosis and hemodynamic effects. Again, the effects of LG2 inhibitors on pathophysiology of cardiovascular disease, again, these effects are self-explanatory. Again, in COVID time also, SGLT2 were used to show whether there was any benefit or not. To this effect, there was this trial known as the DARE-19 trial, which was a very robust study. Although this trial did not show any statistically significant evidence of SGLT2 inhibitors in prevention or preventing the complications of COVID-19, but you know, there was no harm and it was well tolerated. So there is something known as a statistical significant finding of a drug and something whether it is clinically relevant or clinically significant or not. So those patients who are already on these drugs, when we continued these drugs during this trial, they did not have any adverse effects. Rather, it helped them. It may be a causal kind of a relationship or an anecdotal relationship, but there was no harm in utilizing it. So more robust studies are actually required. So again, this was a subgroup study which was done in the same trial, wherein these are the two dapagliflozin versus placebo in outcome measures of all-cause mortality. So here you can see there was a significant reduction in the all-cause mortality in those patients who were actually on dapagliflozin. Although there may be a lot of other confounding factors, but yes, since we are, this is a new topic and this is a new molecule which has been included, which is being tried to be included in acute care setting. Now again, this was a recently done trial known as the Defender trial in 2024. It also included, two sets of patients, which include dapagliflozin as well as the standard of care using a win ratio model. Here you can see the win ratio was 1.01. This is again a new concept wherein it acts like a, the hazard ratio, wherein any value which is more than 1 is considered to be significant. So what were the key encouraging results of this trial? Firstly, despite a neutral result for the primary endpoint, dapagliflozin use was appeared to be safe in a population of critically ill patients with a hospital mortality of around 35%. Adverse effects were similar in both groups with no ketoacidosis, and none of the outcomes or post-hoc analysis do not exclude the potential benefits or harm in any way. So again a very good trial wherein SGLT2 associated with improved outcome in diabetic patients admitted to ICU with septic shock. Again, there were 62 patients who were employed in the non-SGLT2 group and 36 in the SGLT2 group. Again, you see the inpatient mortality. There was a significant reduction in inpatient mortality, although the 28-day and the 90-day mortality was not significant. But yes, now these studies do suggest us that we may try to incorporate this drug into our own critical care setting. Again, empagliflozin suppressing inflammation and protection against acute septic renal injury. Again, this was a study which was done as a preclinical trial in kidney injury patients, where you can see those patients who were on empagliflozin had a good glomerular recovery who had presented with AKI. Reduction in lactic acidosis and improvement in mitochondrial function. Again, the switch from the carbohydrate and the glucose metabolism to ketone metabolism has also shown to improve the cardiovascular and other septic profile of patients. So these are again just two more slides. Worried about complications, fourniers gangrene, a very good systematic review which showed that the studies have shown that it is very, very minuscule, 1.6 per 1 lakh among males and even lesser in females. So these kind of complications do arise in patients who are in ICU setup, and I think with good antibiotic coverage, if at all these things arise, we can tackle it. Again, the ketogenic effects of, it is said that ketones will rise with SGLT2 and it causes harm. But again, there is this new study which has come up that there is a synergistic effect of SGLT2, and combining a ketogenic diet improves the metabolism of patients and improves patients who are critically ill. So to conclude, preclinical studies and evidence from, these are robust trials, EMPA, DAPA, it has shown strong rationale for the potential role in managing sepsis and related complications. More robust clinical trials obviously is required to extend this validation, and most of this evidence points towards a beneficial role of SGLT2 inhibitors in mitigating sepsis, MODS, and renal injury. Risk of ketoacidosis, fungal infections, and UTI are comparable to placebo / can be well managed in a closed ICU setup. So to conclude, what is the bottom line? The bottom line is whether to use it or not, that is the question. It is user dependent, customized to specific patient subgroups, but definitely worth including as a part of sepsis care and part of larger, robust clinical trials. It cannot be negated because of its multiple pleiotropic effects. Thank you.
Thank you, Dr. Arnav. I think questions we'll take in the end. So we'll go with our next speaker.
Thank you, sir. Now, I would like to invite Dr. Jitesh, sir, to present his views against the topic.
Good morning, everyone. Myself, Dr. Jitesh. I'm Associate Consultant in Narayana Hridayalaya. So, the topic for today's debate is SGLT2 inhibitors in sepsis and modes. So, basically, what I will be doing is, I'll be pertaining it into the complications. So, are we desperate enough to treat sepsis? That is basically what I'm going to address. Like, the data, whatever we are getting today, is it just only we are getting a minute data, and are we trying to amplify it? Because we are still desperate enough to treat sepsis. There is no proper immunomodulatory treatment what we have. So that's it. So let me go to the proper topic. So like this is just again the mechanism of action. SGLT2 receptors located in the PCT part. So it is responsible for the 90% of the resorption, and SGLT1 is also located nearby, which is responsible for the 10% of the resorption. And SGLT2 inhibitors inhibit the absorption and promotes glucosuria, thereby help in reduction in blood glucose. Then, so what all are the current ADA recommendation? ADA has recommended its use in chronic disease like heart failure with preserved ejection fraction as well as in reduced ejection fraction. Then in case of CKD, it has been, ADA has recommended it. Now, so let me go to the main complications, and the complications I will be discussing in particular. Initial first few slides will be based on the normal population, and then I will be how it can be portrayed to the critical care population. So these all are the most common complications that we are going to encounter in the normal society. Like one is genital tract infection, urinary mycotic infection, hypoglycemia, volume depletion, diabetic ketoacidosis, lower limb amputation, bladder carcinoma, then bone fracture, Fournier's gangrene, and acute kidney injury. So first let's go to the diabetic ketoacidosis. So why are we so much worried about diabetic ketoacidosis? The diabetic ketoacidosis that occurs with SGLT2 inhibitors is euglycemic diabetic ketoacidosis. So we will have a lower threshold. We may miss it very easily in a ICU setting. So the first meta-analysis, the recent meta-analysis that came in 2023, they had taken around 36 trials, and they found out that the risk associated with diabetic ketoacidosis is around hazard ratio is 2. Then there is another famous population-based cohort study that was done in Canada and UK. This study has done over a period of 2013 to 2018, and they found out that the SGLT2 inhibitors are associated with an increased risk of diabetic ketoacidosis. It's not a single drug effect, it's a class effect. All the drugs like canagliflozin, dapagliflozin, and empagliflozin, all these drugs are responsible for causing diabetic ketoacidosis. So now how SGLT2 inhibitors leads to diabetic ketoacidosis? Basically, SGLT2 inhibitor promotes glucosuria. So glucose itself is an insulin stimulus for insulin release. So insulin is getting suppressed. Along with it, it also stimulates glucogen secretion, thereby promotes diabetic ketoacidosis. So why? What happens in a critical care perspective? So one, as I earlier mentioned, it leads to the delayed recognition. Second, most of the critical care patients are in a state of catabolic state. So already the other stress hormones are in play. So thereby again promotes the occurrence of diabetic ketoacidosis. Then sepsis and inflammation, which itself is a major risk factor for the occurrence of diabetic ketoacidosis. Then effects of other drugs like steroid and all, which we use in very commonly in ICU, can also promote the occurrence of diabetic ketoacidosis. So overall, if we consider if diabetic ketoacidosis occurs because of the use of this SGLT2 inhibitors, the patient will have a prolonged hospital stay and again increases the risk of mortality. Now, next let's go to the urinary tract infection. The first evidence came from a meta-analysis that was published in the year of 2012. Based on this and along with a lot of case reports was came, and FDA has issued a warning against the use of SGLT2 inhibitors. So after that, again, one more meta-analysis came. So that meta-analysis basically mentioned that the urinary tract infection, there is no significant association. But what they found out, the dapagliflozin, which we use very commonly, is associated with a higher risk. That is, if we do use dapagliflozin at a dose of 10 milligram, it is associated with a higher risk of urinary tract infection. So, and even after this meta-analysis, FDA has not withdrawn the warning. So basically, still FDA warns us the possibility of urinary tract infection in the case of a common population. Now, how can we extrapolate it to the next one? Increased risk of genital tract infection. So clinical trials have shown that there is a 2 to 4-fold increase in the incidence, and women who are commonly affected with the occurrence of the mycotic infections, males are also affected. So the meta-analysis has found out that there is a higher risk of genital tract infection, like about 9.5%. So this was again proven by a meta-analysis that was published in the Diabetes, Obesity and Metabolism, which states that the incidence of the genital tract infections are very much higher. Now, how can we extrapolate this to an ICU background? So basically the ICU patients are catheterized. So in a background of a glucosuria, that promotes the concentration of the glucose in the urine, so thereby promotes the growth of organism. So thereby patient can end up with severe dreadful UTI. Because ICU stay itself is a risk factor for urinary tract infection, and ICU, the urinary tract infection is one of the most common cause of sepsis in hospital acquired sepsis. Then, second, so basically what happens if we get a fungal infection, like if we grow candida in urine, what we mainly take it as a colonizer. So we will treat it, we will just remove the catheter and we will treat the patient unless it is not as urological patient, or unless the patient is not immunosuppressed, or if there is any signs of inflammation. But on the background of dapagliflozin or SGLT2 inhibitors, we don't know what we should do, whether we should treat it or we should wait. So that is again, it will come to the picture. So next, one of the deadlier complication, that is Fournier's gangrene. So it is a necrotizing fasciitis of perineum, and the risk factors are mainly older male, people with diabetes, alcoholic, peripheral artery disease, trauma, and immunosuppression. These are the main population which we are going to get in ICU. So all these population are at risk for Fournier's gangrene. Now, one of the research that got published in the Annals of Medicine, it is actually saying that the incidence of occurrence of Fournier's gangrene was very much increased compared to the common population. There were around 55 cases over a period of 10 years. That data is coming of 6 years, there was around 55 cases, and FDA has issued again a warning of occurrence of Fournier's gangrene in the normal common population. So why it happens, we don't know the exact pathology, how the Fournier's gangrene is happening in the ICU population. So what all are the clinical recommendations, what we mentioned for if we are starting dapagliflozin in a common population? We will say that watch for pain, watch for tenderness, any erythema, any swelling. So, and how will we treat? We will treat with broad spectrum antibiotics and debridement. Now, how does this Fournier's gangrene can impair the critical care patients? So basically one thing, most of the patients in critical care, they may be sedated, maybe on some kind of pain medication. So the pain, which is the main symptom of Fournier's gangrene, we may not be able to recognize it. Second, masking of the symptoms. So that I told. Second, perineal hygiene. So most of these patients are on, they cannot, perineal hygiene may not be maintained. So again, that is another risk factor. Then, already patients are in a state of immunosuppression. So once the Fournier's gangrene set up, it can go for an extensive involvement. Then again, it increases the hospital stay and hospital mortality. Now, occurrence of acute kidney injuries with SGLT2 inhibitor. So basically, the post-marketing surveillance, which was done after the SGLT2 inhibitors, they found that around 101 cases was been found in the year of 2015, and they had FDA has issued a warning against for the use of SGLT2 inhibitors, and they have suggested the occurrence of acute kidney injury in case of SGLT2 inhibitors. So after that, one of the recent meta-analysis that came up there, that was suggested that there is the occurrence of AK may be less, or the initial fall in GFR may be in the common population, even though there is a fall in GFR, it may get stabilized over a period of time. So So what all are the what all are the recommendation we give to prevent the occurrence of AK in a common population? One, we used to monitor the kidney function. Second, use cautiously in patients with hypovolemia. Then use cautiously if the patients are on NSAIDs, AC inhibitors, ARBs, and effect may be not well demonstrated if the GFR is less than 60. So now, how does this AK affect in critical care perspective? The patients in ICU are already hypovolemic and hypotensive. So already they are on an N number of nephrotoxic drugs. So we won't be able to find out whether it is because of the drug or if it is because of the other causes. So again, why should we put our patient on stress? Then incidence of hypotension. The hypotension mainly occur by because of glycosuria, it has osmotic diuresis, leads to loss of water, thereby leading to hypotension. So in the American College of Cardiology, they have very specifically mentioned to stop dapagliflozin or SGLT2 inhibitors 4 days before any cardiac surgery. So they themselves expect a prolonged hospital stay or hypovolemic effect in an ICU patient or in an operative patients. So osmotic diuresis, intravascular volume depression, and many drugs that exaggerate the hypovolemia may be already present. So next one is hypoglycemia. So in hypoglycemia, what happens is basically the drug will help in managing the blood glucose, but we need a good control in ICU. We need to have a target of 140 to 180. So insulin still holds the main drug, and once the insulin come to play, the protective effect, like we always say that SGLT2 don't cause hypoglycemia because of the effect of glucagon, that will get vanished. So again, hypoglycemia can occur. Now, amputation risk. So in amputation, what happens in the critical care perspective is the patients are already on vasopressors, may promote peripheral vascular disease, can lead to limb amputation. Now, why to add SGLT2 inhibitors in a critically ill patient? One, sepsis, glycemic control, heart failure, and organ protection. I will be going one by one. In sepsis, what does it do? There are, as Arnab sir has already mentioned, there are lot of some mechanisms has been suggested in the action. But what does the first trial shows? That has got published in the acute critical care journal. So the study was conducted it is a retrospective cohort study. The patient was who got admitted with ICU with septic shock. The population, we need to be very careful with this population. The population actually is those who were taking SGLT2 inhibitors before ICU admission and those population who were not taking SGLT2 inhibitor, they were admitted to the ICU, and once they were randomized to two groups, one SGLT2 arm group and the non-SGLT2 arm group. But the most important thing, none of this population during the ICU stay received SGLT2 inhibitors. So they were distinguished into two groups based whether they were taking it earlier. And what they found out that the in-house, the hospital length of stay, then the 90-day mortality, all those things were non-significant. And the inpatient mortality, there was a reduction, but we were not sure whether it is because of the earlier administration and the drug was not going on an acute basis. So next one is role of it in glycemic control. So this is a pilot trial. The pilot trial which DAPA was used in the ICU, and they found out that there was reduction in the blood glucose. Yes, sir. One. So at a cost of hypernatremia. So there are again case reports coming. Then most important trial, DARE 19 trial, that was based on COVID time. So again, DAPA was used at that time. They found out that, see, this graph was shown by my colleague. Actually, he has forgot to show that there is a p-value was not significant. The p-value is more than 0.8. So that again, that trial don't have any clinical. Yeah, it may be you can project it out, but still we don't know it whether it's useful or not. Then in the Defender trial, what we found out? Defender trial, they found out that addition of dapagliflozin in the critical ill patient and acute organ dysfunction did not improve the clinical outcome. So issues that can occur in a critical care patients are infection, hypoglycemia, hypotension, AKI, euglycemic decay. We are not sure of the amputation risk. So summary, safety is not well established. All the complications are based on a long-term follow-up on a long-term patient. But so whether we should use it in the ICU, we are not yet sure. We should have further more details to decide regarding the use of SGLT2 inhibitor. That's it. Thank you.
Thank you, Dr. Jitesh and Dr. Arnav. I hope the mic is working. It was indeed a very interesting presentation, and thank you for updating us regarding the knowledge of use of SGLT2 inhibitors in patients with sepsis. And please come up. because you're the star kalakars. So my input personally is you both have actually presented two ends of spectrum. One has actually, Dr. Arnav has presented, you are absolutely right, that the initial stages and in the preventive strategies, it is still, this drug is relatively new as compared to the other OHAs. So this is like in the preventive strategies, as I was saying, like heart failure progression or acute or chronic renal failures, early sepsis, where the patient has not started with septic shock, or the patient is taking orally, not on parenteral or enteral nutrition, those kind of things, and there is no low risk of euglycemic diabetic ketoacidosis. So those things are still under study. But definitely, but the studies you have presented are basically the other end of spectrum. So basically refractory shock, the patient is not taking orally, where there will be difficult, there will be other, like you have rightly pointed, that you cannot blanket cover your population. So very sweetly you said the word population is very important. So you select the population correctly and you decide whether which population as to SGLT2 inhibitors you can give safely, and which population you can defer and currently not give till the patient improves. Because so this drug is under study, and yeah, thank you. So this is what we've understood.
Just wanted a just a small comment is that obviously what you said is absolutely correct. This drug is not a blanket sanction for using it in critical care setting.
Right,
so my last slide was that the bottom line was that it has to be customized, it has to be tailor-made, and we have to decide what are the subset of populations where we can actually use SGLT2 inhibitors, and then in future reap the benefits of the so much of pleiotropic effects which this drug has. Obviously not for all ICU care patients. Thank you.
Basically what we are doing right now is we are desperate enough to treat sepsis. So we are trying to look for something.
No, I don't think we are desperate enough to treat sepsis. Sepsis has to be treated. There is no desperate or not being desperate. Because if you don't treat sepsis, it is sure shot mortality for the patient. Thank you.
Can I just make a point? Yes. I'm just speaking here in the capacity of a cardiac surgeon. I've published 2 chapters in textbook of cardiology. One is about SGLT2 role in prevention of major cardiovascular events. And recently, this month only, my another chapter is published, role of SGLT2 in heart failure. So that drug is being promoted as a wonder drug. And yes, it is relatively new as compared to the other drugs. But Dr. Jeet, what you have talked about, Fournier's gangrene, amputation in critical care, all those things, they come when the patient is on heavy inotropes. Normally, now the critical care is advanced all over India. In all good hospitals, there is a critical care setup. So at the first instance where you are seeing that the limb is getting dusky, the team will come into action and take control. Similarly, the genital infections, patient education is very important. And that holds true not just for SGLT2, it holds true for everything. Any patient, for example, we are operating valve patients, if the patient is not maintaining dental hygiene, will still lead to infective endocarditis. So I agree with Dr. Arnav that if you counsel your patient well enough, choose the patients well enough, and balance all other aspects, then there is no better option than SGLT2. Why? Because insulin, the patient has so much of fear of that needle, and somehow even the family starts giving up thinking that patient is on injections. Whereas when the patient takes oral, psychologically that's an impact that your tablet is taking care, oral hypoglycemic agent. So what you are talking about, Fournier's gangrene and amputation, this is a patient which is very critical, heavy inotropic support, maybe ventilator, and all those ICU settings.
Yeah.
Whereas the discussion, the debate basically is about the role of that in sepsis. So sepsis is not just something which is happening in ICU. Sepsis is when you control the patient in ward and this HDU facility also. Patient is not so on inotropes, and this, if you are the patient is ambulatory or patient is required hospital care but not so critical that on heavy vasopressin and supports, then SGLT2 has shown good results in various studies, and it is continually showing improvement. They are trying to now study the effects not just on control of sugar, but also prevention of major cardiovascular events, prevention of heart failure, and it has shown in both sexes. It is showing male and female. It is showing very promising results. So that is why it is being now everywhere taken as a drug with a lot of hope in this management.
Thank you, ma'am. Thank you. Since we have got time constraints, I think more questions from the audience. We'll go to the next session. Right. Thank you.
Thank you so much. Thank you.
Thank you so much for such an enlightening session. Now I would like to request our chairperson, Dr. Nithi Kele ma'am, to felicitate Dr. Arnab Chaudhary sir. I would like to request Dr. Ajit Badoria sir to felicitate Dr. Jitesh sir. I would like to request Professor Ravikant sir to felicitate our chairperson, Dr. Nithi Kele ma'am. I would like to request Dr. Mukesh Verva sir to felicitate Dr. Ajit Singh Badoria sir. I would like to request Dr. V.S. Pai sir to felicitate Dr. Anirudh Mukherjee sir. Thank you so much, sir. As we all know, the healthcare sector faces unique challenges in balancing high quantity patient care with pressing need for sustainability. For our next session, we are honored to welcome Dr. Mukesh Bairwa, sir, Additional Professor, Department of General Medicine, AIIMS Rishikesh, to share insights on a critical topic, Step Towards the Green ICU. Please also welcome our chairpersons for this session, Dr. Jyoti Prakash, sir, Professor and Head, Department of Medicine, AIIMS Patna, and Dr. D. Imanshu Reddy, sir, Professor and Head, Department of Medicine, KGMU, Lucknow. I would like to request our chairperson to join on stage.
Yes, Dr. Mukesh Bairwa, you can start your session and try to finish within the stipulated time.
Okay,
so
sir.
Please.
Definitely. So, good morning to all. As you've seen on the screen, this is our beautiful earth. And what we are doing? We are destroying our nature. How we are destroying, we all know that how we are destroying. If I look in the audience or in the auditorium, that sometime before, one or two decades before, when there is any conference, there is a water in some glass bottles or in a glass, but it's replaced by the disposable bottles. Similarly, when I was a student in medical college, SMS Medical College, the normal saline bottles or DNS bottles, they come in glass bottles and they use and they refilled. But nowadays, what happened? They are all replaced by the plastics. So how the plastics or other materials affect our natures and what are the healthcare setups that is important to destroy our nature? What are the role of the healthcare sector and how we prevent that? That I will discuss in brief within 10 minutes. So do you know, we all treat patients according to either the treatment as a patient-centric, we choose the patient, what type of patient and what treatment usually we give that on the patient's priority. Then we treat patient as a disease-centric. After that disease-centric, we also treat patients as a cost-effective analysis. But we never thought about our environmental. So we have to treat the patient according to the environmental centric. So we have to prevent to damage the things that we do to damage our earth. So what is the importance of green issue? You know, the hospital are the largest contributor of greenhouse gases emission, especially in the ICUs. One patient in a ICU daily developed 17 kilogram of disposable product. 17 kg per day, one patient of ICU patients. So this require to reduce what measures we use in the future and how we reduce that the emission of the greenhouse gases in the ICUs. So this is the study, that's carbon footprint of the treating patient with septic and septic shock in an intensive care unit. That in the US ICU, one patient is having 3.5 units of carbon footprint, and in Australian 1.5. This is very big numbers in sense of carbon footprint producing by one patient. So how we affect, suppose we use one syringe or one seizure, so how it affect the environment? So if you look in this diagram, that when we make any syringe, so you have to dig out our resources, raw material. So that directly affect the environment. Then we have to manufacture that things. That produce a lot of gases that also affect our earth. Then we have to transport these things to our hospitals. Suppose one thing, transport from USA. It took so many routes and so many fuels to transport to India. So one thing we produce in-house, that is very useful, because transportation can be prevented, or that effect of the transportation can be avoided. Then we can use, and we have to dispose. That also lead to the damage in our earth. So how ICU patients, the consumption of the water affect our environment. If you see in this diagram, we usually use the water as an infusion bags, or the antibiotics we mix with the water. That water goes to the direct into our sewage system. Sometimes not only the super specialist hospital or tertiary care hospital, periphery hospital or private hospital, they never use this disposable, the water to proper disposable system. They don't have any proper disposable system. So antibiotics, many other things, they mix with the water and they goes to the directly, to that produce MDR organism. So this can be prevented in the simple things that we can be prevented. So how we reduce these things? So you have to identify a multidisciplinary green champions. That should be volunteer. Then you make daily ICU procedure, records them, and we have to increase them, we have to educate them, then we have to reward them. So they use the things wisely. When we to minimize using of disposable things. Other, you have to stabilize the partnership with other hospital staffs, administration. Then you have to create a green ICU team, improve their educations, review the drug chart. That is necessary. When you go to the round, you have to revise your chart that this drug is going. Suppose we are giving pantoprazole. Universally, we prescribe pantoprazole to all the patients. It is necessary to give a pantoprazole, or be giving in ICU, we usually prescribe IV paracetamol in every patient, where patient gets fever of 99 degrees centigrade. Can be necessary? It is necessary to prescribe IV drugs. We can simply give a oral paracetamol. That can also affect you the same manner. So goal of the green ICU team should be the primary to train the professional and critical care patients who develop the strategy to reduce environmental impact on the ICU. Secondary goal on the 4 P's to cure. You have to use the product, what process, you have to reduce the minimize the process. we have to educate the people or their visit in the hospitals. We can minimize them. We have save our planet. So how we can do 4 P's of ICU is, one is the product. So we use lesser, the fewer product, better product, and better use of product. Next is the you have to care of our planet by reduce, reuse, or recycle the products. Then we can define other P is the process. So what are the process we are using? We can minimize the multiple single use, or we can use recycle these things. And fourth thing is the person, that healthcare person. You have to train them how to use things and how to use less the disposable things, lesser disposable gloves. You have to use less these things. So one is the product. So use fewer product, less use of raw material, reduce use of single-use equipment, especially the aprons or anything, disposable gloves. We usually use them. Reduce the need of transport. So use local product. So our Prime Minister always says the local product, use of local product always promote. Lower the MDR rate. So if MDR rate is less, the isolation is less, so the use of disposable product is less. Then you have to stabilize our process. So digitally all the records. Then choose wisely individually of need of consumers diagnostic test. So some streamline our process, early detection of multi-drug resistance, better healthcare, right diagnosis, right drugs, and right procedure. Then you have to initiate the education that healthcare workers should reduce the minimum use of things that affect the environments. Promote the public health to reduce the need of healthcare use of pharmaceutical, optimize pre-operative and post-operative care, family and patient care, and education system. In the planet, there is a 10 R's. We have to reject the things that is dangerous for our planet. We have to rethink all the treatment. We have reduced the use of disposable items. We have to repair all the things that is broken down or that are dysfunctional instead of buying new things. Then we have to remanufacture, reuse, or recycle or recover. So this is the systemic meta-analysis that what level we can prevent the things. We can prevent in the step in the hospital level. Then we can we can prevent the things as our hospital administration, or then in our wards. Then we can prevent these things to the disposable levels. So this is the example of a single seizure. So if we have used the 300 disposables and seizures, then we have to use 300 type of raw material, 300 times of transport, and 300 times of disposal. If we reuse the same thing, we have to use 1 time of raw material and 1 time of disposable. So what are the evidence that we can is effective? So these are some examples of studies that can reduce the significant amount of the disposable items. Another is the studies which shows that if we use the recycle the things, we can save the lot of money of the patients for that treatment affordability. This is the simple example of IV paracetamol and oral paracetamol. If you can see that there is a lot of difference between the carbon footprint produced by the one patients in the medical field. Only the switch of IV paracetamol to oral paracetamol. So we have to reduce the things, then we have to reuse, then we have to rethink the treatment. Sometimes we use monitoring lines, unnecessary monitoring systems. When I go to the ICU round, I think I saw that patients having catheterized since last 15 days. Or some new patients, conscious patient came to the ICU and patients having catheterization. Then I asked our resident, why you put the catheterization? They said, sir, intake output measurement. So is necessary to measure intake output in a patient who is conscious. You can use different methods to measure the intake output. Simply diaper weight can use as intake output measurement. Then you have to research the things that can help the patient to treat as a fast or the affect our environmental to lesser impact. So my take home message is people have created the problem, so people must commit that themselves solve it. Healthcare professional, in addition to caring our patients, can care our planet, our day-to-day work by developing zero carbon issues. We must plan, execute better process to bring real challenge quality of life present in future generation, and is not an option, not a complicit. Thank you.
Thank you, Mukesh, for your nice presentation covering all the aspects of green ICU. I wish that this ICU be established at AIIMS Rishikesh.
Yes,
by your concept. One question comes in my mind: how to deal with the use the natural light and ventilation while constructing a green ICU? Because ICU में तो आप AC चल रहा है और ये सब लाइट लगी हुई है, तो अगर ग्रीन ICU बनाते हैं तो ये इसका कैसे करेंगे उपाय हम? Ventilation and the lighting.
I think the best thing is the use the nature. Our nature is very beautiful. If you prevent the damage of nature, so you can use direct natural lights for the ICU patients. You can use direct ventilations from the environment. You can put exhaust fan, so they circulate more and more air instead of the circulation the same air in the.
No. Mukesh, will it not increase the risk of infections? Many fungal spores are in the air. So if you allow the air to come from outside, or your critically ill patients on ventilator,
yes,
or on some circuit, I think that should also be taken care of.
Yes, sir.
So it is not so simple.
So we also nowadays we having HEPA filters that filters the air. We can use them also. We have air curtain in our ICUs that prevent inner and outer air mixing during the opening or closing the gates.
Yes.
So these are the small things we can do.
Thank you, Mukesh, for two things. One, actually bringing to a light that green ICUs are something which are important. I think people are forgetting about this, that when we do nowadays, we have got NAC and ABH and all. There you have a separate one part where each hospital has to show what is your carbon footprint, which including even the conference flights, the number that you have taken, because that also comes into account into the cover to the ICUs. The second part I want to thank you is you really actually showed the way by actually finishing well within time, and that is also very important.
Thank you, sir.
So I'll just answer even Dr. Jyoti's question. I think there are ICUs which are made with light. One of the ICUs that I have seen recently in the model ICUs which we were trying to prepare for ourselves, you have what is known as double glass pane ICUs where the air conditioning doesn't get affected, but you have the sunlight coming in. They are not only created for green ICU, they are also created to maintain the day and night the circadian rhythm of the patients. So if you have that, what happens, sunlight comes in directly, the natural light, actually you also know that in ICU, one of the major cause of ICU psychosis is the lack of sunlight.
Yes.
So having sunlight, having natural air inflows, which they do create now, with negative and positive, you have the positive in the inner side and the negative on the negatives on the inner side and the positive on the outer side, with, as you said, the HEPA filters are on the outer side, so the air comes in from there and gets purified and goes in to avoid the micro. So there are concepts which have come in, and I think it's time that we look into it. And equally, one important point is most of the hospitals and most of the ICUs that we see, apart from the big hospitals, are still not connected to the STP and ETP plants, which actually leads to antibiotic resistance. I thank you for that. If any question, I will just one question from anybody.
No question.
Yeah. Thank you.
Thank you so much.
Thank you so much, sir, for such an insightful session. Now I would like to request our chairpersons to felicitate our speaker, Dr. Mukesh Berwa, sir. Thank you, sir. Now I would like to request Dr. Namrata Gaur ma'am to felicitate our chairperson, Dr. Jyoti Prakash, sir. I would like to request Dr. Pragati Kapoor ma'am to felicitate Dr. D. Himanshu Reddy, sir.
As we delve deeper into the complexities of critical care, it is my pleasure to introduce our next speaker, Dr. Bala Murugesan Sir, Additional Professor, Department of Medicine, JIPMER Pondicherry, who will shed light on a vital aspect of patient management in sepsis in his talk titled Myocardial Dysfunction in Sepsis, an Update in Assessment and Management. We welcome you, sir. Please also welcome the chairpersons for the session on stage, Dr. Monica Pathania ma'am, Additional Professor, Department of Geriatric Medicine, AIIMS Rishikesh, and Dr. Namrata Gaur ma'am, Additional Professor, Department of CTVS, AIIMS Rishikesh.
Morning. Actually, today I thank Ravikant sir for giving me the opportunity to come all the way from Puducherry to the AIIMS case. And next 20 minutes I will be dealing with sepsis-induced myocardial dysfunction. We all reading about sepsis. Sepsis is one of the leading cause of mortality. Already in the morning we had a debate whether to use SGLT inhibitor or not. And myocardial dysfunction and sepsis is gaining momentum, and it is a new, relatively new, even though we are unable to understand various pathophysiological aspects in sepsis. However, the pathophysiology of sepsis-induced myocardial dysfunction is not fully understood. We all know that there is a capillary permeability, increasing capillary permeability, increasing microcellular dysfunction, mitochondrial dysfunction, and various pro-inflammatory cytokines and myocardial depressant factor, all those come into play. And still, we were not able to exactly point what is causing a myocardial dysfunction in sepsis, so that we are giving a various treatment aspects, early gold therapy. So, in another 10 minutes to 15 minutes, I will be dealing as far as possible, and we will cover these topics. Introduction, epidemiology, because we have to know what is the epidemiology, pathophysiology of sepsis-induced myocardial dysfunction, assessment and management of sepsis-induced myocardial dysfunction, conclusion and take-home message. We all know before, because we should know as a postgraduate student as well as treating physician, it is a life-threatening organ dysfunction caused by a dysregulated host response to infection. It is being given in the survival sepsis guidelines, campaign guidelines 2021, and we have a various screen tools to start a therapy, because sepsis is like a tickling time bomb. Each minute loss is going to kill the patient, and it is producing a significant mortality in a day-to-day practice as well in ICU care. We are having a Q-SOFA score which comprises 3 factors. There is a respiratory rate and Glasgow Coma Scale and blood pressure. If it is more than 2 is there, it will facilitate the patient need to be admitted and then early treatment to be started. And better than Q-SOFA score, we are using a national early warning score is being used nowadays to predict the outcome. Briefly about, because from the sepsis 2 to sepsis 3, I will tell there is one difference. There is severe sepsis terminology is being removed, and we are only dealing with the sepsis and septic shock, where there is vasopressor is required to maintain the mean arterial pressure of 65 millimeter of mercury, despite adequate fluid resuscitation with more than a serum lactate value of 2 millimole per liter. So that is the main difference between subsys 2 and subsys 3, which has come in 2016, and the updated guidelines have come in 2021. And briefly about epidemiology, in 2017, each year annually roughly about 47 to 50 million cases per year the sepsis patients admitted all over the world, and 11 million deaths occur, and sepsis is the #1 cause of death in the hospitals, and it causes significant cost to the patient as well as to the relative morbidity and mortality. That is the more important thing. And WHO promptly declared sepsis as the global health priority, basically because of increasing in incidence is attributed to, because nowadays the age of the median survival rate is increased, the patient survive for longer duration, increased number of invasive procedures we are handling, and the wide usage of immunosuppressive medications for various immunological diseases and chemotherapeutic agents, and irrational use of antibiotics. All those things lead to there is increased incidence of sepsis. So now we will go into the sepsis-induced cardiomyopathy or sepsis-induced myocardial dysfunction. We can tell in both ways. It's a form of transient cardiac dysfunction. It is not a permanent. Usually when the sepsis is being treated, usually within a 7 to 10 days, patient will completely recover. The myocardial dysfunction will be reversed. So there is no formal definition and criteria till now. A diagnostic criteria is proposed because we always follow that, like, that cardiac failure, Framingham heart study, Framingham criteria, all those things we are following. But there is no clear-cut definitive diagnostic criteria for sepsis-induced cardiac dysfunction. And it is being recognized as the major contributor for hemodynamic instability. It has been associated with the worst clinical outcome. And inotropic therapy can be used in patients with persistent hypoperfusion or adequate fluid hydration. That is the more important thing. And the inotropic of choice usually, apart from norepinephrine and vasopressin, dobutamine and epinephrine are the most commonly, when you recognize sepsis-induced cardiac dysfunction, those inotropic agents, even though dobutamine has got significant risk of arrhythmia, we have to use that agent. And in this slide, what is happening? You can see that the normal heart, there is a balance between the cardiac output and circulation. When there is a sepsis develops, that is basically because of increasing in the vascular permeability, and there is a reduction in the preload. In the initial stage of sepsis, the ejection fraction will not be lowered, that will be maintained. That is basically because of the increase in heart rate, there is sympathetic overactivity. However, the increasing in heart rate is not sufficient enough to maintain the cardiac output. So despite EF is more than 50%, that cardiac output will reduce. But when you are loading the patient with the fluid, the patient will be having a slight improvement. That shows that there is a slight adaptability. EF may reduce in this condition because of reduction in the LV end diastolic volume. In the later stage, the non-survivors would have been given more fluid rather than survivors, and that will lead to that EF will be maintained and stroke volume will be reduced till because of the increased hyperpermeability. That is the pathophysiology which is persistent. So even in the late phases, the stroke volume will be reduced, and heart rate, because of use of the various inotropic agents, various sympathetic activity, and it will be a adrenergic drive will be there, which will not sufficient to maintain the cardiac output. So, and again in that another method, what is happening in severe sepsis, there is the arterial and venous dilatation, and myocardial systolic dysfunction is occurring that causes decrease in the RV stroke volume, subsequently LV stroke volume. So there is reduction in the cardiac output. Subsequently, the patient goes into septic shock. That is the reason aggressive fluid loading 30 ml per kg in the initial time. That is a very important thing before starting a inotropic agent in the septic patient. In this slide, that nutshell it tells what are all the factors which happens. Basically, microcirculatory dysfunction is the most important thing which happens in sepsis-induced cardiomyopathy. Endothelial dysfunction, I am going to tell what is a role of glycocalyx and all those things, glycocalyx dysfunction, otherwise known as glycocalyx dysfunction, and ventricular arterial uncoupling that is happening. Then direct myocardial suppression by downregulation of the beta receptor, myocardial depression, various myocardial depressant factor is there, and apoptosis. Apart from that, I already told mitochondrial dysfunction. Because of that mitochondrial dysfunction, there is a impaired microcirculation happening. So what are all the factors in the pathophysiology? We know that what are the myocardial depressant factors, because this will help, and they are trying various agents based on that. Tumor necrosis factor alpha, interleukins 1 beta 1 6, and complement 5A, lysozymes, all those things are contributing for development of myocardial dysfunction. And lipopolysaccharide, I will tell about that pathogen-associated molecular pattern that will act like LPS, and bacterial components, various endotoxin. There is an increased production of the nitric oxide which causes increased vascular permeability, hyperpermeability, and impaired intracellular calcium metabolism, that thereby that levosimendan comes to play. They tried levosimendan on the treatment, and hypoxemia and acidosis, hyperlactitemia, and microcirculatory and mitochondrial dysfunction. All those things contribute for the development of myocardial dysfunction in sepsis patients. So again, in another way, that is basically because of inflammatory, there is imbalance between the inflammatory process and neuroendocrine metabolic process. There is a inflammatory cytokines, I already told, IL-1, tumor necrosis factor, and increased production of nitric oxide, oxidative stress, production of the reactive oxygen species. There is activation of the coagulation cascade, so that DIC and MODs develop, multi-organ dysfunction syndrome. Endothelial dysfunction is the front runner in the patient with my dysfunction. There is a increased capillary permeability and vasodilatation, along with coupled with there is accumulation of free fatty acid, and there is decreased arterial pressure and decrease subsequently to decreased cardiac output, and myocardial function is depressed. And this is more important. So there is a pathogen-associated molecular pattern and damaged molecular pattern, because we have to reduce these two things. Pathogen molecular pattern will be reduced because there is a microbes invade, then pathogen molecular pattern which acts like a lipopolysaccharide. This activate myocyte apoptosis, thereby causing a ventricular dilatation. These also directly act in the peripheral vasculature, causing this affecting the heart function by varying systemic vascular resistance and venous return. And it acts via pattern recognition receptor, that is a toll-like receptor, down regulation of the beta-adrenergic receptor. That is one of the important thing, and important to control the load of the pathogen-associated molecular pattern by early and prompt antibiotic therapy in a medical patient, and source reduction in surgical patients, so that catastrophic sequelae in the sepsis-induced myocardial dysfunction can be prevented. Another one important factor is high mobility group box 1, that is the circulating histone, HMGB1, is the damage-associated molecular pattern which acts over again toll-like receptor 4-methoxydative stress, causes mitochondrial dysfunction. So we have to arrest both pathogen-associated molecular pattern as well as damage by giving antibiotic therapy, fluid therapy, so that we can reduce the mitochondrial dysfunction, microcellular dysfunction, and production of the reactive oxygen species, and excess production of nitric oxide, endothelial dysfunction. All those can be this thing. So this slide tells about the same thing: warm shock, cold shock, and what is the pathogen-associated molecular pattern, pattern recognition receptor, and there is a multiple myocardial depressant factors, myocardial depressant factor at causing cardiomyocyte injury, and damage to the myocardial protein, that is I told that HMG1, all those things causes ultimately the myocardial dysfunction. And there is a gross coronary perfusion is increased in patient with established septic shock. There are many myocardial depressant factors are there, and endothelial glycocalyx, this is a newly recognized one. There are various trials are being conducted on glycocalyx shedding that causing endothelial dysfunction, and subsequently which causes myocardial edema, and that can cause rise in troponin and not necrosis. This is about the glycocalyx. We know that that is the fundamental component of the endothelium. There is an endothelial membrane which is basically made up of proteoglycan and glycoprotein, and which acts like a mechanical barrier. And because of the shedding, there is increased vascular permeability, activation of the leukocytes and platelet adhesion, and which modulates the inflammatory and anti-inflammatory response. Damage to the glycocalyx morphofunctional integrity is known as glycocalyx shedding. There is enhanced glycocalyx shedding in a patient with sepsis, so we have to arrest the pathophysiology. There are various agents, later I will tell in the treatment when we are dealing with the therapeutic strategy, when tried, and trials are going on, like heparinase, heparin, then sulfodoxide, all those agents are being tried to prevent the glycocalyx shedding. Then oxidizing agents, cytokines, all the same mechanism causing edema, increase interstitial pressure, worsening of tissue perfusion, all those things takes place. You can see there is a enlarged portion of the glycocalyx where there is because of this intercell adhesion molecule, vascular cell adhesion molecule, there is a damage to the glycocalyx. The glycoshedding takes place and causes increased fluid, capillary permeability, and fluid loss is happening. So then we come to the diagnostic criteria. There is a proposed diagnostic criteria for sepsis-induced cardiomyopathy. Usually it is acute condition which is reversible within 7 to 10 days. And there is a global biventricular dysfunction, systolic and or diastolic with reduced contractility. Left ventricular dilatation is there. Will be there. Diminished response to fluid resuscitation and catecholamines. Absence of acute coronary syndrome as the etiology. These are all the proposed diagnostic criteria, but we need a very detailed trial to establish this diagnostic criteria. And because of difficult as there is no established criteria, this is being considered in a patient with history of prior heart failure, septic cool extremities phenotype, hemodynamic instability despite resuscitation with fluids, abnormal ECG or abnormal rhythm is present, low mixed venous oxygen saturation, patients who are having an elevated cardiac troponin. When these finding is there, we can use these things. And then what is the most important diagnostic criteria in a patient with septic cardiomyopathy? We have to echo. There is the one special modality is there, speckle echocardiography. That is the one method which will find out there is a longitudinal strain in the LV. So we can find out left ventricular ejection fraction, stroke volume cardiac output, RV dysfunction by tissue Doppler images, and diastolic dysfunction by the spectral Doppler. That is basically will be giving a longitudinal strain. And it is a quantitatively measuring the strain and the LV. So echocardiography is the one important method to find out that sepsis myocardial dysfunction. Basically, it is helping to rule out the condition which will mimic sepsis-induced cardiomyopathy, like Takotsubo stress cardiomyopathy, pericardial effusion. We can rule out pericardial effusion, dissection of aorta, acute coronary syndrome, early dynamic intraventricular obstruction syndrome. All those things can be ruled out by this thing. So the newer modality is speckle echocardiography. And as always, nowadays we are living in an era of biomarker. We have so many biomarkers which are available in the cardiology, in the diagnosis and prognostication of heart failure. Similar, those cardiac biomarkers also is being used. But however, this sepsis-induced cardiomyopathy, this biomarker is not elevated due to cardiac myocyte necrosis. This is because of that cardiac dysfunction because of sepsis. BNP, cardiac troponin T, heart-type fatty acid binding protein, myeloperoxidase, pernicious-related plasma protein, and procalcitonin, all those things are being used. And when you see a troponin values are minimally only elevated, NT-BNP values are markedly elevated as in cardiac failure, but there should be no structural heart disease prior. That is the most important thing. And however, the conclusion, whatever the review articles, whatever I read, the no biomarker is specific for sepsis-induced myocardial dysfunction. And some of the newer biomarker, what we are dealing, that heart-type fatty acid binding protein, which is cytoplasmic protein found in the cardiac myocytes, released into circulation after ischemic episode, and which is also a biomarker in acute coronary syndrome and cardiac dysfunction and mortality in sepsis-induced myocardial patient. Similarly, myeloperoxidase is a heme-containing peroxidase by activated neutrophils. And there is another one marker, that is a serum triggering receptor expressed on myelocyte, STRM1 on immunoglobulin, basically which are upregulated in the exposure to bacteria or fungi. So there is a one trial conducted in China about 147 patients, septic patients, where only the fatty acid binding protein and cardiac troponin and myeloperoxidase, which has got high predictive value. Other investigations which are very time consuming, which is not readily available, like pulmonary artery catheterization, generally not recommended. Then we go to the treatment aspect. Generally, the treatment is underlying sepsis has to be treated effectively. Fluid treatment based on IVC, collapsibility, output and central pressure guided. Usually intravenous fluid is to be given at the rate of 20 to 30 ml per kg. Norepinephrine is the main inotrope of the choice. Antibiotic debridement and early goal diet therapy with appropriate inotropes, fluid and antibiotic. That is a very important. And there is a trial comparing norepinephrine and dopamine. Norepinephrine is the preferred of choice of inotropic agent because it is does not increase the heart rate, whereas dopamine has got significant adrenergic drive and produces the arrhythmia. In the surviving sepsis guidelines, I will take 2 more minutes. Septic shock and cardiac dysfunction with persistent hypoperfusion, that dobutamine is to be ordered because it increases the cardiac output, reduces the hyperlactemia, and intramucosal acidosis is improved. And we all use nowadays, after norepinephrine, vasopressin is the thing. There is a Vanish trial which compared the use of vasopressin versus norepinephrine. But however, there was no significant difference between the vasopressin and norepinephrine group in 28-day mortality with a relative risk of 1.13 with a confidence interval of 0.85 to 1.1. Recommendation for adults with septic shock, the ultimately, norepinephrine is the first line of agent. Subsequently, vasopressin can be used. If there is sepsis-induced cardiomyopathy is there, we can go for dobutamine. So, a few words about levosimendan, which is the calcium. Since we know that calcium levels are reduced, so that is being tried, both inotropic and vasopressor properties. In a leopard trial, where there is a 515 patients, showed that levosimendan versus no inotropic agents associated with lower likelihood of successful weaning from the ventilator support the patient. No mortality benefit was demonstrated, so this drug is not being used very commonly in this thing. And now we are living in the support devices, extracorporeal membrane oxygenation, intra-aortic balloon pump. These devices are mainly used in the cardiogenic shock due to cardiac conditions. However, these devices are also being used bridge to recovery, like that veno-arterial ECMO and intra-aortic balloon pump, which can increase the diastolic augmentation, increase the coronary perfusion. It is being placed distal to left subclavian artery, But there are so many other problems are there in this, so it is not routinely used in sepsis-induced, but other cardiac conditions. But there are some centers we are using this thing also, because there is a down regulation of the beta receptor. Beta blocker also tried in septic induced cardiomyopathy, which can prevent ischemia. You know that because there is sympathetic activity, there is increase in heart rate. So by giving a beta blocker, ultrashort acting beta blocker, which decreases the TNF alpha production, adrenergic overactivity is being reduced, like landiolol and esmolol is being trialed in various trials with significant survival benefit. In nutshell, sepsis-induced cardiomyopathy, we have to give a fluid resuscitation and vasopressor, particularly norepinephrine, followed by vasopressin, subsequently dobutamine. And we can try this beta blocker and levosimendan, but not much of trials are there, so we need further trials are needed. Intra-aortic balloon pump and ECMO can be used. So conclusion. So what is the thing which we take as a postgraduate student or a treating physician, which is a reversible dysfunction, and which is used to usually because of bacterial endotoxin, increased inflammatory markers, increased oxygen species, and mitochondrial dysfunction. There is a dilatation of the LV cavity, reduction in the LV function, and the function returned to baseline within 10 days. And specular echocardiography for the measurement of the global longitudinal strain is the new modality of echocardiography which we have to use. The biomarkers have come, but no biomarker is specific. And the pathophysiology is not fully yet understood. No specific drug therapy is available for cardiomyopathy. Prompt appropriate antibiotic therapy and source reduction in surgical cases, early aggressive fluid therapy and vasopressor inotropic support as per the guidelines is mandatory. Further multidisciplinary research might unravel newer insight into the understanding and management of sepsis-induced cardiomyopathy. Thank you. These are all my references.
Thank you, Dr. Balmurugesh, for that insightful presentation. So, since we are running out of time, we'll open up for the questions in the floor. Any questions?
Yes, ma'am. Yes. Other means pre-existent heart disease. No, myocardial dysfunction usually occurs, but for example, cardiac dysfunction in a patient with acute coronary syndrome or cardiac dysfunction because of previous the history. No, there is a spectral echocardiography is the newer modality is there. So we can do that thing which can find out quantitatively measure the longitudinal strain of LV strain and even RV strain which can be done, which is being done nowadays. Yeah, sepsis-induced myocardial dysfunction. Yes, ma'am.
Almost all these patients would be on some sort of inotropic support. And with echo, we always want to have a lower heart rate. Probably that is the reason that beta blockers are being given prior to doing a speckle. But if these patients are on ventilator or cannot be positioned, it is really difficult doing a speckle echo.
No, those are all the practical difficulties when we are dealing. Ideally, that beta blocker also only few trials are only there. Yes, so there are not much of trials because why the beta blockers are being given that there is a down regulation of beta receptors, and because we are loading with the inotropic agents which acts over the alpha and beta receptors, as that is the reason they are given that also only ultrashort acting beta blockers like esmolol, which has got a very soft like 6 to 9 minutes. That is the reason those drugs are being tried. but still lot of, because that myocardial dysfunction which should completely reverse to the normal, then only we can tell them it is because of substance-induced myocardial infarction. Previous heart failure is there, that won't recover. Actually, we know from the patient data and all those things.
So one more question to this. You show the study from China where we are using pro-BNP and a combination of
other biomarkers.
Other biomarkers, especially troponin I. So a combination of these two, did they anywhere specify as to, when is their cutoff, as to when they'll say that this is definitely not due to underlying disease and this is due to...
No, actually the biomarker, that whatever the kit we are getting, whatever I am also doing a lot of biomarker in cardiac failure, there is a lot of problem with the biomarkers, and we cannot categorically tell that, because biomarkers, that kit what we are using, that is the more important thing. Those kits should be more sensitive and more specific, and the cutoff value to be determined in the specific group of population, then only we can exactly tell. The trial only done in 147 patients, because doing all those biomarkers like hot type fatty acid binding protein, cardiac troponin, and all those things is very costly affair and is not practically also feasible. That's the thing. Thank you.
Thank you, Dr. Murugan.
Thank you, madam.
Very
Thank you.
Good presentation.
Thank you so much, sir, for such an enlightening presentation. Now I would like to request our chairpersons to felicitate our speaker, Dr. Bala Murugesan, sir. I would like to request Professor Ravikant, sir, to felicitate Dr. Namrata Kaur, ma'am. I would like to request Dr. V.S. Pai, sir, to felicitate Dr. Monica Pathania, ma'am. Thank you so much. Next, we are pleased to welcome Dr. Jyoti Prakash, sir, Professor and Head, Departments of Medicine, AIIMS, Patna. Sir will be presenting on the topic Early Detection of Invasive Fungal Infection and its Management. This topic is of critical importance as timely recognition and intervention can greatly improve patient outcomes in those at risk for these serious infections. Please also welcome our chairpersons for this session, Dr. Yogendra Mathuria, sir, Professor and Head, Department of Microbiology, AIIMS Rishikesh, and Dr. Prakash Sharma, sir, Additional Professor, Department of Pulmonary Medicine and Critical Care, AIIMS Rishikesh.
So I guess this is one of the most important, most being presently researched topic that we are going to listen from Jyoti Prakash sir regarding the invasive fungal disease, because what we believe is it's easier to detect and to investigate a bacterial and a viral infection, but fungus definitely, they are well too hidden. Let's hear from Jyoti Prakash sir how we can deal with invasive fungal diseases in our usual practice. Sir, over to you.
Respected chairpersons and the organizing secretary, organizing chairman, the topic given to me is fungal infection. So I will be talking in next 10 to 12 minutes the ways to early detect the invasive fungal infections and subsequent management. Moving on to the slides. So what is invasive fungal infections? These are the infections which are life-threatening, severe, and caused, which will invade the immune system, internal organs and tissues of the body by invading the bloodstream or organs, and disruption of the tissue function and architecture. Diabetes has a high propensity of acquiring these invasive fungal infections due to hyperglycemic state, which is a good substrate for the fungus. So that things is very pertinent in case of chronic diabetics. There are different types of IFIs, invasive fungal infections. The most common are enlisted here: candidiasis, aspergillosis, mucormycosis, cryptococcosis, histoplasmosis, and blastomycosis. Invading the different organs, they are organ specific also, and sometimes bloodstream infection comes, then it is invasive. So broadly, IFI can be classified into three groups: probable IFI, proven IFI, probable IFI, and possible IFI. So proven IFI means there is microbiological and histopathological evidence, and probable IFI means there is clinical diagnosis, there is radiological evidence, but with supporting laboratory features. And possible is only clinical suspicion is there, and we are lacking the lab diagnosis. So what are the common organisms which cause invasive fungal infections? The most common organisms are yeast. Among yeast, most common is Candida, Cryptococcus neoformans, and others, Trichosporon and these. Molds, various molds, the common molds are Aspergillus, Mucorales, Fusarium, and others are least important. They are rare, but they do occur. These are the multi-drug resistant emerging pathogens, real concern for human beings. They are Candida auris, Aspergillus cladiosus, Fusarium oxysporum, and Pseudosporium prolificans. They are multi-drug resistant IFI, fungal infections, that needs critical appraisal in this context. Certain dimorphic fungi also create problems, such as Histoplasma, blastomyces, and coccidioidomycosis. So what are the risk factors which make a person prone to develop this IFI? They are immunocompromised status is number one. Next is neutropenia, less than 500 neutrophils per microliter. Broad spectrum antibiotic use, central venous catheters in ICUs, burn trauma, diabetes mellitus, and of course prolonged corticosteroid use, more than 21 days or more than 1 month. They are all risk factors for this IFIs.
Sir, can I hold you for a second? I request the audience to kindly maintain silence while the speaker is giving the lecture. Thank you.
Yes. So certain organisms have certain risk factors. Like Candida is prone to develop in neutropenic patients, patients having CVP catheters, having on broad spectrum antibiotics for more than 14 days. Aspergillus is prone to cause lung disease in immunocompromised status. Mucorales in diabetics, ketoacidosis patients, also in iron overload patients, and Cryptococcus, we all know, Cryptococcus neoformans in HIV/AIDS patient, and other immunocompromised state patient. How do this invasive fungal infection present? The presentation is quite non-specific, like fever, respiratory distress, cough, chest pain, hemoptysis, neurological symptom like headache, confusion. They are all non-specific. That's why we are sometimes not able to diagnose. So a high degree of suspicion is warranted. And sometimes their presentation with shock, fever with shock, sepsis. Think of some candidemia or some blood stream infection of these fungal infections. How to diagnose? The certain criteria are there, the broadly clinical criteria based on symptom and sign, microbiological criteria based on culture, PCR and other serological tests, imaging based tests, CT, MRI, chest X-ray, and host factors also, they also guide what could be the possible etiology. So how to detect early? Because early detection has role in combating the problem at time. Blood culture, gold standard still, although it has low sensitivity, only 50%, but easy to perform and easy to and widely available. Most effective method for diagnosis of candidemia. But the era has changed, the era of biomarkers like beta D glucan, galactomannan, molecular tests such as PCR and serological tests and imaging studies also. This test, biomarkers galactomannan assay, has been approved for use in serum and ball, but can be taken from any source, and it is especially useful for aspergillus infection. Beta D glucan and other tests useful for aspergillus and histoplasma, and they are quite sensitive tests, so but costly, so not done everywhere, but in India it is getting done now. Certain advances in molecular based diagnostic methods will learn the PCR and various various advancement of PCR. They are preferred choice for the antifungal drug resistance as well as detection of cryptic and non-cryptic species. T2 candida is quite sensitive, of course 91.9% sensitive and 99.4% specific. This is nothing but molecular based technology coupled with MR imaging. So that why sensitivity and specificity has raised, and this can detect almost 5 species of candida within 3 to 5 hours without waiting for culture. So this will definitely help in early detection and subsequent management. Multiplex PCR allows simultaneous detection of multiple targets in a single reaction well. This saves cost, time, effort with no compromise of the test utility, can distinguish between closely related organism. Another advancement in this PCR technology is safety fast and MIC assay for aspergillus, and also aspergillus is a unique multiplex PCR, real-time PCR, which consists of 2 multiplex real-time simultaneously. This is digital droplet PCR, novel PCR technique having higher sensitivity and specificity and superior to qualitative PCR. So these things have come and these things are getting widely accepted all over the world. Combined PCR approaches, sepsis flow chip is there, which will exhibit high value of sensitivity, albeit 93% and 100% specificity regarding candida species. E-plex system, another automated platform for analysis of positive blood cultures using microfluids, PCR and electrochemical detection techniques all in one. Another is DNA meta barcoding, well-known method of species identification. Next is next generation sequencing, NGS. It is reliable alternative for seriously ill patients who can't endure invasive procedures like bronchoscopy. Successful use of this technique in infections of Pneumocystis jirovecii. There are some biosensor based fungal diagnostic tests such as electrochemical biosensors, optical biosensors, proximal ligation assay. So these are the techniques. Now how to prevent the fungal infections can be prevented by the simple measures which you miss. Simple hand hygiene for 30 seconds will prevent. Everybody know in Corona we are quite active for 30 seconds, but now again we are back to the usual story. Second is maintaining a safe, clean, hygienic hospital environment, screening and categorizing patient according to the risk. Risk patients should use HEPA filter. Public health surveillance and awareness, antibiotic stewardship. कितना दिन एंटीबायोटिक देना है कि ये फंगल डेवलप ना हो, that is most important. We doctors, we paramedical staffs and ICU staffs, they cause iatrogenic fungal infections by our act of omission, and follow the patient safety guidelines. Now, how to manage this invasive fungal infections? General principle is early initiation of the antifungal therapy. Usually combination therapy will inhibit resistance pattern, surgical debridement when as necessary, and supportive therapy in cases of shock, septic shock, and monitor for the adverse effect and drug interactions. The common agents recommended are triazoles. Voriconazole is now superior azole. Other are posaconazole is oral. Isavuconazole is the recent advancement in this azole group. Echinocandins is pan-spectrum antifungal, you can say. Caspofungin, micafungin, anidulafungin. Polyeins, amphotericin हम लोग कालाजार के लिए यूज करते थे. रियल में एक एंटी फंगल दवा है जिसको कालाजार के लिए भी यूज किया गया. Now liposomal preparation has come and other preparation has also come. New agents like fosmanogepix, they are in pipeline. A specific management strategy will be for different fungal infections. For candidemia, the initial therapy will be echinocandin or liposomal amphotericin B, and a step down to fluconazole or voriconazole. For invasive aspergillosis, start with voriconazole plus liposomal amphotericin B, and later on you can, if not responsive, you can combine this voriconazole with caspofungin also. Mucormycosis initial therapy is liposomal amphotericin B, that is drug of choice, but if response is poor, you can combine with posaconazole also. For cryptococcosis, initial will be amphotericin B with flucytosine, later maintenance on fluconazole 400 to 800 mg for 6 weeks, or rather 6 months sometimes. The guidelines for this fungal infection these are the IDSA guidelines, America guideline, but in our India it is IDSI, Infectious Disease Society of India, and ECIL and ESCMID. There are another Indian Society of Indian Society of Critical Care Medicine that also formulate guidelines regarding this. Those people who are in emergency medicine, they must be knowing this ISCCM. Emerging trends are personalized medicine. Tailor the antifungal therapy based on genetic markers of the individual. This is a new concept. Another is immunotherapy with interferon gamma or GCSF, and nanotechnology is another advancement in this management. So to summarize, and challenges, what are the challenges? So the antifungal resistance is greater challenge, biomarker development needs, and clinical trials needs to be ongoing. So to summarize the things I stated, early detection saves lives, recognize the risk factors, monitor for signs and symptoms, utilize the diagnostic utilities test, biomarkers, PCR, imaging, etc. Delayed diagnosis increases the mortality rate. Initiate empiric antibiotic therapy promptly, but as soon as you just come with the result, change the therapy. Choose agent based on pathogen susceptibility. Consider polyein plus echinocandin. Combination therapy enhances efficacy. Surgical debridement whenever necessary. Supportive care whenever necessary. Personalized medicine optimizes the treatment, and of course multidisciplinary approach is the need of hour. Monitor for the antifungal resistance. collaborate with infectious disease specialists, and keep your knowledge updated on this IFI diagnosis and management. Thank you very much for your kind attention.
Well, thank you, Professor Jyoti Prakash, for covering the topic in a nice way. And you have just covered all the techniques, detection techniques for the latest techniques for detecting the fungal infections and the latest treatments.
Thank you, sir, for covering up the entire topic in such a small span of time. What I believe is that fungal infections, be it in ICU or outside of ICU, is a topic of huge debate even right now. There's a lot of things going on, especially when you have to come to a diagnosis, because proving it as a proven is usually not feasible, because that would require a biopsy, and most of these patients are usually very critical. So how often do you feel, sir, that we can reach a diagnosis of a proven IFD, while it's slightly easier to go up to a probable one?
Of course, I told that allow 50% sensitivity is there for blood culture. So initially, when patient gets admitted in ICU, you send the blood culture, because that will take time, and of course it will be helpful. But the biomarkers which I stated, I think this is not available easily in everywhere, not in also in AIIMS Patna nahi hai. So the blood culture is still reliable, and certain measures, the regular fumigation of your ICU, that will definitely decrease the risk of these fungal infections by various circuits, ventilation circuits, and oxygen pipes, many more things. That will also decrease the.
Sure, sir. Thank you so much. I have a lot of questions regarding IFD, but in the view of constraint of time, I guess I'll move on to the
I just
audience.
wanted one question. Have you noticed a rise in aspergilloma cases post-COVID? Because in Rishikesh, OPD, we are seeing many patients who are, Dr. Prakhar may be best person to answer. Yeah,
Pan India, mucormycosis was there. In our AIIMS Patna,
that we treated a lot in AIIMS Rishikesh.
and followed by aspergillus. You are right.
Yes, no, but post 22, we are noticing a lot of patients of aspergilloma coming to us in CTVs for getting operated. Something has happened that post COVID, we are seeing a rise in number of aspergilloma cases. Mucormycosis, we had a separate ward in AIIMS Rishikesh during COVID, where we treated.
The answer will be because we have now been curious and know these things. So the tests are going on. जब जांच ही नहीं होती थी तो पता नहीं चलता था. So we are vigilant कि aspergillus हो सकता है. तो suspicion rate बढ़ा है. इसलिए हम लोग diagnose कर पाते हैं.
So and a simple microscopy of a suspected or probable case of mucormycosis, that will aid in prevent the patient from subsiding further. It takes time for the culture to come or galactomannan to come. So a simple, that is a critical call alert, you can say, mucormycosis.
Because
that we have used it especially during the COVID times, and we had more than 1,500 cases of positive, post-COVID.
Yes, it will definitely help.
So microscopy, I think, for mucormycosis, getting a pauciseptate hyphae, that is critical call.
Hyphae
septa can be seen to the microbiologist, and
mucors are usually diagnosed by the microscopy parts. Galactomannans are not actually very useful. It should not be used.
Not for mucor.
Even the beta-D-glucan is a pan-fungal, so it has a lot of, though it is sensitive to catch a fungus, but it's not sensitive to say this is mucor or not.
True.
Now the point of concern is, if you talk about aspergillosis, aspergillus again has different ways, invasive, non-invasive and all. So as ma'am was pointing out, and I think you are right in that part, that now we are seeing more because we are searching more for that.
True.
Technically for asper. But even for us, we had a huge center, the whole of UP was in KGMU. So now we also have a huge number of mucor. That's because now once people have started realizing, they're also referring them. Earlier, whatever was being diagnosed as TB is now actually, many of them are actually also being diagnosed as asper. They tend to have a lot of
Jyoti, actually regarding the false positive elevation of these biomarkers when we are using
Yes,
this
that
thing.
is also a concern. There is false
That actually
positive
needs to be there. And
that
then,
needs to be correlated with clinical and microbiological, clinical presentation.
and drug interaction with the thing. When you are treating particularly with the uriconazole and those group of drugs, when you are using other like anticoagulation and all, because potential toxicity interaction is there. Those also need
that
to be
needs
borne
to
in
be
mind.
cared of. Yes, yes, you're right.
Yeah.
Yes,
There are big drug monitoring
that
and
needs
all.
to be cared of. Okay, thank you.
True. So at the end of this session, what we can take as a home message is that the first thing, it's about how and when are you suspecting that an IFD or a fungal infection might be present. Then next comes your imaging, which plays a major role. You have to again suspect on presence of various signs on your radiology, mostly CT scan. And then you have to utilize your microbiology lab and colleagues to come to a final diagnosis of invasive fungal disease and then treat it aggressively. With this, I would like to close this session, and thank you so much, sir, for your valuable insights.
Thanks.
Thank you so much, sir, for such a wonderful session. Now, I would like to request Dr. Darab Singh, sir, to felicitate our chairperson, Dr. Yogendra Mathuria, sir. I would like to request Dr. Anirudh, sir, to felicitate our chairperson, Dr. Prakash Sharma, sir.
So the next lecture is based on a topic of significant importance in the management of critically ill patients, beta-lactam dosing, continuous versus intermittent. Today, we are privileged to have Dr. D. Himanshu Reddy, sir, professor in charge of infectious diseases, medicine ICU in the Department of Medicine, KGMU Lucknow, to deliver the lecture. We welcome you, sir. Please also welcome the chairpersons for the session, Dr. Girish Sindhwani, sir, Professor and Head, Department of Pulmonary Medicine, AIIMS Rishikesh, and Dr. Ambar Prasad, sir, Associate Professor, Department of Microbiology, AIIMS Rishikesh.
So, rather controversial topic now. Intermittent dosing versus continuous dosing in of beta lactams in patients with a special category of patients who are critically ill. So this has been a topic of debate for a long time, and then in a specific subgroup of patients who are critically ill, the pharmacokinetics and dynamics are different. So maybe there is a case for a continuous dosing to be maybe better than the intermittent dosing of beta lactams, because this is a different subgroup of patients. So we'd like to hear from the speaker about what is the current evidence and how should we proceed.
Thank you. Thanks a lot for the invite, and thanks for the introductions. So yeah, the beta lactams are the mainstay of any ICU, are the mainstay of any treatment. All the residents out here, I know the moment the patient comes in, the moment the patient says fever, the first thing they start off is ceftriaxone, as if that's the Brahmastra which is going to kill everything. And then every ICU, if you look at the charts, irrespective of what you treat, it will always have a beta lactam, whether it's meropenem or it's a ceftazidime, avibactam, whatever you say, you'll have a beta lactam out there, and rest all are around it, taking care of the other things. So why do we need this topic? Because a lot of issues which do occur, and we have to understand basically what it is. So initially, I'll just introduce that the beta lactams have been and will always be the mainstay. We started off the antibiotic era with a beta lactam, and I think as long as we have beta lactams, we'll keep on having something to treat.
there are a huge group of beta-lactams. It's not like when you say a beta-lactam, there's just a single point of some antibiotic. It's a huge group. It encompasses nearly 30 to 50% of all the antibiotics that we are daily using. And it has a different ways of actually also killing the bacteria. And one of the most important thing is the way it links to the penicillin-linked peptides and how it actually helps in destroying the structures of the cell wall and all. The penicillin-bound protein itself is a protein, and it changes with lot of milieux, lot of things which actually occur. For example, somebody has sepsis. If you have sepsis, the albumin can go down because it is a negative phase reactant. The albumin go down. If there is an organ dysfunction, albumin can change because of many other causes in a pregnancy and all. Similarly, the fluid management changes in different things. So equally, the moment the protein changes, the penicillin binding proteins also tend to change, and this is what is going to alter. And this will be the idea with which I'll try to explain why and where and how to use the beta-lactams. So the next part is, what is it that we talk about when we talk about any antibiotic? Well, any antibiotic kills by 3 methods. That is the concentration dependent, or the time dependent, or both concentration or time dependent. Now technically, if you look at it, an aminoglycoside, most of the times, or the quinolones, they tend to have more of a concentration dependent. And some studies also show that they could be both concentration and time dependent also. The beta-lactams are the best example of time dependent antibiotics. That means if you have a minimum inhibitory concentration, that is the level at which above the antibiotic is going to kill the bacteria, then the longer it stays above it, the better outcome you should be getting technically from the antibiotic. So this is the sort of chart that you would see. Now what you do, what we do. In most of our wards, we do not have time. What we do is we give them as TDS doses or a BD dose, or sometimes an OD dose. So you'll have one strong peak of concentration which is going to come, and then there will be slow lag period. For a infection, for a simple infections, these are pretty good, because that's the amount of time duration which will have. And certain antibiotics like meropenem also tend to have, after it dips, even after the time period, they have a lag period where the effect goes on for another 2-3 hours. So this ensures that in a general ward, you can get all the effect that you want by just doing this TDS or a QID or a BD dose of a ceftriaxone and all. But what happens in an ICU? That is what is important. In an ICU, there are a lot of other things which will happen. An ICU patient, first of all, as I said at the very beginning, has a lot of volume distribution changes. That means you have a patient who is having pulmonary edema, the patient is having low albumin, the patient is having fluid in the third space. Now what does that do? That is, beta-lactams, one important thing is they are actually hydrophilic. They are water soluble very easily. So they will go on getting distributed wherever the water flows. So you can understand, the more the fluid in the third space, the more chance that the beta-lactam is going to go out there. Now look, let's go back to this simple graph. So here is a beta. It means the time actually spent in above the MIC for a patient who has a lot of fluid will be much lower. Similarly, what happens? You are also giving a lot of cardiac output. We just discussed about it. There could be increased, there could be decreased cardiac output. There will be use of vasopressors. Vasopressors can cause there are a lot of things where there could be capillary leaks. Hypoalbuminemia, the albumin is not binding. So there is a lot of free antibiotic. Now the free antibiotic, as soon as it goes into the renal area, it gets cleared, which is known as the augmented renal clearance, which is also increased initially in the initial part of severe sepsis. As the kidney shuts down, then this might again change, where the antibiotic might start getting collected in the body. Then you have mechanical ventilation itself. The mechanical ventilation, what does it do? It actually increases the intrathoracic pressure. So the amount of blood coming back into the heart is going to decrease. The flow throughout the body is going to decrease. So again, you may not have the same amount of ratios or maintenance above the level of the MIC. Then you have a thing called inoculum effect. What is inoculum effect? Certain antibiotics tend to have higher, they require higher doses if the bacterial load is much higher in the body. Meropenums usually do not show inoculum effect, but piperacillin, tazobactam, ceftazidime, ceftriaxone, they all show inoculum effect. That means the microbiologist might be using certain concentration on the plate, but in vivo, the concentration of the bacteria is much higher, due to which the inoculum effect, might require a much higher dose for actually treating the patient. So in a graphical manner, this is what you might see. There's a lot of things which can change. I know it is pretty blurred, so we'll go ahead. And this is what happens. So in an organ failure, where you can see the volume of distribution is high and the clearance is low, so you might have actually a very high peak which the antibiotic might reach. The first graph is normal, where it has a peak and then slow distribution down with a normal volume distribution. When you have an organ failure like liver failure or a kidney failure, the antibiotic is not going to go out so fast. So the peak will be high, but there is a lot of volume. The kidney patients will be having a lot of fluid in third space, so it will get distributed everywhere. In sepsis, where the organ failures have not set in, the concentration will go down and you may not actually maintain the MICs above what you really want to have. So then you have to have different doses. So first part I'll say is, along with this, is you have to have much higher doses. The doses would be something like you might have to go something like a 4 hourly or 8 hourly, or you might have to go for meropenem like 2 gram 8 hourly. In ECMO patients, you might have to go for 2 grams 8 hourly. Even in high ventilation patients where you are having high PEEPs, you might go up to 2 gram 8 hourly. So what does that do? So that actually causes another issue, that you might have side effects. So what are the strategies to improve PKPD? So one of them is altered dosing strategy via a prolonged infusion. So if you look at this graph, if you just look at this, now if you administer at 1 hour, you will have a peak, that the gray line. The orange line is if you give it at 4 hourly, you have a much longer period. So the antibiotic is going to stay, the beta-lactam is going to stay above the MICs for nearly a much longer period. And if you give it as a continuous infusion, the peak will not be there because it is going to go in slow and slow. The distribution to the third space is also going to be slow, but you might maintain a steady state above the MICs. So if you look at this, so it would appear that giving a continuous infusion would be much better than giving a bolus dose, right? Let's see further. The problem out here is you also need to actually reach a level. I'll just, as I go back to this slide, if you look at the blue line, it takes nearly 2 hours by a continuous infusion to reach to that MIC level above the MIC level where the action will start. In a critical care patient, that 2 hours can make a huge difference. So what do we do? And if we give a bolus, it goes up, but it comes down. And the higher the bolus, then the chance is, with the high concentration, your toxicity levels will also go up. You'll reach above the toxicity levels. So what is suggested? Suggested is use a loading dose. Now we do that for colistin. We do that for teicoplanin. Technically, the newer studies are showing that it would be good if you do it for even beta-lactams. Load it, reach to that level, and then put the patient on an infusion so that you maintain the steady state. But you also have to consider the antibiotic stability. All beta-lactams are not stable. Some have a stability for 24 hours, some have stability for only 4 to 8 hours. That means if you put it in continuous infusion, the antibiotic will get spoiled. Then you have to take into account the residual volume or dead space. You are putting into an infusion, the 50 ml in the syringe and in the line itself is there, and that is a pretty decent concentration of antibiotic. You have to take into account the compatibility with other drugs. What do I mean by that? If any resident who has worked in an ICU or in a septic care, he knows that you have one central line, you are connecting multiple infusion pumps, you have a vancomycin going in, you have a beta-lactam going in, you have got other things going in, like vasopressin and all. So how do you ensure that there is no interaction between them? So talking is very easy, that I'm going to put this thing and put it into infusion, but there are multiple drugs going in there. Then the drug accumulation in patients with renal dysfunction, and plus when you're starting a dialysis, then again you have to rethink about how to maintain it. And the target population knowledge should be always there. So how do you do that? So effect stability, most beta-lactams have approximately 12 to 24 hours. So therefore, we never suggest to put it in one thing and go on for 24 hours. It's better that you give it like an infusion of 4 to 6 hours, then again 4 to 6 hours, then again 4 to 6 hours, and so that you can maintain that. And if you look at it, it also depends on what sort of diluents you are using. If you are using water or a saline, it is beyond 4 hours, the beta-lactam starts actually degenerating. So for meropenem and imipenem, the ideal time is between 4 to 6 hours. For ceftazidime, along with avibactam, you might go for a much longer time of 10 to 12 hours also. But beyond that, you can understand the efficacy of the drug will go on decreasing if you are using an infusion pump. The residual volume, as I stated, can account to nearly loss of 10% of antimicrobial activity. So therefore, you have to tell the nursing staff that after infusion, please ensure you add a little bit of saline, let the whole thing go slowly, and don't give it as a bolus. Allow it to flow in slowly, or you take an extra drug count. अगर आपको 1 gram देना है तो थोड़ा सा एक्स्ट्रा लेके चलना पड़ेगा वॉल्यूम, so that you do not lose out on that much of amount of 10% of antibiotic activity. How do you account for the co-administration? If we are giving multiple drugs, how do you do it? So that's where if you have 4 hours, then a gap of 2 hours, the other drug which might actually have an interaction can be given during that space, and that is what you have to do while you're making your charts. You have to account for that. So if you look at it totally, it is not that when we talk about infusion, there is another term called prolonged infusion, and there is a term called continuous infusion. So maybe what the most studies now are saying, a prolonged infusion is a better option than going for a continuous infusion or just a bolus regimen. Do we have a role for therapeutic drug monitoring? Well, if you look at it, most studies till now have not characterized for beta-lactams. Though it has a high variability, it goes into the third space, it might be useful person to person, but one has to remember that the beta-lactams, the cutoff levels, the troughs and the peaks have not been actually classified till now properly, but this is something which people are doing research on. Maybe in future, beta-lactam can also be used for TDMs. You cannot, even though we have TDMs for many things, but we do not have the cutoff values for many. Even for many fungals, if you actually go into it, when you start doing it, you do not have full cutoff values. What is the peak and what is the trough between which you have to maintain it? So you can get a value, but you don't know whether you are in the real value or not. So I'll just end with that. For appropriate antibiotic, you should know first of all the PK/PD for all antibiotics, and attainment in this group might be difficult, specifically in the septic groups where you have a lot of fluid management requirement, fluid changes, albumin changes and all. So prolonged infusion might be useful for such cases. Thank you.
So very nicely explained, first I'll ask the questions from audience if they have any question on this. Yes, please. Please, ma'am. Exactly. So, yeah, it depends again on patient to patient. How many what are the other drugs which are going on? Those are the things which are taken into consideration. You might have one patient who has multiple disorders, and the patient might be on 10 to 15 injections, and then you won't be able to reach that. But you have somebody who's an acute sepsis, where you've got 3 antibiotics and maybe a vasopressor. There you can actually try to reach that 4-hourly dose. Beyond that, I'm pretty sure nobody will be able to reach. You'll have to give those gaps for those drugs to go in. Sir, any studies or maybe RCT to show that these 2 modalities are different in?
Yeah, so there have been 36 RCTs as such as of now. Why I'm saying that there's been a systematic review. In the systematic review, after they did the search for that, they found 36 RCTs. Most of the RCTs, what they show is that the prolonged infusions tend to be better. But again, there is this switch, as as pointed out, you have to see the patient, you have to see your ICUs, you have to see your infusion pumps, and then take into account. Suppose you have 5 infusion pumps, so which is the priority? Then you might give priority to the vasopressors, and then you may not go for this. So even they state that. But if you have the options, and if you can do it, go up to 4 to 6 hours. Beyond it, nobody actually suggests.
So in few of the studies, they are still doing PDM.
Yes.
I mean, to see the toxicity,
Yep.
whether continuous, like prolonged, continuous infusion that leads to toxicity.
So now the
No, not proven.
so there are 2 parts. If we go for a higher dose, for what do you do? If I also look after the ICU, so when you have these sort of situation, one, you might go for a higher dose, like 2-gram shots, which actually crosses the toxicity barrier. Then again you have a problem. The long term will actually lead to, again, building up of in the fatty tissue. The beta lactams tend to have lesser risk compared to certain other drugs because they are not lipophilic. Fat soluble ones tend to have much higher toxicity with time zone. But having said that, ceftriaxone does tend to have bit of, fat attachments. So there you might have such problems again.
So any more questions? If there are no more questions, I would like to thank such a lucid talk and well nicely described. Thank you, sir.
Thank you, sir. Now I would like to request our chairpersons to felicitate Dr. D. Himanshu Reddy, sir. Now I would like to request Dr. V.S. Pai, sir, to felicitate our chairperson, Dr. Girish Sindhwani, sir. Now I would request Dr. Rohit Raina, sir, to felicitate our chairperson, Dr. Ambar Prasad, sir. As we know, achieving and maintaining optimal glycemic control is vital in hospitalized patients, particularly those receiving TPN, where the risk of hyperglycemia and its complication can significantly impact outcomes. So we are honored to welcome Dr. Nidhi Kelly ma'am, Associate Professor and Head, Department of Emergency Medicine, AIIMS Rishikesh, who will share the insights on the topic glycemic management in patient on TPN. We welcome you, ma'am. Please also welcome the chairpersons for the session, Dr. Prashant Verma, sir, Additional Professor, Department of Pediatrics, AIIMS Rishikesh, Dr. Ankit Agarwal, sir, Additional Professor, Department of Anesthesiology, AIIMS Rishikesh, and Dr. Gaurav Jain, sir, Additional Professor, Department of Anesthesiology, AIIMS Rishikesh.
Good morning. I now welcome Dr. Nidhi on the dais to start her talk.
So good morning, everyone. I am Dr. Nidhi, heading the Department of Emergency Medicine at AIIMS Rishikesh. And my talk of today is management of hyperglycemia in hospitalized patients receiving parenteral nutrition. Now, this is indeed a very confusing topic and a difficult case to manage also, because a lot of glycemic variability is associated with a patient who is critically ill, there are other factors also, and especially if the patient is on parenteral nutrition, and it is an independent predictor of mortality in these patients. Thus, it is very, very important that how we manage hyperglycemia in a patient with critically ill, plus also on total parenteral or incomplete parenteral nutrition. Hyperglycemia is seen in around 22 to 46% of hospitalized patients, and particularly in those receiving enteral nutrition or parenteral nutrition with or without diabetes. So irrespective of diabetes status in these patients, these patients they tend to develop hyperglycemia, and we're going to go through the slides, and we'll try to learn that what are the factors associated with hyperglycemia in these patients. So irrespective of the diabetes status, they tend to develop hyperglycemia. So the patients on enteral nutrition, the prevalence of hyperglycemia in these patients is around 30% as per previous studies. And the patients on total parenteral nutrition, the estimate is around 28 to 44%, especially if the diagnostic cutoff is more than 200 milligrams per deciliter, and it is up to 90% if the cutoff value is more than 150 milligrams per deciliter. Now, why are we so worried about hyperglycemia in a patient on TPN? So hyperglycemia, as we all know, it is associated with increased mortality and morbidity. And these patients, they take more time to come off of feeding tube. That is associated with worsening outcome of stroke, pneumonia patients, acute renal failure. It can lead to cardiac complications. So there are varied complications associated with hyperglycemia, and thus it is of paramount importance to control hyperglycemia in patients with total parenteral nutrition. Now, what is actually total parenteral nutrition or parenteral nutrition? Hota kya hai TPN or parenteral nutrition? Is actually when you're giving intravenous nutrients bypassing the GI tract. Okay, this is called as parenteral nutrition. So a bag of total parenteral nutrition or a parenteral nutrition, it has a set of macronutrients, micronutrients, and electrolytes. Now, the three important macronutrients which are most important and which we actually can change the percentage of, they are glucose, lipids, and amino acids. Glucose, lipids, and amino acids. So lipid emulsions is actually, they amount to 25 to 30% of your parenteral bag. And then you have your proteins, which the recommended dose is in a critically ill patient 1.5 grams per kg per day of protein. And it can actually depend on if the patient is having chronic renal failure or hepatic encephalopathy. A patient of So basal bolus regime is another approach. The third approach is, especially if the patient is getting parenteral nutrition, cyclic parenteral nutrition, that is, if you suppose you're giving a nocturnal parenteral nutrition, TPN, so in that case, you can add your insulin, that is 80% of the total daily insulin requirement, you can add to your infusion bag itself. Regular insulin can be added to the parenteral nutrition bag, and along with that, the correctional insulin can be given every 4 to 6 hourly. The dose of regular insulin to parenteral bag can be based on your ID ratio, that is insulin dextrose ratio, that is 1:20 for patients without diabetes or 1:10 to 15 for patients with diabetes. I repeat, the dose of regular insulin can be based on insulin to dextrose ratio, that is 1:20 for patients without diabetes to 1:10 to 15 in patients with diabetes. And then you can monitor the patient's glucose every 4 to 6 hourly. So this is the intravenous regular insulin infusion, which is administered separately from peripheral or central line along with your TPN. So this is something like sliding scale only. Then dynamic insulin administration correction can be given. Suppose the blood sugar is less than 72, decreased by 1 ml per hour. Like that, you can alter your insulin infusion rate as per your blood glucose levels. This is what insulin added to the parenteral nutrition. Now in this, one of the important aspects is obese patients with type 2 DM and significant insulin resistance, 1 international units of insulin can be added for every 5 grams of glucose. And in thin build patients, that is with type 1 diabetes, may require only 1 international units for every 20 grams of glucose. Now, if the patient is receiving separate IV insulin infusion and you want to add your insulin to your TPN bag. Now this is the algorithm you can use. One is changing from IV to insulin added to the PN. You can add 80% of the total dose which the patient was receiving in 24 hours to your TPN bag. Okay, suppose the patient was receiving whatever 20 international units of insulin patient has received. 80% of that 20 international units can be added to your TPN bag in the first go. So one is that. Another important, the blood, then it also depends on your blood glucose levels. Suppose the patient is euglycemic, I'll just take another 2 minutes. Suppose a patient is having euglycemia, the blood sugar is less than 150 milligram per deciliter, then you can alter your insulin levels according to 0.1 international units per grams of glucose or 15 international units per 150 grams of glucose. In blood glucose levels between 150 to 200, 23 international units per gram of glucose should be added. And if the blood glucose level is 200 to 300, start at 100 grams of glucose parenteral nutrition, and insulin dose 15 international units per 100 grams should be added to your parenteral nutrition bag. If blood glucose is more than 300 milligram per deciliter, then parenteral nutrition is contraindicated, and they say you should always normalize your blood glucose before parenteral nutrition initiation. Another important aspect is how do you convert if the patient is having IV insulin and is receiving IV insulin and you want to convert the IV insulin to subcutaneous insulin injection. If the patient is receiving parenteral nutrition for 24 hours, then 100% of that insulin should be added as your basal insulin. If the patient is having parenteral nutrition over 24 hours in combination with oral and enteral feeding, 50% of basal and bolus can be added. Again, for cyclic parenteral nutrition, 50% of basal bolus can be added, and remember to cover the nocturnal insulin requirement as a basal insulin requirement. This is a scheme of injection of rapid-acting insulin for patients receiving parenteral nutrition. Another entity which I will not go in detail, which they have advocated for use, is continuous glucose monitoring, that is closed-loop insulin delivery. How do you control glycemic variability in patients with receiving total parenteral nutrition is actually a topic of debate. So they have advocated the use of hybrid closed-loop insulin delivery system, which is still under studies. And one more point I want to highlight is when you are interrupting the parenteral nutrition, do not stop insulin immediately in patients with type 1 diabetes mellitus and type 2 diabetes mellitus. They should still keep getting insulin infusion in tapering dosages, because there is a risk of ketosis, especially in patients with type 1 diabetes mellitus, and rebound hypoglycemia when stopping parenteral nutrition with added insulin is a very rare thing. So insulin infusion should not be stopped in these patients. So these are the summary of recommendation, and I think I'll end my presentation. Thank you so much.
Thank you, Dr. Nidhi, for such a crisp and lucid talk. So the topic is now open to questions from audience. Any, please?
No question, then I want to ask one question. Just there are no other study beside the insulin to use to decrease glucose? There are no studies beside the use of
Mainly
insulin?
there are actually original articles only which have advocated the adding insulin to the insulin bag. That also if the patient is receiving cyclic parenteral nutrition. If the patient is receiving total parenteral nutrition in 24 hours, then they have advocated the use of IV insulin separately, infusion separately from parenteral nutrition. That is always better. And these closed loop hybrid in the use of closed loop insulin delivery system to reduce the risk of glycemic variability calculation. So they have actually calculated glycemic, and it is an independent predictor of mortality in these patients. So that they have studied. So.
And that use of glutamine
And
is...
Insubar is only the study which has actually, it's an RCT, and it has found that IV insulin infusion is at par with the insulin added to the parenteral path.
So any other question from audience?
Madam, actually, is there any trial comparing that analog basal insulin newer analogs, rapid acting analogs with conventional, which will be better in these kind of patients when you are using? No, generally we tell that analogs are better, but is there any specific trials or some conducted head to head comparing the rapid acting analog like Aspart and Lisbro with the conventional insulin?
Sir, I could not find any study on separately on analog, but the most of the studies are on have utilized regular insulin only, not these ultra short acting.
Not even any place that.
No, sir. And in critically ill patients, the guidelines also say regular insulin, but definitely we'll go through that.
Dr. Nidhi, I have a question.
Yes, sir.
Optimal frequency of testing of random blood sugar while a patient is on TPN.
Yes, sir.
SCM को बताए CCM तो नहीं होगा सब जगह. तो जो common ICU में patient है, आपने उसको रख दिया है total parenteral nutrition.
Yes, sir.
What should be the optimal frequency? जैसे normal पे हम लोग करते हैं 4 hourly or 6 hourly. Is there any optimized frequency of blood sugar testing?
Sir, actually, there are three approaches. So in the first approach, you're giving IV insulin infusion. So in that, every 1 to 2 hourly you have to check, because you have actually, it will depend on your second hourly RBS, how much insulin you're altering. But if you're adding...
My question is,
at least
patient is not on insulin, patient is on TPN.
Only TPN.
So
at least
to avoid hyperglycemia,
yes,
what should the optimum dosing frequency of blood sugar checking?
Sir, at least 4 to 6 hourly. Most of the studies have advocated that. At least 4. Yes, sir.
Okay.
Yes.
So no more question. In conclusion, total parent.
Just one. This lipid content that TPN increases, because I have given total parenteral nutrition to patients in ICU, and we have fixed formulation available from companies like Fresenius, where they actually give how much protein and this is giving. So while you are giving nutrition to the patient about total calories that you are giving, but some amount of lipid will be always exceeded than required, because usually such patients are debilitated. I don't know how much of it is getting absorbed. So what should a person do for this triglyceride and this lipid rise? Because glucose will be compensated, protein you will give, but the lipids, the content that I've seen in all those prepared formulation, usually they give a fixed amount of lipids in that. And if the patient, I don't know what should be the
Sir,
what precaution
madam,
can we take?
everything will be utilized. It is actually the calorie-based requirement of these patients only. So, whatever protein you're also giving, whatever lipid, that will be converted to glucose. So, immediate rise in glucose is maximum with dextrose. That is why you are giving less of dextrose and more of protein and lipids in these patients. And hypometabolic state is there, so you have to.
So when you bypass the GIT, which is one of the endocrine largest organs, mostly the hyperglycemia is major problem, and we need to manage properly. Thank you for so much a nice presentation, Dr. Nidhi. I'm really appreciate for your presentation. Any question from audience? Then if no, we can wind up this presentation.
Thank you. Thank you, sir.
Thank you so much.
Thank you so much, ma'am, for such a wonderful presentation. Now I would like to request our chairpersons to felicitate Dr. Nidhi Kaile, ma'am. Now I would like to request Dr. Namrata Gaur, ma'am, to felicitate our chairperson, Dr. Prashant Verma, sir. I would like to request Dr. Pragati Kapoor, ma'am, to felicitate our chairperson, Dr. Ankit Agarwal, sir. I would like to request Dr. Darab Singh, sir, to felicitate our chairperson, Dr. Gaurav Jain, sir. Thank you so much, sir. Up next, we have an interesting panel discussion on a topic that is vital to the care and recovery of critically ill patients, nutrition in ventilated patients. This panel discussion aims to shed light on the latest guidelines, best practices, and emerging research in the field. Before we dive into the discussion, let me briefly introduce you to our esteemed panelists, Dr. Jyoti Prakash, sir, Professor and Head, Department of Medicine, AIIMS, Patna; Dr. D. Himanshu Reddy, sir, Professor and in charge of Infectious Disease Medicine ICU in the Department of Medicine at KGMU, Lucknow; and Dr. Bala Murugesan, sir, Additional Professor, Department of Medicine, Jipmer, Pondicherry. I would like to hand over the mic to our moderator of the session, Dr. Mukesh Berwa, sir.
So good afternoon to all. So as you know that nutrition is very important for not only the us but also those patients who are on ventilation, and usually we all demand our foods when we are hungry. But what about those patients who are not in the state of demanding the food when they are hungry? So nutrition is prime important for those patients also. So our esteemed panel is for discussion of the nutrition in critically ill patients. So we have Dr. Himanshu Reddy, sir, Dr. Jyoti Prakash, sir, and Dr. Balamurgeshan sir. So my first question is for Dr. Himanshu sir. Sir, please enlighten us about what is the risks and benefits of enteral versus parental nutrition in the critical ill patients.
So, yeah, thank you. Well, by and large, nowadays what the whole world is moving is towards early enteral nutrition systems. The idea is very simple. One, when you start enteral nutrition, you do a lot of things which is physiological.
Yes.
We just heard about the previous talk also. When you talk about enteral, the amount, the way the calories are absorbed, way they pass through the pancreatic and the liver metabolism systems, they're actually the way the body works. That's one. Second is, it also ensures proper gut motility, avoids bacterial overgrowth syndromes, and third, maintains the proper blood flow in the intestines, ensuring proper immune and maintenance of the epithelia. So if you do not have proper gut epithelia, you have again the risk of multiple entry of organisms, and it has been seen that you tend to a higher risk of infections also when you do not use enteral system. But then there are places where the body may not be accepting. You have places where the patient is not actually able to tolerate the feeds. Patient cannot be given feeds because of certain other causes. In such scenarios, you might be using parenteral, but the parenteral feeds tend to have higher risk of infections. One, because of what we explained, plus additionally, most of these feeds which are pre-prepared feeds have a higher risk of candidal infections and bacterial infections. Internationally nowadays, they prepare feed as per the patient there and themselves. They do not actually use the pre-prepared feeds at all.
Okay, thank you, sir. So I think when we start the feed we start the feed in the patients, so enteral feed is better than the parental feed. If we is able to do the enteral feeding, enteral feeding is the more beneficial than the parental feedings. Okay. So my next question is for Jyoti Prakash sir. Sir, usually when we give the food, so there is in India usually there is no balanced food is available. So the feed that is came from the markets, usually they promote that our feed is high protein diets. Most of companies are promoting high protein diets. So what are the risk factor for that high protein diet food for those patients who are having kidney failure or liver failure?
See, Dr. Mukesh, we know that it is well known fact that a high protein diet will worsen patients of liver failure. It can exacerbate the stage of hepatic encephalopathy, and in case of kidney failure patients, acute kidney injury may also worsen, euthymia may increase. So there is a limited, there is a restricted, not limited, there is a restricted protein intake in cases of patients having dysfunction of kidney or liver. The usual will be 0.8 to 1 gram, less than 1 gram per kg per day. But in critically ill patients who are on this critically ill patients, we rather give more protein. It will be around 1.2 to 2 grams per kg per day. So we should be very cautious about the enteral feeding or in cases of patients having this type of hepatic or renal dysfunction. Okay. And the formula fed, the outsider you said, that should be carefully observed because they contain high protein diet. So that I think the homemade cereals, homemade foods, that should be suited to that kind of patients.
Thank you, sir. So the amount of proteins in the feeds depend on the patient's profile, not for the formula feeds. That fixed formula is vary from for patient to patient. So my next is question for Balamurgeshan sir. Sir, please enlighten us about that we knows that those patients, critically ill patients, most likely having hyperinflammatory state. So is there any impact of route and the timing of feeds in these hyperinflammatory patients?
Time, okay. Yeah. So, as much as possible, in those patients, it is better that we should give a enteral nutrition, I mean oral feeding, because the gut integrity, already in the last lesson also it has been told, gut integrity will be maintained and there will be a lot of immunoglobulins will be synthesized when you are mobilizing. And when you are giving a parenteral nutrition, there is increased risk of various metabolic complication, electrolyte abnormalities, and there is a chance of secondary bacterial infection and fungal infection also through the processed feed. So as much as possible, the timing is you start as early as possible because of the Society of Enteral and Parenteral Nutrition and Society of Critical Care Medicine. Within 4 to 7 days as much as possible, when the patient is being put on total parenteral nutrition, is to be put on enteral nutrition. That is a time limit they tell. But as early as possible, depending upon the patient, each patient, we should be giving a oral, means enteral nutrition is better to avoid this thing and maintain the gut integrity, because we are now dealing about that gut microbiome, all those things are we are thinking and considering. So to maintain the good gut integrity, as early as possible, the enteral feeding should be sorted. It should be around 4 to 7 days, it is better.
Okay. Thank you, sir. So, as you know that the timing of enteral feeding should be started as early as possible. So my next question is for Dr. Himanshu Reddy, sir. Sir, sometimes we are unable to give the enteral feeding on the patient. Causes may be various. Some patients having intestinal obstruction or some patients having intolerance to feeding. So when we decide, or what at that time we can decide that patients may require enteral nutrition? Parental nutrition.
Well, technically, see, nowadays the nutrition is a very important aspect in critical care. You cannot get a patient out without having good nutrition. So the moment you see that you are not able to achieve 62% of your calorie count or the protein levels, then actually you have to move ahead to the TPNs. But again, the effort should always be you should actually supplement with the enteral. If you are not able to reach certain levels, or in a critical patient who is not having any other organ dysfunction, like you said already, renal and liver, but suppose he's also with renal, he's on dialysis, then again you have to go at a higher level of protein. You need to reach at least 1.5 of the ideal weight. That's also very important. When you calculate, it has to be according to the ideal weight. You should not take the weight with the edema or the weight in the sarcopenic stage. It should be the ideal weight for the height, and then from there you start calculating. If you're not reaching to that level, then you have to go to the parenteral nutrition.
Thank you, sir. So my next question is for Jyoti Prakash, sir. Sir, various pharma companies came with product, pouch or injectable form in the micronutrients. So how the micronutrients deficit impact the patient of critical care?
The concept is that routine supplementation of these micronutrients in the formula supplied in market is not required by all kind of patients. So it should be on the judgment of the treating physician what micronutrients they might be having deficient. It should be less in practice to give just these oral preparations enteral, because patient might be lacking in micronutrients. Of course, certain micronutrients like vitamin C, vitamin D and zinc, they are beneficial for the critically ill patients in gaining their good health. So this can be given separately. So I just advocate routine supplementation of these feeds for the purpose of micronutrients or micronutrients should not be in regular practice, barring few.
Okay. Thank you, sir. So coming to my next question is for Dr. Balamurgishan, sir. Sir, usually we start the parental or enteral nutrition in the patients who are critically ill patients, but we can't measure how much amount patients require. So what are the various monitoring parameters that can tell us that patient is getting sufficient amount of food or nutrition?
Sufficient amount of. So basically, there is a critical care patients are having a hypermetabolic state. So I already told that protein should be increased when they are having a normal renal function and normal liver function. So normally when we give around 1 to 1.2 gram, and then it should be increased to 1.5 to 2 gram per kg body weight protein. And when we are giving a carbohydrate level also, actually depending upon the weight of the patient, and then glucose level, as already told, blood glucose level to be maintained around 180 milligrams, not that strict hypoglycemia means glucose level need not to be maintained, increase the mortality. So those things should be kept in mind when we are prescribing the protein and carbohydrate, all those things. That's important.
Thank you, sir. I think we are running shortly for the timing. So if any questions from the audience for our panel list. Anyone? If there is no, then we conclude the session of this panel discussion. Thank you, our esteemed panelist. Thank you so much, sir.
Thank you so much, sir, for such an insightful session. Now I would like to request Dr. Pragati Kapoor ma'am to felicitate our panelist, Dr. Jyoti Prakash, sir. Now I would like to request Dr. Nidhi ma'am to felicitate our panelist, Dr. Bala Murugeshan, sir. I would like to invite Dr. Anirudh Mukherjee, sir, to felicitate our panelist, Dr. D. Manchu Reddy, sir. Thank you so much, sir. We have successfully come to the conclusion of our first scientific session. Now we will resume with the postgraduate paper presentation. I would like to request our judges, Dr. Anisa Atif Mirza ma'am, Dr. Pragati ma'am, Dr. Pradeep Meena sir, and Dr. Rajesh Kumar sir to take their seats. I would like to invite our first speaker, Dr. Arun from AIIMS Bhatinda.
Yeah, please stick to your timeline. 7 minutes. It's 7 minutes, right? 6 minutes. 6 minutes.
Good afternoon, everyone gathered here. Myself, Dr. Arun Kumar, internal medicine resident from AIIMS, Batinda. I'm going to present a case on the topic young onset hypertension, underdiagnosed and undertreated, a rare case presentation. So first things first, a short glimpse on secondary hypertension. So hypertension in young age accounts for about 18% and is almost always associated with cardiovascular events in the middle age. The most common causes of hypertension in the young age or secondary, in which the most common cause is kidney diseases, which accounts for about 88%, second being endocrine causes, which accounts for 11%, and 10% is attributed to renovascular diseases. Skipping to my case, my patient is a 28-year-old male who is third born in a non-consanguineous marriage. He has a significant birth history in which initially he was noted to have a female-like genitalia. Later it was identified as male with penile growth. His past history, he reports occasional transient vision loss for 5 to 10 minutes without associated neurological symptoms. He was also diagnosed with hypertension at the age of 16 and he was using over-the-counter medications for the same. Also, he received testosterone injections, multiple doses for around 6 to 7 years for poor beard growth. His surgical history reveals multiple corrective surgery for hypospadiasis in childhood. On clinical assessment, on vital examination, his blood pressure was 170 over 90 millimeters of mercury in right upper limb and 162 over 90 millimeters of mercury in left upper limb. And physical examination revealed stretched penile length of 2.5 centimeter, which is very less as compared to normal, which is 11.6 centimeter plus or minus 2.4 centimeter for the same age. And bilateral testicular volume was less, around 8 ml, which is normal is 12 to 30 ml for the same age. And associated medical conditions were hypospadiasis and undescended testis and primary testicular failure. And we ran labs for the patient, which revealed hypokalemia in the range of 3.12 milliequivalents per liter. His KFT and urine analysis were within normal limits, and calcium and phosphorus and other electrolytes were also within normal limits. His ECG revealed left axis deviation, and 2D echo was within normal limits. There was no diastolic dysfunction or left ventricular hypertrophy with normal ejection fraction. And his serum cortisol at 8 a.m. Came out to be less, around 3.3 micrograms per deciliter, and FSH and LH were significantly high. Then a complete steroid profile was done for the patient, which revealed low levels of androgens and elevated levels of corticosterone and 11-deoxycorticosterone, which was suggestive of 17-alpha hydroxylase deficiency. Then radiological imaging has been done for the patient, which revealed bilateral undescended and atrophic testis, and karyotyping was also done for the patient, which revealed 46XY chromosome. And coming to management part, the patient was diagnosed with 17-alpha hydroxylase deficiency, and due to which mineralocorticoid excess was seen, and the patient was having hypertension secondary to that. So owing to 17-alpha hydroxylase deficiency, there will be associated cortisol and sex steroid deficiency also, for which the patient was started on oral hydrocortisone in the dose of 10-10-5 for cortisol replacement, and he was also started on injection testosterone enanthate 50 mgs IM every 3 weekly for 2 months for replacing sex steroids, and tablet Telma 40 mg OD after getting consultation from the cardiac team. Discussion. 17-hydroxylase deficiency is a rare form of congenital adrenal hyperplasia causing cortisol and sex steroid biosynthesis defects and mineralocorticoid excess, which leads to hypokalemic hypertension and sexual abnormalities, which manifests as pseudohermaphroditism in males and sexual infantilism in females. It is inherited in an autosomal recessive manner, resulting from mutations in CYP17 gene. Our patient presented with incidentally diagnosed uncontrolled hypertension with poor secondary sexual characters with ambiguous genitalia. This case highlights the need to look for rare endocrine causes for hypertension in young individuals. Hypertension in young individuals should prompt investigation into potential underlying causes rather than considering it to be a primary cause. So key takeaway from the presentation is the patient's poor male secondary sexual characters and elevated FSH LH were initially interpreted as primary gonadal failure from a private clinic, and hence he was treated with multiple testosterone injections. However, the true cause was 17-alpha hydroxylase deficiency, highlighting that elevated FSH and LH does not always indicate primary gonadal failure. So these are my references for the same. Thank you.
how many such cases have been reported worldwide?
Sir, I could find barely like 4 or 5 articles in the same 17 hydroxylase. Usually, congenital adrenal hyperplasia occurs with 21 hydroxylase enzyme deficiency, but 17 alpha hydroxylase deficiency presenting as hypertension, I could see like barely 5 to 6 articles.
So basically, your patient, the primary thing was that his OHP, 17 OHP deficiency was not picked up in time.
Yes.
Also, there's bilateral undescended testis. In your history, were you able to pick up a reason as to why he's been operated for hypospadias and the surgeon has not looked for bilateral undescended testis? It's something which is very, very unlikely to happen.
Yes, ma'am, but initially, with ultrasound only, outside they have, actually the patient is working in a medical shop, so he took over the counter antihypertensives by himself. And once only he visited to a private clinic and he was not investigated properly there. No radiologic investigations also has been done from outside. He was taking medications on his own only, then he presented directly to our OPD, then only we investigated everything.
No, what I'm trying to understand is he's been operated for hypospadias.
Yes, ma'am.
Yes. So whoever has examined the penile area must have examined the testes too.
But
so is there a reason that the surgeon had not operated for undescended testes?
For which the
No history.
The patient has no records also for the same, so we
Okay.
couldn't find out what is the
Okay.
reason.
Thank you.
Thank you. Next speaker, please.
Next, I would like to invite Dr. Bharat Gopal from AIIMS Patinda.
A very good afternoon to one and all present here. I'm Dr. Bharat, junior resident from Department of General Medicine, AIIMS Bathinda, here to present a case of a chest wall mass which was later on diagnosed as a paraskeletal plasmacytoma. These are the contents. So plasma cell neoplasms are characterized by the uncontrolled growth of differentiated B lymphocytes leading to secretion of monoclonal immunoglobulins. Multiple myeloma is one such disorder in which the abnormal plasma cells accumulate inside the bone marrow, which in turn produces monoclonal immunoglobulins. This multiple myeloma accounts for 1.8% of all cancers, and in multiple myeloma, sometimes there can be a soft tissue involvement which can present as a mass, which are of two types, paraskeletal plasmacytoma and extramedullary plasmacytoma. The incidence of paraskeletal plasmacytoma is comparatively higher when compared to extramedullary plasmacytoma. However, during relapse, the incidence of extramedullary plasmacytoma is more. We had one such patient who was a 45-year-old male with no previous comorbidities, presented with a swelling over his left chest region for over 1 year, which was gradually increasing in size over the last 6 months. Associatedly, he also had pain and stiffness from the last 20 days, along with a low-grade fever, with no history of cough, vomiting, trauma, bleeding, or abnormal body movements. His physical examination were within normal limits, and vital signs were also stable. On local examination, there was a 4x4 centimeter non-tender, non-erythematous mass over his left infraclavicular area, and the mass was smooth and firm in consistency. The rest of his physical examination was normal. On further evaluation, routine blood investigations were done which was within normal limits, and a true cut biopsy over his mass was done which revealed 4 fragmented linear cores with diffuse sheets of plasma cells suggestive of plasmacytoma. Serum protein electrophoresis was done, showed a gamma globulin of 2.61, and serum free light chains showed increased kappa chains of 168.98 gram per deciliter. So urine electrophoresis were within normal limits. Following this, a whole body PET scan was done which showed an enhancing marsh lesion in the left anterior chest wall involving the left third rib. So this is the histopathological examination of the mass showing the plasma cells, which is seen as a diffuse sheets over here. And this is his blood investigations. His routine were within normal limit. However, Gamma globulins were 2.61 grams per deciliter and free kappa chains were elevated, which was 168.98. This is the bar chart showing the same. This is the whole body PET scan showing this enhancing lesion over his left chest area in both axial and coronal sections. So further diagnostic workup, a bone marrow trephine biopsy was done, which showed a increase of monoclonal plasma cells of 17%, and the flow cytometry showed 3.5% of viable plasma cells, of which 93% were of clonal were of single clone. Fluorescent in situ hybridization was done, of which the abnormal results were 3 copies of chromosome 4p was found, which is indicating hyperdiploidy, and deletion of 1 copy of 14q and 3 copies of 5p, 15q and 4 copies of chromosome 9q were also seen as abnormal FISH results. Immunophenotyping for the same was done, which was positive for CD38, CD138, CD56, indicating that it confirming that those cells were of plasma cells only. So diagnosis of smoldering myeloma with associated paraskeletal plasmacytoma was made, and to reduce the local tumor size, he was started on radiation therapy, which was planned for 30 grays over 10 fractions. Along with the proteasome inhibitor of bortezomib was started 2 milligram subcutaneous weekly, and steroid and cyclophosphamide for immunosuppression. So discussion, an article published by Rosinol et al. Showed a consensus review of both extramedullary plasmacytoma, their incident rates, and paraskeletal plasmacytoma, which determined their incident rates, clinical features and management. This was published in the British Society for Hematology in 2021. Prognosis wise, paraskeletal plasmacytoma is more like an localized disease, which has a better prognosis when compared to the extramedullary disease, which is theoretically proposed to be of a hematological spread. So the take home point is that both extramedullary disease and paraskeletal plasmacytoma are distinct challenges in management of multiple myeloma, with the AMD associated with comparatively worse outcomes. So it is essential for clinicians to distinguish between the same to avoid unnecessary evaluations and surgical interventions. These are my references. Thank you.
I request the audience to please maintain some decorum while our presenters are on the stage. Yeah. So my question to you is, you've been lucky that some CTVA surgeon did not take up the rib mass and excise it. So that's good. One question as to, did you later go in for a FNAC or a biopsy? Just randomly to, since we have all the investigations done, we might as well do this and find it out.
What, ma'am?
Did you go in for a FNAC or a biopsy from the tissue?
Yes, ma'am. Yes, ma'am.
So do you do routine immunohistochemistry also for all these patients?
Not
or
routine.
since you had, since you already had a diagnosis, you did not do
since the hematoxylin eosin stain showed plasma cells, after that we went for immunohistochemistry.
Okay.
Thank you. Now I would like to invite our next delegate, Dr. Abhishek Bhargav from GRMC Gwalior.
A very good afternoon to all respected faculties, dignitaries and delegates. Today I am presenting longitudinal extensive transverse myelitis, rare neurological sequelae following dengue virus infection. I am Dr. Abhishek Bhargav from GRMC Gwalior under the guidance of Dr. Kanika, Assistant Professor, Department of Medicine. Dengue fever is a common endemic in India, the manifestation of which can range from common pyrexial illness to extreme neurological sequelae like encephalopathy, seizures, and intracranial hemorrhages, we report a rare case of neurological manifestation, that is LETM following dengue infection. LETM is a rare type of transverse myelitis, clinical course of which is characterized by single or multiple attacks of paraparesis or quadriparesis plus sensory deficits and bowel bladder disturbances. A spinal MRI showing lesions across more than equal to 3 vertebral segments suggestive of LETM. Early suspicion in LETM is important in dengue fever epidemics. In the month of September 24, a 20-year-old patient presented to us with complaints of progressive bilateral weakness, lower limb weakness, numbness in both lower limbs, and difficulty during micturition. All of this developed over a period of 8 to 10 days. She also had history of fever with chills, myalgia, arthralgia, 3 weeks back, which lasted for 4 to 5 days, and she used to live in an area of recent dengue outbreak. Serological studies confirmed diagnosis of dengue fever and documented low platelet counts. There was no history of visual symptoms, and never had any history of similarness in the past, history of altered sensorium or any facial asymmetry. There was no history of diabetes, any STDs or tuberculosis or similar neurological illness. On examination, bilateral plantar reflexes had extensor response, patient was had exaggerated lower limb reflexes, superficial abdominal reflex was lost, power in both lower limbs at hip, knee and ankle joint was reduced to 1/5, which improved to 3/5 on corticosteroid support. Pinprick sensation was reduced below T4 level, joint position vibration sense were absent, but all of these were normal in upper limb. So clear sensory level was obtained at T4 level. The cranial nerves and upper limb examination was normal. No tenderness deformity found and no respiratory distress time of presentation. There was no significant finding in higher mental functions. All these history and clinical examinations suggested transverse myelitis, which prompted imaging studies. MRI revealed contiguous T2 hyperintensities extending from T3 vertebral level to distal dorsal cord up to D11 vertebral level, suggestive of LETM. Screening MRI brain was done, which was normal. Serum IgM antibody tested positive for dengue. Fundus examination was unremarkable. CSF analysis was also done, which suggested inflammatory pathology or infectious pathology due to pleocytosis and elevated protein levels. Treatment was initiated with corticosteroids, following which weakness significantly improved. Patient was catheterized for difficulty in micturition. Symptomatic treatment was given and lower limb power improved within 12 to 15 days of treatment. If the patient would not have responded to corticosteroid support, then plasma exchange therapy can also be done. In this case, transverse myelitis is the most likely an immune response to dengue virus infection. These investigations were done, which documented low platelet counts, positive serum IgM ELISA antibody, negative ANA and RA factors, VDRL, HIV all tested negative. There was no significant findings on chest X-ray, just some lymph nodes. T2 hyperintensity within the dorsal spinal cord were noted on MRI. So WHO has clarified clinical presentation of dengue into 2 entities: dengue fever plus warning signs or severe dengue. Neurological dengue is classified as a form of severe dengue. LETM is often associated with autoimmune CNS disease like NMO or AIIMS, but in this case, all the investigations suggested infectious etiology. LETM can occur in patient with dengue fever either in infectious or post-infectious phase, but in this case, it is most probably immune-mediated post-infectious phase. Conclusion: high level of clinical suspicion is required along with appropriate imaging modality to diagnose the condition of patients living in dengue endemic areas. These are my references. Thank you.
What was the course of the disease? After how many days did the patient present to you with the weakness in the lower limbs?
After 3 weeks, she presented with weakness.
3 weeks?
Yes, sir.
So
around
the patient was having weakness for 3 weeks or?
No, sir. After 3 weeks of fever,
okay,
she presented back with weakness.
So it was a sequel of dengue or it was active dengue?
No, sir. It was a sequel.
Sequel, right?
What was your mobility of the patient? You've said that there was recovery after steroid use. So your power was 1/5 initially.
Yes,
You've not mentioned power later. So is she walking with support? Is she not walking?
Ma'am, she started walking with support. The power improved to 3/5 with corticosteroid treatment for around 2 weeks. We gave her corticosteroids.
So she's recovered to, she's on 5/5, 4/5 with support?
No, ma'am, there was residual deficit.
There is residual deficits. Okay, thank you.
Thank you. Next, I would like to invite Dr. Akshat Kumar Soni from GRMC Gwalior.
Good afternoon, respected faculty members, my dear colleagues. I am Dr. Akshat Soni, Junior Resident of Internal Medicine, GRMC Gwalior, and I am going to present a case report on the topic initiation of levothyroxine in patient with hypothyroidism precipitating adrenal crisis. It was done under the guidance of Dr. Vijay Gar, Assistant Professor, Department of Medicine, GRMC Gwalior. So, hypothyroidism is frequently diagnosed while adrenal insufficiency often gets missed out. The administration of levothyroxine prior to the glucocorticoid replacement in individual with combined adrenal insufficiency and hypothyroidism can potentially precipitate adrenal crisis. In this report, we present a case of a patient who presented to us in an adrenal crisis after initiating levothyroxine therapy without prior glucocorticoid replacement. So, the patient is a 43-year-old male who presented to our ED with severe hypotension and hypoglycemia. He was referred from a clinic due to complaints of periorbital swelling, malaise, fatigue, constipation, hoarseness of voice, decreased hearing, nausea, and non-bloody MSS. Upon arrival at the ED, the patient's BP was 60 systolic by 40 diastolic mmHg. The pulse rate was 80 per minute. Oxygen saturation was normal at the room air and body temperature was 35 degrees Celsius. His RBS level was 79 and his BMI was 27.6 with body weight of 69.8 kg. Further investigation revealed hyponatremia, hyperkalemia and metabolic acidosis. Based on the clinical suspicion of adrenal insufficiency, serum cortisol level and serum ACTH were ordered and ACTH stimulation test was performed, which confirmed the diagnosis of adrenal crisis. Additionally, the patient was found to have primary hypothyroidism with elevated TSH levels. The chest X-ray suggested possible pericardial effusion, which was confirmed by 2D echo. Subsequently, 1.5 liters of pericardial effusion was drained. Initially, the patient was treated with injectable hydrocortisone and fludrocortisone, along with other conservative supportive measures. Thyroxine replacement therapy with levothyroxine was initiated once glucocorticoid replacement was established. The patient responded well to the treatment with correction of electrolyte imbalance, normalization of blood pressure, and overall improvement is in his general well-being. These were the relevant investigation findings showing hyponatremia with hyperkalemia with raised creatinine. He was not a diabetic patient, and his TSH level was raised, serum cortisol and ACTH, and ABG analysis showed metabolic acidosis. These were the reports of pericardial effusion. So, in this case, the patient experienced an acute presentation after commencing levothyroxine treatment for hypothyroidism. This case exemplifies the potential risk of associated with initiating levothyroxine therapy in individuals who also exhibit signs of adrenal insufficiency. From the physiological standpoint, the hypothyroid state is characterized by a catabolic state that necessitates lower cortisol level. However, when the body's thyroid hormone level are replenished, an anabolic state ensures demanding higher doses of cortisol. In patient with low cortisol level and limited production reserves, the introduction of exogenous levothyroxine can precipitate an acute primary adrenal crisis. Furthermore, thyroid hormone plays a crucial role in cortisol clearance. The initiation of levothyroxine therapy can enhance the clearance of cortisol, thereby exacerbating any underlying adrenal insufficiency and contributing to the likelihood of adrenal crisis. So, to conclude, in cases of combined adrenal insufficiency and hypothyroidism, adrenal insufficiency is generally treated first to prevent the precipitation of adrenal crisis in such patient, careful history and physical examination with regard to recognizing the sign and symptoms of adrenal insufficiency prior to starting patient or levothyroxine for the hypothyroidism should be done. A high index of suspicion of such scenario must be maintained, and awareness of potential danger of starting levo for hypothyroidism should be spread to prevent potential life-threatening adrenal crisis. Therefore, it is imperative to conduct a comprehensive history and detailed physical examination for any patient presenting with overt sign and symptoms suggestive of adrenal insufficiency. These were my references. Thank you.
So you said that ACTH was done on a high degree of clinical suspicion. I would consider that high degree of clinical suspicions with the pinch of salt. So probably you would have the patient would have undergone some more investigations prior to picking up cortisol.
No, the patient had never undergone any investigation of cortisol, or he was undergone investigation of T3, T4 and TSH, and he came with reports of anti-TPO negative, which ruled out autoimmune nature of this disorder. And adrenal workup was done in our center.
So before you did the adrenal workup, you would have investigated the patient for other things, because a young male who comes with hypotension, hypoglycemia, with body swelling, it's either renal shutdown or it is sepsis, usually, yes? So what were the other, when you say it is only high degree of clinical suspicion, I'm asking you, what was it that prompted you to do ACTH under cortisol level? Or did you investigate the patient prior for all these common things and then went in for cortisol?
Actually, the patient was a known case of hypothyroidism since 3 to 4 years, and he was taking medication, thyroxine, on and off. And he presented to us from a clinic, and he had reports, private reports of T3, T4 and TSH and anti-TPO, as I mentioned. And so we suspected that there is some endocrine system being involved more. And the patient was also in shock, and the patient was giving levothyroxine before we admitted. So as per the history and the reports he brought up in our hospital, we suspected to go in this. Thank you, ma'am. Thanks.
Next, I would like to invite Dr. Anish from Department of General Medicine, AIIMS Rishikesh.
Respected dignitaries on the dais and off the dais, I am here to present a case report on silent loculated empyema in a diabetic patient presenting with extreme thrombocytosis under guidance of Professor Ravikant, Head of the Department of General Medicine. Short introduction. Thrombocytosis is defined by the platelet count more than 450,000, and it can be of two types, primary and reactive. Among the hospitalized patients, around 8% of the cases have reactive thrombocytosis, of which 1% of the cases only have platelet count more than 10 lakhs, that is extreme thrombocytosis, and our case was one among them. Case history and examination. A middle-aged female, known case of type 2 diabetes mellitus for 4 years on oral hypoglycemic agent. Documents were not available and she was not knowing the name. She had presented to the diabetic OPD with generalized weakness and uncontrolled sugars on self-blood glucose monitoring at home for last 2 months. She did not have any history of fever, cough, shortness of breath or any chest pain. And on examination, there was left-sided infraaxillary coarse crepitation, and rest of the general and systemic examination was normal. On admission, patient had an RBS of 600, and after blood gas analysis and urine ketone dipstick testing, ketoacidosis was ruled out, and to control the blood sugar, patient was started on insulin infusion. The baseline reports revealed hemoglobin of at 10, counts of 20,000 and platelets of 9 lakhs at presentation with elevated inflammatory markers ESR and CRP. But the patient did not have any symptoms suggestive for the same, and we could not explain the counts as such. Then we got at X-ray. X-ray had revealed, chest X-ray revealed left lower zone consolidation suggested by the clinical examination as well, and patient was initiated on empirical antibiotics to treat the community acquired pneumonia. But since the platelets were elevated, about 10 lakhs per cubic mm on the second, and when it was repeated on 20th, it was 14 lakhs. And 3 months back, the CBC which we reviewed, it was 3 lakhs, it was normal. But since the platelet count was about 10 lakhs, we had to go ahead with, we had to consider myeloproliferative neoplasm as is usually considered in all of the cases. We went ahead with the bone marrow aspiration and biopsy, which was reported to be reactive thrombocytosis only. By the time we had repeated the chest X-ray for the patient after completing antibiotics for 5 days, and it had revealed left lower zone air fluid cavity as shown by the red arrow. First X-ray did not have that finding. After 5 days, then when we repeated, it showed the fluid filled cavity behind the cardiac shadow. We performed a local USG, point of care ultrasound, which showed a loculated collection, and on USG guided aspiration, it revealed the thick pus. Then we aspirated and sent it for analysis. The gram stain had revealed gram-positive cocci, and the culture had revealed methicillin-resistant Staphylococcus aureus. Patient was managed by inserting pigtail to drain the collection as well as culture-guided antibiotic therapy. And with that, her platelet counts came back to normal of 2 lakhs by 28th of 9. So this was a rare case of the reactive thrombocytosis where the counts were more than 10 lakhs, but it gradually improved. So this was the serial X-rays. This last is the X-ray showing pigtail drainage of the collection. So coming to the discussion, this case illustrated the diagnostic dilemma in cases of severe thrombocytosis in range about 10 lakh per cubic mm. As per our conventional understanding, we consider platelet count in range about 10 lakh to be of primary thrombocytosis like myeloproliferative neoplasm. And severe thrombocytosis usually poses a great challenge when it is incidentally detected, as was in our case, resulting in economical and psychological burden as well to the patient and their family. Considering it could be a blood cancer, the patient gets worried in such cases. So even with these high levels of platelets in reactive thrombocytosis, antiplatelets are not indicated as thrombotic risk is very low. When platelet counts are more than 10 lakhs, there is always a dilemma whether to start antiplatelets or not. And in one of the cohort study, only 1.6% of cohort with reactive thrombocytosis had thrombosis. And in extreme thrombocytosis as well, only 4 to 6% had the thrombotic risk. So these are the articles showing the same. First study showed 8% prevalence of infectious disease, 8% cases of reactive thrombocytosis in hospitalized patient. And second one reviewed the 732 patient with elevated platelet count, retrospective study it was, and it found that reactive cases, causes of secondary thrombocytosis were 42% tissue damage, infection in 24%, malignancy in 13%. Another issue in this case we found out was silent infections in diabetes. Pleural empyema is basically pus in the pleural space, and patients with empyema usually require prolonged management, longer hospital stay, intensive care admission, and more medical intervention. And risk of pleural empyema has been associated with tobacco consumption and alcohol, but association with diabetes, there are not much studies available, and it is yet to be elucidated quantitatively how many cases are associated with silent loculated effusion. The data are not much available, especially in patients, especially when they are immunocompromised by virtue of type 2 diabetes, which without manifesting any complaints, it's very difficult to give the numbers in these cases. In a population-based retrospective cohort study, the hazard ratio of empyema in diabetes group was 1.99 times the control group. And empyema is associated with elevated morbidity and mortality. Around 20 to 30% of the patient affected usually die or require further surgery in the first year after developing empyema. This is not with regard to the loculated, it's a generalized empyema. The factor that contribute to risk of empyema in diabetes, some of the explanations could be impaired immune response, chronic infections, altered inflammatory response, metabolic factors like hyperglycemia that influence the pathophysiology of infections and their resolution. So this was a cohort study explaining hazard ratio in diabetes patients, and these are the references. Thank you.
Yeah, thank you. It was Nice case and well presented
Thank
with
you, sir.
nice summary. One thing I want to highlight is if the patient is very severely immunocompromised. One cause of empyema is diabetes.
Yes.
Diabetes is the patient was immunocompromised.
Yes, sir.
And if the patient is very much immunocompromised, then the ESR CRP can be normal. Because
Yes, sir. That can also be normal. Yes, sir. It's very difficult to pick up these kind of silent infections in these cases, and some of them could be in the lung. This was a respiratory. It could be in the abdomen, the site as well. Especially when diabetes patient come with uncontrolled blood sugars, we need to actively search for such infections when they're compliant with the medications as well.
Okay,
thank you, sir.
Next, I would like to invite Dr. Pranjal from GRMC Gwalior.
Good afternoon, respected faculties, my dear batchmates. Myself, Dr. Pranjal Pipre from GRMC Medical College, and today I am going to present a case on a diabetic cardiomyopathy, an overlooked rheumatological manifestation of diabetes mellitus, and it was done under the guidance of Dr. Vikas Yadav, Assistant Professor at GRMC Medical College. Background: diabetic cardiomyopathy is characterized by thickening and tightening of the skin of the underlying tissue. Diabetic cardiomyopathy leads to reduced joint mobility and functional impairment. It is a progressive condition with hallmark signs include prayer sign, where patients are unable to fully press their palms together due to restrictive movement of the fingers, as you can see in the photo. Next, tabletop sign, inability to make contact with the entire surface of the palm and finger on a flat surface when laying their palms on a tabletop with fingers spread out. This limitation in joint mobility is usually painless, although some patients may experience mild pain. Over time, stiffness can lead to significant contracture, particularly in the metacarpophalangeal, distal interphalangeal, and proximal interphalangeal joints, resulting in claw hand deformity. Pathophysiology of the disease include prolonged elevated blood glucose level lead to non-enzymatic glycosylation of collagen and other protein within the connective tissue. This process result in the formation of advanced glycation and product which contribute to the thickening and stiffening of the skin and periarticular tissue. The excessive accumulation of advanced glycation and products disrupt the normal architecture of collagen fibers, causing fibrosis and reduced elasticity. Additionally, microvascular complication further exacerbate tissue damage by impairing blood flow to the affected areas, leading to ischemia and further fibrosis. Impact on the quality of life of the patient: diabetic cardiomyopathy is a non-life-threatening condition, but it can lead to impaired hand function, making it difficult for the patient to perform daily activity such as dressing, eating, and writing. Diabetic cardiomyopathy is indicator of poor overall glycemic control, which is associated with higher risk of diabetic retinopathy and nephropathy. Case report. Coming to the case report, a 46-year-old male presented with 8 months of progressive painless stiffness of both hands. He complained difficulty in doing fine tasks like writing, buttoning his shirt, eating. Patient was examined clinically with general examination followed by systemic examination. On examination, patient was of average build, weighing 64 kg with BP of 132/68, SpO2 under normal range, and RBS of 180. Patient has limited bilateral hand mobility. This consists of fixed flexion deformity at the level of PIP and DIP with mild pain and induration with the positive prayer and tabletop sign. There was thickening and induration of the skin of the palm. CVS examination was normal. Respiratory examination consists of bilateral fine grafts. Ophthalmological examination has visual acuity of 6/12 with non-proliferative diabetic retinopathy on further examination. Routine examination comprises HbA1c 11%, TLC 13,000, +1 proteinuria with mildly raised creatine and within normal limit liver enzyme. Chest X-ray was normal, ECG was also normal. Based on history and examination, 4 differential were considered: rheumatoid arthritis, scleroderma, thyroid disorder, cardiomyopathy. Further workup, there was no Raynaud phenomena, no nodule at the joint, no joint pain. Radiography of the hand did not reveal any significant finding apart from fixed flexion deformity at PIP and DIP joint. Rheumatological workup was negative with normal ESR, normal C-reactive protein, negative rheumatoid factor, and negative workup for scleroderma. Normal thyroid function and normal HRCT chest was found. With above workup, the final diagnosis of diabetic cardiomyopathy was made, and patient started on basal bolus insulin regimen with 14,666 unit, international unit. Patient was also given NSAID for pain along with the physiotherapy. Telmisartan 40 mg was also started for proteinuria. Following up the patient pain and inflammation subsided significantly, but there was no significant changes in fibrosis and deformity, highlighting early recognition and management, essential to prevent the progression of condition and preserve hand. Conclusion, coming to the conclusion, a strong suspicion of diabetic cardiomyopathy should be kept for the patient presenting with joint deformity, mainly in hands, and raised HbA1c level. Cornerstone of the treatment remains strict glycemic control, physiotherapy, stretching exercise, particularly hands and finger. Pharmacological intervention may include NSAID, and severe cases, surgical intervention may be necessary to release thickened tissue. These are my references. Thank you.
This case, what you have presented, how long he was suffering from diabetes mellitus, any number of years did you take in the history?
Ma'am, patient has no such records, but patient has symptoms of polyphagia, polyuria from 3 to 4 years.
Just 3 to 4 years.
As
Because
patient
his
said.
blood sugar was 180.
Yes, ma'am. 180 mg on presentation with 11% of HbA1c.
And the symptoms which was there?
Ma'am, mainly he told us that it was from 8 months, but
8 months.
It was far earlier.
Actually, this is quite common entity among diabetic patients. If you, I am an orthopedic surgeon and I have seen many cases of such in our OPD. The spectrum is very huge, from Dupuytren's contracture to trigger. So the hand diseases are very much common in this. So this is not very uncommon thing. This is very common. Yes.
Sir, I have not seen such cases in our
No, it is
area.
very
That's why.
every 10 out of 100 patients. Yes.
Well,
for you it might be.
Or in my areas it's.
But yes, it's quite common in the
Sir,
patients.
in AIIMS it would be common, but in state medical colleges I don't think it's a common entity.
Okay. Anyways, nicely presented. Thank you.
Thanks. Thank you.
Now I would like to invite next delegate Dr. Vedant from GRMC Gwalior.
Good afternoon, respected dignitaries. I am Dr. Vedant, junior resident from Department of Medicine from GRMC Gwalior. Today I want to share a case presented in our OPD. The patient that presented to us was diagnosed as diabetic steatopathy. Was a known diabetic female who had been suffering from diabetes from 6 to 7 years, and due to her presentation with hemichoria and hemibellismus, the clinical suspicion was raised that she could possibly be suffering from diabetic steatopathy. So we further evaluated the patient for the same. In introduction, diabetic steatopathy is intriguing acute hyperkinetic movement disorder secondary to non-ketotic hyperglycemia. It is a rare disorder with estimated prevalence of 1 per 1 lakh. The prevalence could have been more, but the patients are often with diabetes are often missed with this disease. It is more prevalent in females, and greatest risk factor is old age. The features that include are development of hemibellismus, hemichoria associated with hyperintensity in T1 weighted MRI or NCCT of putamen, caudate nucleus and globus pallidus in various combinations, with putamen being mostly involved. Imaging usually shows absence of mass effect or contrast enhancement, indicating an intact blood-brain barrier. Internal capsule is normally spared. Most likely pathology of diabetic steatopathy involves myelin destructions caused by swollen reactive astrocytes called gemistocytes. This hyperkinetic movement disorder is usually improved with judicious glucose control. The case was a 53-year-old female with poorly controlled diabetes mellitus and 2 months history of continuous involuntary motion of right upper and lower extremity with sparing of tongue, face and neck presented to us. Her movements did not abate with sleep. Her speech was unaffected. Smoothness of her gait was interrupted by incessant motion. Past history was significant for hypertension and diabetes mellitus since 10 years with poor adherence to anti-diabetic medications. There was no family history of chorea. Her medications included metformin, metoprolol, atorvastatin and telmisartan. The vitals with which she presented to us were BP 126/76, pulse rate 82. Her BMI was 23.57. High amplitude involuntary dyskinesias of trunk, right upper extremity, right lower extremities were present. Athetotic and torsional movements of right shoulder, elbow, wrist, hip and ankle were also noted. Gait of the patient's right foot and lower leg jerked during swing phase, making her gait irregular and unsteady. Speech was normal in volume, prosody and fluency. Extraocular muscles were intact with normal amplitude, eye motion in all directions without nystagmus. Pupils were briskly reactive to light with normal accommodation. Cranial nerve examination was normal. It should be noted that there was no orobuccolingual dyskinesia, blepharospasm or jaw deviation. Dystonia was no jaw deviation. Blinking frequency was also normal. Motor strength was preserved in upper and lower extremities. Coordination examination with finger to nose test and right heel to shin test demonstrated sinuous movements due to choreoathetosis, but the target was reached. Patient's DTR was normal. Sensory examination was also within normal limit. Plantars were bilaterally flexor. Her RBS was 345 on presentation with HbA1c of 13.6. Basic metabolic panel was also normal. Workup for electrolytes, because other reasons for steatopathy also include hypocalcemia, hyponatremia, apart from which polycythemia is also one of the reasons. So metabolic panel was done and rest were within normal limit except for her RBS. NCCT had revealed a hyperintensity signal involving left putamen and caudate nucleus. Based on absence of family history of chorea, the characteristic clinical history of poorly controlled diabetes and characteristic NCCT had findings, a tentative diagnosis of diabetic steatopathy was rendered. Patient's blood glucose was controlled and patient demonstrated substantial improvement in the movement disorder within a period of 1 month. This was CT of the patient on presentation, which shows left-sided basal ganglia hyperintensity, and after the blood glucose of patient was controlled, the hyperintensity resolved. Acute hemibalismus hemichorea is defining clinical characteristic of diabetic steatopathy. However, diagnosing diabetic steatopathy is not always straightforward, as there are also many differential diagnoses for it. The possible causes include metabolic, infectious like HIV, inflammatory conditions, iatrogenic, autoimmune conditions like APLA, SLE, also Sydenham's chorea, and neurogenic, neurodegenerative etiologies. Common clinical presentations of diabetic steatopathy include hemibalismus hemichorea involving unilateral limbs, progression from upper to lower extremities, worsening of it during nervousness and suppression of it during sleep. In our case, the patient's acute onset of unremitting unilateral hemibalismus and chorea and HbA1c of 13.6 raised suspicion for diabetic steatopathy. The acute nature of her symptoms and lack of fever helped to rule out neurogenetic and infectious causes, making diabetic steatopathy more likely. Non-ketotic hyperglycemia, hemibalismus hemichorea is rare syndrome characterized by triad of chorea, hyperglycemia and basal ganglia lesion. In our case, the patient has right hemichorea with high blood sugar and hyperdense lesion in left basal ganglia on NCCT head. Although the pathophysiology of non-ketotic hyperglycemia induced chorea is not clearly understood, several hypotheses have been proposed. The mechanism involves shift from aerobic to anaerobic metabolism during pathogenesis of non-ketotic hyperglycemia, leading to decreased level of gamma-aminobutyric acid due to consumption and subsequent disinhibition of thalamus and activation of hyperactive pathway of dopaminergic signaling, causing uncoordinated movements. Poor glycemic control can lead to vascular complications beyond peripheral vascular disease and also increases the risk of cerebrovascular ischemia and also can lead to decreased cerebral blood flow. In general, for patients presented with clinical features of sudden onset uncontrolled movement, the inflow workup should also include neurological evaluation as well as evaluation of non-ketotic hyperglycemia syndrome. Blood glucose control is most important treatment for non-ketotic hyperglycemia, hemichoria. This results in significant improvement of hemichoria. I would like to conclude by saying that diabetic steatopathy is rare hyperkinetic movement disorder associated with poorly controlled diabetes and is characterized by hemibellismus hemichoria. The diagnosis can be complicated by many possible causes of hemibellismus hemichoria. Twofold approach that narrows down the possible diagnosis based on patient's clinical presentation and brain MRI NCCT head characteristic can be effective tool for diagnosis of diabetic steatopathy. Blood glucose control is usually a sufficient treatment for non-ketotic hyperglycemia hemichoria. Proper long-term management for patients' diabetes and achieving adequate control of HbA1c in long term is of great significance.
Please conclude. Please conclude. Your time is on.
Sorry. Apart from this, the patient can also be taken on atypical antipsychotics like haloperidol and VMAT2 inhibitors like tetrabenazine, deutetrabenazine, valbenazine. These are my references. Thank you.
So this is typically a diagnosis of exclusion than a diagnosis of inclusion. So you would have investigated the patients in other ways for the various DDs that you have mentioned. इसमें ऐसा था significant which you picked up during your investigations, because this is a diabetic, chronic diabetic, uncontrolled female.
Yes,
So it's unlikely that you wouldn't have picked up B12 deficiency, folate deficiency, routine peripheral blood smears. Anything else significant that was picked up in your study?
Ma'am, we did not have workup on vitamin B12 levels done on her. Apart from this, the electrolytes and taking polycythemia into account, so apart from this, these were all normal. Thank you.
Now I would like to invite our next delegate, Dr. Pavan, Junior Resident from Emergency Medicine, AIIMS Rishikesh.
Good afternoon, everyone. I'm Dr. Pavane, JR1 from Department of Emergency Medicine. I'm here to present a case report on euglycemic diabetic ketoacidosis from our emergency department. DKA is one of the acute complications of diabetes mellitus, causing significant mortality and morbidity. The clinical presentation of this condition is diverse, going from abdominal pain to sensory distortion and coma. DKA causes approximately annual hospitalization of about 6.53% and in-hospital fatality of 0.4%. A subset of DKA cases termed euglycemic DKA, characterized by euglycemia of blood glucose level of less than 200 milligram per dl and high anion gap metabolic acidosis and an increased plasma ketone concentration. This clinical condition comprises approximately 2.6 to 3.2% of total DKA admission, making it a rare condition. The clinical case: a 50-year-old man presented with a history of systemic hypertension for 10 years and smoking and type 2 diabetes on OHA since last 5 years on tab metformin 500 mg and vildagliptin 50 mg BD and tab dapagliflozin 10 mg OD with a history of CAD and old anti-wall MI with stenting into LAD and heart failure with reduced ejection fraction of 35% on GDMT and CKD grade 3A. Patient came with a complaint of passing loose stools with a frequency of 4 to 5 episodes per day and with vomiting, fatigue and reduced appetite since last 3 days. On physical examination, patient was dehydrated and was actively vomiting. His vital signs were significant for heart rate of 120 beats per minute, temperature of 99 degree Fahrenheit, BP of 110/70, respiratory rate of 22 cycles per minute and saturation of 96 on room air. His ABG values were at admission, pH was 7.085 and bicarb was 14.8 and anion gap of 20 and his urine ketone bodies were moderate positive. his HbA1c levels was 8.8%. This was his POCUS video, and this is ECG showing poor RV progression. Differential diagnosis could be acute gastroenteritis with prerenal AKA with HAGMA, and acute on chronic CKD or type 2 cardiorenal syndrome, euglycemic TKA, or incompletely treated DKA. Upon initial evaluation, patient was administered 500 ml of bolus and 4 mg IV ondansetron. After the diagnosis of euglycemic DKA, he was started on continuous IV regular insulin at a rate of 0.1 units per kg per hour and continuous DPI infusion. And we stopped his tablet dapagliflozin 10 mg. Over the next 24 hours, his bicarb improved to 21 milliequivalents and anion gap reduced to 11. His regimen was transitioned to 18 units subcutaneous HIR Lantus and 6 unit HIR TDS before meals. After 2 days, he was discharged and instructed to stop dapagliflozin and asked to follow up in endocrinology OPD and our fast track OPD. Coming to discussion part, euglycemic DKA is a diagnostic challenge for treating physicians since there is no hyperglycemia. In May 2015, the US FDA issued warning regarding the risk of DKA with the use of SGLT2 inhibitors, and they identified 73 case reports of DKA patients treated with SGLT2 inhibitors. All SGLT2 inhibitors currently approved by FDA for the management of DKA, management of type 2 diabetes mellitus, have been associated with DKA, leading the FDA to require a warning on the package labels. Buckey et al. Performed a systemic review investigating the relationship between SGLT2 inhibitors and DKA in patients with diabetes. He found out 34 case reports of patients with type 1 and type 2 diabetes. Of these cases, 26 case report involving dapagliflozin and 5 involving 26 involving canagliflozin and 5 involving dapagliflozin, 2 involving empagliflozin and 1 involving ipragliflozin. These are the reference article where in 2019 Alexis et al. Reported a case on a 44-year-old male having this canagliflozin 100 mg presented with a complaint of presented to ED. They diagnosed with euglycemic DKA. His precipitating factors were due to insulin withdrawal from his physician. And in 2014, Jana et al. Reported a case on 36-year-old female presented with complaint of acute pancreatitis. Due to prolonged fasting for 1 week, they diagnosed as euglycemic DKA. And Gara et al. In 2020 on 44-year-old male having this empagliflozin consuming ketogenic diet, and Plabo et al. In 2018 74-year-old male consuming dapagliflozin due to dehydration, and Morrison et al. In 2020 on empagliflozin 25 mg due to coordinate infection. Coming to pathophysiology, SGLT2 inhibitors cause euglycemic DKA by causing glycosuria and increasing ketone body absorption in the PCT, and decrease in insulin secretion from the pancreas, and increase in glucagon secretion, leading to increase in fat lipolysis and free fatty acid release into the bloodstream, causing increase in plasma ketones and euglycemic DKA. The reduction in insulin to glucagon ratio stimulate lipolysis and increase in free fatty acid in the blood. The risk factor associated with development of DKA include insulin decrease in insulin dose or starvation, decreased carbohydrate intake, ketogenic diet, acute illness, alcohol intake, pregnancy, pancreatitis, cocaine abuse, and cirrhosis. Another possible cause of euglycemic DKA.
Please conclude. Please conclude.
Yes, ma'am. To conclude the case, euglycemic DKA is an underdiagnosed medical emergency that can develop on a patient who was taking SGLT2 inhibitors. A non-specific clinical presentation and near normal blood glucose levels are likely the main reasons this diagnosis is often missed. It is important to note the side effects of patients who have started on ketogenic diet while on one of the medication. Due to the difficulty in diagnosing this syndrome, we encourage healthcare providers prescribing these medications to counsel the patient about the possible complications and side effects. By understanding the etiology and precipitating factors of DKA with the use of SGLT2 inhibitors, clinician can take the necessary precautions to reduce such events. Thank you.
So how often would you like to do ketone bodies for patients in urine, ketone bodies in urine for patients who are taking SGLT2 inhibitors? We had a lot of discussion today about SGLT2 inhibitors.
Yes, ma'am.
So how often would you like to do ketone bodies in urine? Because this was what your patient
Yes,
was.
ma'am.
Yes?
Ma'am, in the patients who are taking this tab, usually we in emergency department, we witness a patient taking dapagliflozin for heart failure. In that, in high clinical suspicion, like any patient coming with dehydration or alcoholic intake, or any patient coming with a complaint of pain abdomen, in that conditions, we usually routinely we do urine ketone bodies. If the patient is having pH of less than 7.3 and bicarb of less than 15, we usually do, ma'am. Okay, thank you.
Rest paper presentation will be resumed after rheumatology session. I request all judges, faculties and speaker to proceed for lunch. We will resume after 30 minutes. Now, I would like to invite Dr. Ajay, junior resident from emergency medicine. Dr. Naneshwari is here. Dr. Akansha Gaur. Dr. Manish Singh. Okay, I would like to invite Dr. Manish Singh from GRMC Gwalior.
Good afternoon, respected faculty members, delegates and participants. Myself, Dr. Manish Singh Maravi, resident of internal medicine, GRMC Gwalior. Today, I am going to present a case of secondary amenorrhea in a 18-year-old type 1 diabetes mellitus patient under the guidance of Dr. Manish Sharma, Department of Medicine, GR Medical College, Gwalior. Introduction. Diabetes affects both metabolic and reproductive condition in women of reproductive age group. Secondary amenorrhea is the absence of menstruation for 3 or more consecutive months in a woman who previously had regular cycles. Secondary amenorrhea can be a significant concern in a type 1 diabetes mellitus. In these patients, poor glycemic control, insulin deficiencies and associated endocrine dysfunctions can disrupt the hypothalamic pituitary ovarian axis, leading to menstrual irregularities. Here I am presenting a case of 18-year-old female with type 1 diabetes mellitus presenting with secondary amenorrhea. Case presentation: 18-year-old female with complaints of polyuria and polydipsia since 2 years, weight loss since 2 years, amenorrhea since 1 year. In examination, patient's vitals were within normal limit with RBS 534 mg/dl. Investigations were done. RBS on admission was 534-35 milligram DL. HbA1c was 10%. C-peptide was 0.09 nanogram per ml, and urine ketone were negative. FSH was 2.59, LH was less than 0.1, and prolactin was 14.4. FT3 was 65, FT4 was 1.5, and TSH was 2.07. Anti-GAD antibody and anti-islet antibody was negative, and USG whole abdomen was done, which is bilateral ovaries were normal, and uterus shape and size were normal. Discussion: reproductive dysfunction is less known complication of both type of diabetes. Type 1 diabetes mellitus, poor metabolic control, hypothalamic amenorrhea. Type 2 diabetes mellitus, PCOS and obesity, reproductive disturbances. Discussions provide valuable opportunity to initiate timely intervention such as preconception counseling and mitigate reproductive and pregnancy complications. Conclusion: controlled diabetes mellitus type 1 may lead to secondary amenorrhea, and correction in glycemic index of such patients reverts the states of secondary amenorrhea, and secondary amenorrhea can be a screening tool for type 1 diabetes mellitus in female reproductive age group. Thank you.
Just one question. You have described 1 year of amenorrhea?
Yes, ma'am.
And she's type 1 diabetes or type
Yes,
2?
ma'am. Known case of
Type
diabetes,
1
ma'am.
diabetes.
Yes, ma'am.
Okay.
Yes, ma'am.
So she was not investigated before for a year?
No, ma'am. No,
before
ma'am.
she was-
She was not.
And she's only 18-year-old?
Yes, ma'am.
Okay. Thank you.
Thank you, ma'am.
I would like to invite our next speaker, Dr. Ajay from Emergency Medicine.
Good morning, everyone. Myself, Dr. Ajay Kumar, JR1 from Emergency Medicine, AIIMS RISHIKESH. I am here with a case report on snake bite inducing atrial fibrillation presenting to the emergency department. Introduction part, globally.
Please display the PowerPoint. Yes. Make it full screen mode.
Globally, snake bites will be 4.5.
Make it to the slideshow mode.
Oh, sorry. Global burden of snake bites are 4.5 to 5.4 million snake bites annually.
Please come to your title. First slide.
Out of 4.5 to 5.4 million snake bites, there will be some 81,000 to 1,38,000 deaths per year, and especially in tropical and subtropical regions like India, Southeast Asia, and Africa. And venom and its systemic effects are there are venom components for neurotoxins, hemotoxins, myotoxins, cardiotoxins, and common side effects regarding to hemotoxic are coagulopathies, bleeding, and necrosis, and regarding neurotoxic symptoms are ptosis, paralysis, respiratory failure, and myotoxic like rhabdomyolysis and acute kidney injury, and shock resulting from systemic inflammation due to the toxin. And cardiac complications and WHO recognition regarding snake bites are cardiac complications are rare, but severe like arrhythmias, heart failure, even cardiac arrest There are instances of case reports of cardiac complications and ECG changes like T wave abnormalities with ST segment depression, and arrhythmias were also reported. And WHO recognizes this as a neglected tropical disease, with highlights the need for better treatment and awareness and research globally. Coming to the case presentation, this is a 50-year-old woman with a past medical history of hypertension, which is controlled on regular medications, and there is no prior history of heart disease and other major health issues. Presenting complaint with a snake bite on the left ring finger at around 5 p.m. on the same day, and she complains of swelling and tingling numbness over left hand, and she also has ptosis, diplopia, palpitations and anxiety, and she denied history of nausea, vomiting, gingival bleed, ecchymosis, respiratory distress, altered sensorium, and neurological symptoms like dysphagia and dysarthria. And on initial examination, the time of arrival is around 9:40 p.m. on the same day, and on primary survey, her airway is patent and with a saturation of 97 with room air, with a respirator of 18 breaths per minute, and heart rate of 90 with a blood pressure of 200 by 110 mm of Hg, and Glasgow GCS scale was E4 V5 M6 with a with peripheral pulses palpable and regular. And on local examination, as the image shown on the right top corner, she has a swelling with fang marks over the left side ring finger with any evidence of blistering and necrosis. There is tenderness present on palpation but no visible bleeding or signs and severe tissue damage. And on coming to neurological examination, she has ptosis, unable to open her eyelids for prolonged time, and her single breath count was 18 seconds, and muscle power is 5/5 in all limbs and normal tone. And coming to other key findings for ECG, on presentation he has a normal sinus rhythm, and point of care ultrasound shows bilateral A profile in the lungs, and IVC was greater than 50% collapsing without any fluid overload, and her echo suggests normal ejection fraction with a ejection fraction of 50% without any wall motion abnormality and pericardial effusion. And on initial ABG was normal with the pH of 7.35, PCO2 of 42, bicarb of 20, and saturation of 98%, and lactate is also normal, around 1.8 millimoles per liter. And we have managed the patient with initial investigation with blood tests, complete blood count were within normal limits, and LFTs and cavities were also within normal limits with a mild elevation of lactates, and her whole blood clotting time was also around 12 minutes, which is normal, indicating no major coagulopathy. And we have initiated her with blood pressure control with intravenous labetalol of 20 mg stat IV, followed by she has a reduction in BP of to 160 by 90 after 1 hour. And we have also administered anti-snake, polyvalent anti-snake venom because of the neurotoxic effects, ptosis, dysphagia, and we also given with her with injection tetanus toxoid of 0.5 ml AIIMS stat, and regular assessment for ptosis and SBC breath holding time, which is improved after 4th dose of atropine and neostigmine. And on the day 2, actually she has complaints of palpitations and anxiety, and her on examination her heart
rate was... Please conclude in 2 slides.
On clinical implications and recommendation, key lessons from this case report were we have prompt ASV administration for snakebite induced atrial fibrillation, although and ECG monitoring is also essential for these patients, keeping in mind that the cardiac complications can also be as a result of snakebite, and cardiac complications in snakebite are rare but critical, with atrial fibrillation emerging as possible response to venom, and importance to early detection and management with ECG, and vital for early detection and management of arrhythmias, and prompt antivenom therapy with routine cardiac assessment for snakebite victims can also be life-saving, especially in cases with neurotoxic symptoms. And these are the references where I have take this case. Actually, there are case studies over here, sir, where they have seen this Crotolidae polyvalent immune fab post snake bite there will cardiac complications like atrial fibrillation and paroxysmal atrial fibrillation and sinus node dysfunction, where they have given anti-snake venom therapy plus plus or minus amiodarone in some cases, and they have not given in some cases. So we have took references of these studies, and we have tried ASV, and to our surprise it was resolved after 30 minutes. So thank you.
50-year-old female, most common cause of atrial fibrillation is paroxysmal atrial tachycardia. So how have you followed up this patient in post-snake bite period to know that she doesn't have any more atrial fibrillation? And how would you like to follow up?
To follow up this, we have insisted that patient to come to fast track OPD for regularly, and we have already insisted her to come after 1 week, and we have repeated an ECG and troponin levels, and they were in normal limits. Thank you.
Next, I would like to invite Dr. Akash Sachdeva from AIIMS Rishikesh.
Somebody please help me to get in PowerPoint presentation mode.
Good afternoon, respected faculty members, my fellow colleagues and esteemed guests. So today it's a great pleasure for me to present a case series on type 3C diabetes, that is pancreaticogenic diabetes. As we are all aware that diabetes is the most prevalent chronic disease worldwide. But when we listen about diabetes, it comes about type 1 and type 2 diabetes. But I want to say that type 3C diabetes is not a less prevalent form, but often a misdiagnosed form, because it is mainly misdiagnosed as type 2 diabetes and sometimes as type 1 also. So type 3C diabetes, also known as pancreaticogenic diabetes, affects the liver and main pathology affects the pancreas, and main pathology starts in the pancreas. It is often misdiagnosed as type 2, and the most common identified cause of type 3C diabetes is chronic pancreatitis. Among 10 patients of chronic pancreatitis, 7 of them will be suffering from type 3C diabetes. And the other causes include hemochromatosis, cystic fibrosis, and previous pancreatic surgery, which led to the removal of pancreatic tissue and hence led to decreased insulin production. So during the past 2 decades, there have been a tremendous advancement in the understanding of genetic determinants of chronic pancreatitis, which leads to the progression of the disease. But the potential genetic difference between the type 3C diabetes, which is secondary to pancreatitis or type 2 diabetes, there is no potential difference found. So various hypotheses have been put forward to explain the frequent finding of exocrine and endocrine comorbidity, and it mainly includes diabetic neuropathy and atrophy of exocrine tissue due to the lack of local trophic insulin effects or related to local or general vascular damage. As we can see, among 100 cases of diabetes, there are 9 cases of type 3C diabetes. And the majority is type 2 diabetes mellitus, and the middle one is type 1 diabetes mellitus. And the most common cause of type 3C diabetes is chronic pancreatitis, which is accounting approx 79%. So I have taken 3 cases from the medicine ward unit 1. So my first case is 26-year-old male who presented to us with generalized weakness, unintentional weight loss, burning and pricking sensation in both lower limbs, and altered bowel habits. On presentation, the vitals were normal. The metabolic profile includes increased HbA1c, which was 11.1%, vitamin D was decreased. Urine ketones were negative as the diabetic ketoacidosis is very less common in patients of type 3C diabetes mellitus because insulin is decreased along with the glucagon because the main pathology lies within the pancreas. On ultrasound, we found that there was atrophic pancreas, fecal elastase was done and it was found to be decreased, fasting C-peptide was within normal limits, and bilateral DSPN and no retinopathy was found. The diagnosis of type 3C diabetes mellitus was made and distal symmetrical polyneuropathy was found and there was vitamin D deficiency. The patient was managed on insulin therapy and pancreatic enzyme replacement was done. The other case was 62-year-old female who presented to us with pain, abdomen, vomiting, history of chronic pancreatitis and diabetes mellitus. The metabolic profile increased HbA1c, vitamin D was decreased, and elevated blood urea and serum creat. On abdominal ultrasound, we found MPD dilated. So the discussion is that type 3C diabetes presents unique challenges because there are a lot of overlapping features between type 1, type 2 and type 3C diabetes, but it often requires imaging studies and thorough examination of patient history. Imaging studies include CT, ultrasound to visualize the pancreas. The criteria are not well defined, but the major criteria include exocrine pancreatic insufficiency, which can be told by fecal elastase, consistent pancreatic abnormalities on imaging, that is ultrasound or CT, and related autoimmune markers, that is antibodies against insulin or glutamic acid decarboxylase should be absent, which is present in type 1 diabetes mellitus. So these criteria are limited because there are several important factors. There is a lot of overlap between long-standing type 1, type 2 diabetes mellitus and type 3C. When it comes to the management, insulin is the first line therapy and metformin can be tried when HbA1c is within normal limits. So in the conclusion, it is demonstrated that comprehensive diagnostic approach is necessary, which includes imaging, blood test to differentiate type 3C from other types. And in the management, we have to provide insulin and along with enzyme replacement have to be done for pancreatic insufficiency. These are my references.
So these patients of type 3C, that is pancreas-related diabetes, what are the other factors that you have, since this was you've presented 3 patients, so have you defined any set criteria in which you would like to investigate? Would you like to investigate all patients of type 2 or would you like, there's some set criteria for them?
The patients of type 2 diabetes mellitus which presents to us with altered bowel habits, that is nausea, vomiting, or along with it that is diarrhea or constipation. We have to think that there may be a pancreatic enzyme insufficiency. Then we have to investigate for ultrasound and look for the pancreas. And if there is history of chronic alcohol consumption, then we have to think about.
The pancreatic enzymes, what is the levels you have noted? Are they normal or?
Ma'am, fecal elastase we mainly investigate, and if they are
Amylase and lipase in serum?
Ma'am,
They show
amylase,
normal?
lipase, ma'am, yes. For
They show
pancreatitis.
normal or they are?
Ma'am, they will be altered, ma'am, because of
Altered?
pancreatitis.
So this will be making you, then you go for the
Go for, ma'am,
radiodiagnosis.
further diagnosis, CT and. Thank you.
Thank you. Next, I would like to call Dr. Naneshwari.
Good afternoon to one and all present here. Myself, Dr. Jnaneshwari Bai S, Junior Resident from the Department of Community and Family Medicine, AIIMS Rishikesh. I am presenting a case series of pyelonephritis in diabetes mellitus patients. Coming to the introduction, acute pyelonephritis is an infection of renal pelvis and kidney that results due to the ascent of bacterial pathogens from ureters and bladder to kidneys. Diabetics are at increased risk of these infections due to poorly controlled plasma glucose concentration, which impairs granulocyte function and cell-mediated immunity. Incidence of UTI among diabetics was found to be 51.4 and 147.9 per 1,000 years for men and women. The aim of this case series is to add to the current literature by providing information regarding clinical features, microbiological profile, and treatment outcome of pyelonephritis in diabetic patients. Here is a case of a 46-year-old female, a resident of Saharanpur, Uttar Pradesh, who is not formally educated homemaker, known case of diabetes for 10 years, hypertension since 5 years, non-compliant to medicine, without substance use disorder, without any prior hospitalization, now presented with complaints of fever and bilateral flank pain since 3 months, burning micturition, vomiting since 4 months. On presentation, vitals were stable. On systemic examination, their per abdomen bilateral renal angle tenderness was found. On investigations, a peripheral smear showed normocytic normochromic to microcytic hypochromic anemia with few pencil cells. HbA1c on presentation was 9.0, raised CRPH and ESR. She was HCV reactive. Urine analysis showed pus cells of 40 to 50. Urine culture sensitivity yielded E. coli, which was sensitive to amikacin. Ultrasound whole abdomen with KUB showed cystitis with bilateral bulky kidneys and surrounding fat stranding, which was showing likely pyelonephritis. NCCT KUB showed right bulky kidney with perirenal fat stranding with few air foci, likely emphysematous pyelonephritis. Chest X-ray also in this patient showed right-sided pleural effusion. Pleural fluid analysis showed raised TLC and ADA. The final diagnosis was bilateral emphysematous pyelonephritis, right more than left, right tubercular pleural effusion, which was diagnosed clinico-radiologically. Secondary diagnosis being anemia on chronic disease, systemic hypertension, type 2 diabetes, hepatitis C reactive status. Treatment was IV fluids, bilateral DJ stenting was done by the urology team, and empirical antibiotics was started on the day of presentation. Later on, it was changed on to the, based on the culture sensitivity report. Anti-tubercular drugs were started. The insulin injection Lantus, 8 units subcutaneous HS was given. Injection human atrapid regular insulin and telmisartan for hypertension. Here is another case too, 31-year-old female who is a resident of Hasanpur, Uttar Pradesh, with 9 years of married life, obstetric score of P2, L1, D1, known case of diabetes since 10 years, who is non-compliant to medication and hypothyroidism since 3 months on tablet thyroxine 25 microgram. History of prior hospitalization 3 times for the similar complaints. She now presented with complaints of fever, vomiting and pain abdomen since 1 month, burning micturition since last 7 days, burning and tingling sensation of all 4 limbs. Vitals were stable. On systemic examination, there was tenderness over lower abdomen with right angle tenderness. CNS examination showed bilateral symmetric flaccid areflexive motor predominant quadriparesis. Metabolic workup, HbA1c of 9.3. Ultrasound was hydrouretronephrosis. NCCT KUB showed perinephric fat standing with subcapsular collection. Final diagnosis is sepsis, bilateral chronic pyelonephritis with sterile pyuria, bilateral non-obstructive hydrouretronephrosis. Anemia on chronic disease, diabetes was queried type 1 diabetes with bilateral moderate NPDR, bilateral sensory motor axonal neuropathy, diabetic kidney disease, and diabetic cystopathy. Treatment was, she was on antibiotics and insulin was started. Case 3 was 46-year-old male who was a resident of Saharanpur, was known case of diabetes since 4
I
years.
think you will have to conclude it fast now.
Okay, sir. So, discussion, the burden of pyelonephritis in patients with diabetes is high with the implications of clinical outcomes, economic cost, and quality of life. So, diabetes forms the single most important risk factor for complicated UTI. So data suggests that early goal-directed IV antibiotics, fluid resuscitation, and a good glycemic control can improve the prognosis of pyelonephritis. Less invasive procedures like DJ stenting can provide a viable alternative to nephrectomies in early stages of emphysematous pyelonephritis. So conclusion, we can put preventive strategies focused on glycemic control and proactive screening for UTIs can help mitigate the risks of pyelonephritis in this vulnerable population. This is my references. Thank you.
So you had 3 excellent cases with the pyelonephritis and some of the worst complications of diabetes. That is the most important thing that you should have brought out. Yes,
yes, ma'am.
Yeah. And so, what was the common in the drugs that were being used for this patient? All the 3 patients of yours, were there any similarities?
Meropenem was used and amikacin. Most of the patients' urine culture was sensitive to amikacin.
No, this was before they had a complicated course. This is post-op. What you have given is, I understand. Was there any similarity in the drugs that any of these patients were taking, and which of the drugs are you looking at?
Meropenem.
Yes. What was the drugs which they could have been taking?
Diabetic
Yeah.
medications,
Yes. Which
They
could have
were
been leading to diabetes, to the complications of pyelonephritis?
No, ma'am. If they were all the 3 cases were non-compliant to medications, so which led to the severity of this complication. Thank you.
Next, I would like to invite Dr. Akanksha Gaur from GRMC Gwalior. Not there. Dr. Naveen from GRMC Gwalior.
Good afternoon, respected faculty members, batchmates. I am Naveen Kumar Sharma, Junior Resident, Department of Medicine, GRMC Gwalior. Today I am presenting a case of quadriparesis, an uncommon manifestation of Sjogren's syndrome. Sjogren's syndrome is an autoimmune disease which is characterized by lymphocytic infiltration of exocrine gland as well as profound B cells. Hyperactivity with female to male ratio of 9 to 19:1, particularly in middle-aged women. This syndrome has unique features since it can be present with wide clinical spectrum from organ-specific to systemic disease, but renal involvement is relatively uncommon, which is around 5 to 9% overall. Renal tubular acidosis as a part of tubulointerstitial nephritis and glomerulonephritis both are relatively rare occurrence in Sjogren's syndrome. Here I am presenting a case who came with quadriparesis and subsequently found to have Sjogren's syndrome. A 36-year-old female who was average in build and nourishment presented with sudden onset of weakness in all 4 limbs since the last 3 days, which occurred after 2 days of one episode of mild fever and dysuria. On examination, her BP was 108 by 74 mm of Hg, pulse rate is 104 per minute, and SpO2 is 98% on room air. She had mild pallor without any edema, cyanosis, icterus, or lymphadenopathy except slight bilateral cheek swelling with poor oral hygiene, dry oral mucosa, and prior history of dental caries. She did not have any skin rashes or joint pain or any other systemic symptoms. On neurological examination, she had flaccid quadriparesis with grade 1 by 5 power in all 4 limbs, along with inability to hold, move neck by herself. She was fully oriented to time, place, and person. Higher motor functions normal. Bilateral plantars mute. Neck rigidity absent. Kernings and Brzezinski signs negative. DTR absent in both upper and lower limbs. Sensory system intact. Bladder and bowel habits are normal. No prior history of tuberculosis, hypertension, trauma, drug intoxication. Family history of similar episode. Cardiovascular, GI, respiratory, and urinary system was normal on examination. So, on the basis of presentation and clinical examination, tentative diagnosis kept as Guillain-Barré syndrome, hypokalemic paralysis, or encephalomyelitis. On her routine blood examination, hemoglobin was 10 gram percentage, TLC is slightly elevated, 12,300. In her serum electrolyte, potassium is low, 1.3 millicolon per liter. Rest investigations are normal. In her ABG analysis, metabolic acidosis was noted. In her urine test, pH is 7.1, urinary protein 1 plus, pus cells 6 to 8, and RBCs are plenty per HPF. Rest all the investigations are normal. In her radiological examination, USG was within normal limits. Contrast enhanced MRI was in normal limit. In her rheumatological investigation, ANA was positive, NTSS-A and NTSS-B both are positive. Rest antibodies are negative. After carefully excluding all the inflammatory, infectious, demyelinating, neurological, endocrine, and other rheumatological disease, primary Sjogren's syndrome associated with distal RTA with hypokalemic quadriparesis with UTI kept as the probable diagnosis. Outcome: the patient was managed conservatively in initial phases of treatment of hypokalemic quadriparesis as well as acidosis. She was put on the parenteral potassium replacement therapy for gradual correction of profound hypokalemia. She also received the initial short course of empirical antibiotics correction of uncomplicated UTI. After 2 days of continuous potassium replacement therapy, a dramatic response was seen in the patient, and she started to move her lips actively. Then she put on oral potassium therapy and was discharged on low dose oral prednisolone with hydroxychloroquine as advised for regular follow-up. Discussion: hypokalemia is one of the most common electrolyte disorder observed clinically. There are many causes of hypokalemia, which can be divided into 3 categories: insufficient potassium intake, excessive loss of potassium, and changes in the intra and extracellular potassium distribution. Renal potassium loss may occur in primary aldosteronism, congenital adrenal hyperplasia, Liddle syndrome, RTA, and Bartter syndrome. Combination of clinical examination and investigation, it is clear that above mentioned cases is Sjogren's associated distal RTA with hypokalemic quadriparesis. Sjogren's syndrome is associated autoimmune disease with wide clinical. Conclusion: primary Sjogren's should be considered as a potential diagnosis if any patient comes with hypokalemia or hypokalemic paralysis with no prior history. Sjogren's syndrome is mixed diagnosis, which include both clinical as well as extensive investigation with proper correction in between. These are my references. Thank you.
Did you get any MRI of brain or?
Yes.
So that was normal?
With it normal. Yes.
Okay.
Dr. Naveen, can you tell me as to what could have been other causes of so severe hypokalemia in a relatively younger patient with no other medication, no other prolonged illness, adequate oral intake? There is so much hypokalemia, there is no diuretic intake, young female who's already who's on orals, short duration of illness, just 3-4 days of fever. So were you looking for any other diagnosis, or this was the only diagnosis?
GBS
with GBS syndrome.
Thank you.
Thank you so much, everyone. Now we'll conclude the paper presentation part. Our next series of lectures is based on rheumatology. As we all know, the intricate relationship between the endocrine system and musculoskeletal health often goes beyond what meets the eye. Let's unravel the fascinating interplay. I would like to request Dr. Mukesh Berwa sir to felicitate Dr. Pragya Kapoor ma'am. Dr. Anisa Atif Mirza ma'am. Pradeep Meena sir. Dr. Rajesh Kumar sir. Thank you so much, everyone. Our next series of lectures is based on rheumatology. As we all know, the intricate relationship between the endocrine system and musculoskeletal health often goes beyond what meets the eye. Let's unravel the fascinating interplay between these two systems and discuss how timely diagnosis and management can significantly improve patient outcomes. So, for our first session in rheumatology, I would like to invite Dr. Ramesh Agarwal sir, Professor, Department of Medicine, Lady Hardinge Medical College, to discuss rheumatological manifestation of endocrine disorders. I would also like to invite chairpersons for this session, Dr. Santosh Kumar sir, Additional Professor, Department of Community and Family Medicine, AIIMS Rishikesh, and Dr. Pragya Gupta ma'am, Assistant Professor, Department of Endocrinology, AIIMS Rishikesh.
Organizer, excuse me. Please, could you send us the introductions of sir, please? Either please display or I think we should proceed, and I welcome sir. He is Professor Lady Hardinge, and this manifestations of rheumatological manifestation in endocrinology. It's a very confusion situation that comes to the physicians whenever we encounter such type of patient. We are hoping that we are going to have very enlightful sessions. Thank you very much, sir.
Yeah. Thank you very much, chairpersons. And at the outset, I would like to thank the organizers, particularly Dr. Ravikant sir, who has given this responsibility of introducing and telling this confusing topic, which the chairpersons have very rightly said. So, as the words say, it may seem very easy for the rheumatologists which are sitting here in front of me. To me, the rheumatology means something like to deal with the joints, something to do with the, say, musculoskeletal problems, something to do with the tendons for a physician. And for endocrine, that we all know, so I need not tell you, but yes, the commonly things in the endocrine system which we see is the mostly thyroid, diabetes, pituitary and parathyroids. Apart from that, many other specialists may be seeing many other things. For a physician, something like this, endocrine problems and more of these musculoskeletal problems. So how to integrate these things so that when as for a physician, the patient comes to you with either rheumatological problems, then what are the endocrine associations, or say when the patient comes to you with some endocrine problems, so what we should see in them and try to diagnose them early and maybe help them early. So the rheumatological diseases which for me are like ankylosing spondylitis, Crohn's disease, gout, infectious arthritis, some autoimmune diseases which we can say scleroderma, Sjogren's, polymyositis, SLE, tendinitis. So there's a whole list of those autoimmune and rheumatological disorders. So they may present with some specific problems. So coming to the first problem like hypothyroidism, so we all know that these patients, when especially when there is a long-standing hypothyroidism and an uncontrolled hypothyroidism, so these patients may come to you with proximal muscle weakness, and that may be in a prevalent situation of say 30 to 80% of the patients may come to you with difficulty in some sort of walking or getting up from the bed, and all those features of proximal myopathy, and muscle stiffness may be there. And for the postgraduates, we may see that when we tap that part there, it may give rise to a myoedema, like we can see in this slide. In the joints, patients may come to you with the involvement of the knees, the proximal interphalangeal joints, the metatarsophalangeal joints, and there may be some laxity of the ligaments. And of course, what we know is that when there is a lot of edema over there, patients may come to you with symptoms of carpal tunnel syndrome. So joint effusions, joint swelling, muscle weakness, and muscle laxity. So these are the symptoms which are very commonly encountered in patients of hypothyroidism. And the mechanism underlying which has been stated is that thyroxine, it may affect the cellular metabolism, and the T4 deficiency, it leads to abnormal glycogenolysis, mitochondrial oxidative metabolism, which in turn impairs the muscle function. So these effects are reflected in selective atrophy of the type 2 fibers, muscle fibers, which are dependent actually on the glycolysis for their energy supply. And TSH can increase the production of synovial fluid by hyaluronic acid and proteoglycan synthesis, which cause joint effusions. So patient may come to you with some joint effusions and problems of muscles as in hypothyroidism. X-ray may be normal in many cases. If we do a tap of the synovial fluid, it may give rise to some elevated protein in that, apart from increased hyaluronic acid concentrations. There may be presence of some calcium pyrophosphate crystals in the joints. And if you look at the different aspect of the hypothyroidism, apart from what they clinically manifest, there are associations of the thyroid disorders, particularly hypothyroidism like Hashimoto's thyroiditis. So most of the patient, to the tune of say 40 to 50%, they may be associated with other autoimmune diseases like Sjogren's, SLE, rheumatoid arthritis, systemic sclerosis, polymyositis, etc. And the prevalence of fibromyalgia also in autoimmune thyroid disorders is to the tune of 30 to 40%. So when we encounter patients of hypothyroidism, we must keep in mind, like we do certain investigations like anti-TPO, and we may like to and patients may have varied manifestations apart from hypothyroidism, and there may be association of these thyroid disorders with other autoimmune disorders. When we talk of hyperthyroidism, so patients again may present with some myopathy, which was first noted by scientist von Besdow, and again the proximal weakness of the arms and thighs was noted, and the mechanism of that myopathy was again increased cellular metabolism and energy utilization. Increased catabolism, as we all know that it is increased catabolic state in hyperthyroidism, which can lead to protein degradation, and at a later stage maybe myopathy. Patients may come to us with periarthritis with the joint stiffness and involvement of the joints of shoulders, metacarpal phalangeal joints, lumbar spine and hips, and that too in decreasing frequency. So osteoporosis may also be seen in these patients of hyperthyroidism, where increased osteoclastic activity and increased fecal and urinary excretion of calcium and phosphorus may be present. This is another not a very common condition, but yes, if this may be associated with patients of hyperthyroidism, particularly in Graves' disease, that we see the swelling of the metacarpals, as we can see that there may be associated with some digital clubbing and the soft tissue swellings of the hand. Condition is known as thyroid acropathy. And there may be the asymmetrical periosteal bone reaction, which is seen in the diaphysis. So this is also a condition which can present within weeks to years after the patient presents to you with hyperthyroidism. And the changes may occur even after the patient reaches the euthyroid state or hypothyroid state. And that's probably because of the long-acting thyroid stimulating bodies which are present in these patients, which can lead to soft tissue swelling over the fingers. And the joints which are commonly involved are the metacarpophalangeal, proximal interphalangeal joints. And in the radiography, we may see, as we saw in the last diagram, that may be subperiosteal new bone formation involving diaphysis. And etiology may be secondary to the long-acting thyroid stimulator. And these antibodies are basically IgG class of antibodies, which are different than which are not similar to the thyroid stimulating hormone. And the formation of these antibodies is believed to result from inappropriate release of an antigen from the thyroid follicular cells, and which later produce these autoantibodies in the body. So after this thyroid gland, we can discuss something about the pituitary gland. The acromegalic arthropathy again presents with some joint complaints, which may be present in up to 50 to 60% of the patients who have acromegaly. And these patients may come to you after more than 10 years of their presentation of acromegaly. And it should be suspected in patients who present with joint effusions and stiffness that worsens with the activity. And due to excess of growth hormone causing raised IGF, it can cause, it affects the osteocytes, chondrocytes, and the fibroblasts. And the joints may have, the joints may be large, and it involves knees, hip, and shoulder more than the small joints and the spines. And on examination, there may be presence of crepitus, bony overgrowth of the knees and hands, but effusions may be absent in these patients. Radiography may show some soft tissue thickening with broad metacarpals and phalanges, and large spade-like terminal phalanx and some increased joint space, squaring of phalanges with periosteal apposition. I will show you in the next diagram. I think that will be clear from this, that there are some terminal changes in the patients of acromegaly. So these changes are attributed to the acromegaly. And if you want to compare the patient who have come to you with primary osteoarthritis and acromegaly, so we can see that the patients who have osteoarthritis, they lose the joint space rather than in patients with acromegaly, they generally retain this joint space. So this may be one of close differentials of patients who present with joint problems in acromegaly. When we discuss about the adrenals, so Cushing syndrome can also present to us with various rheumatological manifestations, including musculoskeletal problems. They again will have some muscle weakness and atrophy, ecchymosis, edema, and osteoporosis. Avascular necrosis is a very known complication of patients of hypercortisolism. Metacarpals, femoral neck, and vertebral bodies, they all show decreased bone density and vertical striations, and the codfish vertebral deformities, they can be seen in these patients. So proximal myopathy is more especially in the lower limbs, and that's a classical teaching. When we see a patient of Cushing syndrome, generally these patients will have presence of proximal myopathy. Apart from that, crystal-induced synovitis and arthropathy due to repeated intra-articular injections, they may also contribute to some manifestations of some rheumatological manifestation in these patients. Osteonecrosis is another common problem in these patients, where because of the interruption of the blood supply, possibly due to microemboli, these patients may land into fractures of the neck of the femur. So these patients may have a hip which is more than shoulder, knees, and ankles, and there may be painful, tender, and swollen joints, and restrictive, active, and passive motion. And there are 2 or 3 particular signs which are visible on the X-ray, like a crescent sign where we can see the subchondrolucency of the femoral head. And similarly, we can see the dense sclerosis which is over the head of the humerus, as you can see in this. So these are some certain subtle signs which can be picked in the X-ray of these patients who come to us with Cushing syndrome. Then vitamin D metabolism, we all know that when problems occur in the early age, so patients will have some rickets, and when at a later stage come to with osteomalacia. Of course, osteopenia and multiple compression fractures, they are a problem with the vitamin D. And the rickety rosary, they can be present on the chest, as you can see on the costochondral junctions, and there may be subluxations of the epiphyses of the radius and ulna, as we can see in this diagram. So coming to the diabetes, which is the mainly a common problem which we all face. So this whole thing probably reflect most of the problems where the rheumatologist and endocrinologist or a physician, they try to integrate and find out the problems of a patient who has diabetes. On the one side is there are most of those rheumatological problems, on the other side they are the major macrovascular problems which these patients suffer. So these patients have a very serious problem, which is diabetic foot, which we all know. They have got osteoarthritis, then diabetic hand, which is cheroarthropathy, trigger finger, dupuytren's contracture, carpal tunnel. So we're coming to one by one of these things. Then they may have some osteoporosis, some adhesive capsulitis, which is very disturbing as the age also increases and the duration of the diabetes increases. So it is commonly taken as a frozen shoulder, and patient have multiple consultations with the doctors for this problem. Scleroderma of Buschke, which is again a clinical finding which can be picked early in these patients. So musculoskeletal disorders, they occur more frequently in type 2 diabetes individuals as compared to type 1 diabetes. And most frequent articular manifestation it was seen was, these are some studies which I am trying to quote. The numbers may vary from study to study, but in general, T2DM patients, they have more of these musculoskeletal problems, whereas compared to the T1DM. And the frequent articular problem was of the osteoarthritis of the knee, whereas carpal tunnel syndrome, adhesive capsulitis, and hand problems were there in at the extra articular. Some associations was found in the patients who had retinopathy. It was found that a significant association was demonstrated between vascular complications, like mainly in patients suffering retinopathy and the development of extra-articular manifestations such as carpal tunnel, whereas like problems of dupuytren's contracture and diabetic neuropathy, it was associated with adhesive capsulitis. So these are some associations which may or may not be of very relevance, but yes, it helps in identifying those problems. In type 1 diabetes, the problem is of the insulin like growth factor, which are decreased, and because of that there is problem in the differentiation quantity and functions of the osteoblast. In type 2 diabetes, the pathophysiology lies in the advanced glycosylation end products, which bind and lead to many problems in the musculoskeletal system. In the hand, the problem in the hand, they may vary from 3.5 to more than 50% in the patients, more common in type 1 diabetes patients. And as I said, that the problem is because of excessive glycosylation of dermal and periarticular collagen. It may result in these problems in the hand. And patients may have, if we examine the patient by folding the hand, the patient may have some prayer-like deformity where they may be unable to extend the joints of the metacarpophalangeal or the interphalangeal joints. So prayer-like deformity may be seen. Similarly, carpal tunnel syndrome is again a problem for the patients. They come to you with the pain in the distribution of the median nerve in the hands, and that may be elicited by different signs like Tyndall sign or the Phelan sign. And for a physician, it may sometimes be difficult to differentiate from a polyneuropathy with a long-standing diabetes. However, the presence of bilateral presentation in a globe-like pattern, that may favor more of polyneuropathy rather than CTS. And of course, investigations are there which can differentiate between a polyneuropathy and a carpal tunnel syndrome. Again, adhesive capsulitis of the shoulder is problematic for any gender, male or female, because it reduces the range of the motion of your shoulder joint, and patient has got a good poor quality of sleep because of this, because of the pain which is associated with it. And again, this flexor tenosynovitis is in patients of women with long-standing diabetes. Presentation, they may present with aching and stiffness in the palmar aspect of the hand, and they may find that the problems are more in the fingers, more in the morning, and the trigger finger may occur due to inflammatory nodule which is caused in the proximal pulley at the base of the hand, and the treatment again will be NSAIDs, local steroid injection, or surgical releases of that particular part which is trapped. Dupuytren's contracture is present with nodular thickening of the palmar fasciae, which is leading to flexure contractures, usually 4 of the 4/5 of the digits. It has no association with the glycemic control, and due to contractile myofibroblasts producing increased collagen secondary to microvascular ischemia, treatment is almost the same as for the trigger finger, some local NSAID or some local steroid. They may help in relieving this contracture and the pain. So this is again a diagram which is showing that patient is having Dupuytren's contracture. So this is more of a clinical thickening which is present over the nape of the neck, that the patient of scleroderma adultorum, they may present like a thickening of the skin present over the nape of the neck, and a non-pitting edema which is spreading to the shoulders and the back. It may again limit the range of the movements, so sometimes it is disturbing for the patient, although there is no specific treatment for this. Thing which is important for both the clinical and the postgraduate is that diabetic amyotrophy or a diabetic lumbosacral radiculoplexus neuropathy is unilateral presentation, where the patient presents to you with acute one-sided proximal lower limb pain, and it mainly affects the thighs and hips, which is followed by gradually weakness and atrophy of that particular muscle or the limbs. And it is associated with type 2 diabetes. The underlying mechanism is quite likely to be an immune-mediated inflammatory disorder, which may be because of the ischemic neuropathy. Another thing which is of serious concern for the diabetic patient is the involvement of the feet. The involvement of the feet may have many mechanisms, which we all know. The infections may contribute, and we have got a lot of many other series of lecture which probably are scheduled for tomorrow also. The main mechanism which will be contributing for this type of diabetic foot will be infections, neuropathy, some sort of derangement in the arches of the feet. So all of these contribute to the joint problem in these patients, where they come to with Charcot arthropathy. So this is seen in long-standing diabetes mellitus, where the mid-tarsal joints are often involved, and it may come to you with a painless unilateral foot swelling. And the problem here lies with the microangiopathy, which lead to decreased perfusion, and subsequent traumatic osteoarthritis. They may lead to presentation with this type of feet. And X-ray may show destruction of the tarso-metatarsal and metatarsophalangeal joints. And this is just an overview of the X-rays and the images which we can get. In these type of patients, which is showing that the mid-tarsal collapse is present. Similarly, we can see in these patients that may be some hypertrophic changes, some bone destruction. Osteophytes may be seen in these patients in their feet, and some other typical radiological features may be present in these type of patients. And they subsequently may get ulceration, and if infected, ultimately it will be something very serious. So the treatment for these patients will be to, of course, offload the feet by protected weight bearing, some sort of cast and the crow boots. So, and there is no role for fusion or arthroplasty, and probably when severe they may go in for an amputation. So just a show of that the feet. And then again, there is some patients may have a diffuse idiopathic skeletal hyperostosis, which is known as the Forestius disease, where the 4 vertebrae may be fused together and they may cause restriction of the back and the limited motion of the back. And it is generally a painless condition, very difficult to diagnose. And the treatment will be NSAIDs and the physiological treatment. So this is the fusion of those vertebrae which is being demonstrated here. Parathyroid disorders, as we all know that there may be a hyperthyroidism or hypo, and these patients may come to us with problems. Apart from those endocrine problems, they may come to us with bony problems, which are manifested as a Rugger-Jersey spine or a brown tumor, where you may see those lytic lesions in the spine or in the subperiosteal bone absorption. They may be seen in the middle phalanx. So to summarize, I will just say that yes, both the physician and the rheumatologist, they encounter those problems which are not specific to them, but yes, they are very relevant to the patients. And it is better to address the problems by ourselves rather than just referring the patients to one another, so that at least the patient is not shuffled between the 2 specialists, wherever we can help them. So thank you again. Thank you for your patient listening. Thank you.
Thank you. So yeah, it's very interesting area of rheumatological manifestations of hormonal disorders. In majority of our endocrine diseases, we do see musculoskeletal involvement to varying extent. As you mentioned, that some of these can be very obvious, like acromegaly, Cushing's, hyperparathyroidism, whereas in other diseases like diabetes and all, it may not be so obvious, but always elicit, especially for our postgraduates, eliciting these signs may give you the telltale signs of underlying diseases. So yeah, it's very interesting pictures and radiological images you have shown. Thank you.
Thank you very much. Yeah.
Well, Professor Ramesh Agarwal sir, thank you very much for touching this very interesting as well as very confusing topic what I had mentioned earlier, because we are in our daily practice we are encountering such type of patients, and whenever we are having this type of patient, we are always a question raised, question comes to us how to treat, how to approach. So first I would like to go with the audience. Any questions from your side? Yes, ma'am.
The rheumatological manifestations, as you've shown, of disease, it has also been shown in studies that females have preponderance for development of rheumatoid arthritis. And those who have rheumatoid arthritis, those females, especially diabetic females with rheumatoid arthritis, have shown to have inclination towards development of heart failure also. This is what the recent study says.
Very true, ma'am. So it's basically an inflammation which is contributing to this.
So it's a microvascular inflammation that continues all throughout.
Yes.
And unfortunately, many a times when the treatment for heart failure is started or when the investigation is going on, people do not have sex-specific methods of diagnosing. And they forget that females have a different way of clinical presentation and different risk factors, which are sex-specific. So rheumatoid arthritis, which is found more in females, has shown to ultimately lead to heart failure. So it's a very intrinsic part. It becomes a vicious cycle where one leads to other.
Yeah, definitely, ma'am. Every female, for that matter, early development of CAD because of that hormonal loss which happens in the post-menopausal. So that is very fast as compared to those who, the production is mainly by the hormones which is pre-menopausal. The moment they try to enter, they enter from the pre-menopause to the post-menopause, that production is lost. So whenever we are looking at those patients, so we are very sensitive. Of course, apart from that, the female gender as such is more prone to
You've
the
shown
increase.
very nice radiographic images and very nice pictures.
Yes,
but it needs more health awareness in patient education.
True.
More of it is required.
Yes, ma'am.
Very good presentation.
Thank you.
Thank you, sir.
Thank you, sir.
For giving such a nice and wonderful presentation.
Thank you.
And now, hand over to organizer, please.
Thank you so much, sir, for such a wonderful presentation. Now I would like to request our chairpersons to felicitate Dr. Ramesh Agarwal, sir. Now I would like to request Dr. Namrata Gaur ma'am to felicitate Dr. Santosh Kumar sir. I would like to request Dr. Darab Singh sir to felicitate our chairperson, Dr. Pragya ma'am. Glucocorticoids are widely used to manage a range of inflammatory and autoimmune conditions, but their prolonged use comes with significant side effects, one of the most concerned being osteoporosis. We are honored to have Dr. Pragya Gupta ma'am, Assistant Professor, Department of Endocrinology, AIIMS Rishikesh, here with us to share valuable insights on glucocorticoids-induced osteoporosis. I would also like to invite chairpersons for this session, Dr. Subodh Gururani sir, Assistant Professor, Indresh Hospital, Dehradun, and Consultant Rheumatologist, Synergy Institute of Medical Sciences, Dehradun, and Dr. Kamal Bhatt sir, Consultant Rheumatologist and Immunologist, Dehradun.
Good afternoon, everyone. As we are running short of time, I will request Dr. Gupta to start her topic. And she has already been introduced. She was trained in CMC Vellore and has come all the way from there to join AIIMS Rishikesh as a faculty in Department of Endocrinology. She is going to talk about glucocorticoid-induced osteoporosis, a very relevant topic because not only rheumatologists, but I think everybody, every specialty of medicine is using a steroid. So over to you, ma'am.
Thank you. So, so before proceeding for our discussion, I'll be presenting various cases. Am I audible? Am I clear? Yeah, so we'll be proceeding with some case scenarios. So our first case is 60-year-old postmenopausal woman. She has history of wrist fracture following a trivial trauma. She is a known case of rheumatoid arthritis. She was started on 15 mg of prednisolone, which was tapered to 7.5 mg over 5 weeks. And then she is planned to be maintained on 5 mg or lower for longer duration. Now coming to our second patient, this is 25 years old, apparently healthy woman who is diagnosed with ulcerative colitis, and then she is on prednisolone 20 mg for past 2 months. Her Z-score on BMD is -1. Now last case is a 53-year-old healthy man. He is diagnosed with rheumatoid arthritis. He is on prednisolone 10 mg for 4 months. And his FRAX estimation shows 10-year risk for hip fracture as 1.1%. So which patient we would treat? We will come back to this slide at the end of our discussion. Now, as we all know that glucocorticoid is very commonly prescribed both over the counter as well as it's prescribed by physicians of all specialities. So the glucocorticoid-induced osteoporosis is the most common cause of secondary osteoporosis, and it's the most common cause of idiopathic osteoporosis. So many of our patients are on glucocorticoid, but because of lack of awareness, most of them are underdiagnosed and undertreated, and many of them do land into fractures because of lack of treatment. The most characteristic feature of glucocorticoid-induced osteoporosis is the rapidity. That is, as soon as glucocorticoid is started, within 3 to 4 weeks, there is a rapid decrease in bone loss, and maximum fractures do happen in the first year after initiation of glucocorticoid. This is very much contrasting feature with postmenopausal osteoporosis, where we do not see this degree of weight loss. And there is no safe dose or route of administration, although it is dose dependent. Even daily doses as low as 2.5 mg do confer risk, and even studies have shown that high doses of inhaled glucocorticoid do put the patient at risk of glucocorticoid-induced osteoporosis. So coming to pathogenesis, the main effect of glucocorticoid is on the bone formation. So as we know that in any bone, the bone formation is coupled with bone destruction. What glucocorticoid does, it causes apoptosis of bone forming cells, which is osteoblast and osteocyte. Hence, the characteristic feature which we get in glucocorticoid-induced osteoporosis is decreased bone formation. We do see increased bone resorption in early phases of glucocorticoid intake, but it stabilizes over a period of time. Again, this is something which is different from postmenopausal osteoporosis, where bone resorption is more than the bone formation defect. So this is the main mechanism which causes glucocorticoid-induced osteoporosis. The other thing is, as we all know, glucocorticoid do affect muscle, and it puts the patient at risk of falls. It decreases intestinal and calcium absorption, and it causes hypogonadism, all of which put the patient at increased risk of falls and fractures. And not to ignore the underlying inflammatory conditions. So these patients, because of the underlying inflammatory condition, they have high cytokines, high prostaglandins, which also put them at risk of osteoporosis. So in this, the only thing we have to remember, because bone, initially whenever we put the patient on glucocorticoid, initially the bone resorption will be high, and bone formation may or may not be low, but over course of glucocorticoid intake, the bone resorption will stabilize and bone formation will come down. So this is very characteristic. Whenever we decide of starting this patient on therapy, this information is very useful. Now coming to the site of involvement, glucocorticoid mostly affects the cancellous or the trabecular bone. That is the reason in patients who are on glucocorticoid, they are at highest risk of getting vertebrals and neck of hip fractures, as can be seen in this study. The risk of vertebral fracture is as high as 160 to 186%, which is followed by hip, which is as high as 60 to 101%. One very important thing to remember here is, in most of these patients, the forearm will be spared. So if we find that forearm is affected more than these sites, we should rule out other causes of secondary osteoporosis. The most important of that is hyperparathyroidism. Again, this is the most important slide of my discussion. The only point to remember from this is that as soon as we start patient on glucocorticoid, the bone loss starts as early as 3 to 4 weeks, and the rapidity is maximum in initial 6 to 12 months. After that, it stabilizes. So the risk of fracture may increase up to 17 to 20% in first year of starting glucocorticoid. And this is the window period where we have to promptly diagnose, screen these patients, and put them on therapy to avoid these increased risk of fractures. So the highest risk is seen as early as 3 to 6 months after starting these patients on glucocorticoid therapy. Now, one more important thing is, as BMD, bone mineral density assessment using DEXA scan has become a day-to-day thing, one thing we have to remember, that patients who are on glucocorticoid, they fracture at higher BMD as compared to patients who are not on glucocorticoid. So this is this slide actually compares the postmenopausal females who were not on glucocorticoid versus postmenopausal females who were on glucocorticoid. So we can see the incidence of new vertebral fractures in postmenopausal women who were not on glucocorticoid increases steeply after minus 2 BMD of T-score of less than minus 2.5. Whereas patients who are on glucocorticoid, the same postmenopausal female, the risk increases to in BMD as high as less than -1. So this is something we have to remember, that these patients fracture at higher BMD. This is because BMD is basically the bone mineral content of the bone. Glucocorticoid also affects the bone architecture, which is not elicited in BMD. And also these patients are at higher risk of falls and fractures. We have newer tools like TBS, which most likely will come to our daily routine in next few years, which is a marker of bone architecture. So how to assess which of these patients who are on glucocorticoid they are going to fracture? The most important risk factor is daily glucocorticoid doses. Studies have shown that patients, the daily glucocorticoid dose is the most important predicting factor of bone loss and the future risk of fractures. Also, patients who have prevalent fractures before starting glucocorticoid, these are basically low trauma fractures, or patients who are lean or who have low BMD at the onset of glucocorticoid, these are the patients who are at very high risk of fractures. From this graph, we can see that the risk of non-vertebral fracture increases as the dose increases, and it never comes to 0. So even patients who are on less than 5, they are again as low as -2.5, -2.5 2 milligram per day. They are also at higher risk of bone loss. So we should have high degree of suspicion in all our patients who are on glucocorticoid. Now the next question is, what happens when the glucocorticoid is stopped? So the studies have shown the excess risk appears to be reversible once glucocorticoid is stopped. And from this graph, we can see that the reversibility is as high as 30 to 40% of bone loss is recovered in the initial 2 months after stopping glucocorticoid, and it kind of reaches baseline at 1 year after discontinuation of therapy. Now, whether it reaches baseline or not, that is still controversial. Studies are going on. But one thing to remember is patients who are young, patients who do not have major underlying comorbidities, these are the group of patients who will have more recovery as compared to patients who are elderly, that is more than 40-50 years. And that is why our threshold for treatment in patients who are less than 40 years is very high, which we'll be discussing in subsequent discussions. So if a patient on glucocorticoid is coming to us, which all patient we should assess for glucocorticoid-induced osteoporosis? Now, this is ACR guideline, which is American College of Rheumatology, 2022. It states that all patients, adult patients more than 18 years of age who are started or who are on prednisolone equivalent of more than equal to 2.5 milligram per day for more than 3 months, these all patients should be assessed at the baseline, and this assessment is using clinical factors. We should ask the history of any previous low trauma fractures, and then we should assess using FRAX, which FRAX is a tool which we will be discussing later. FRAX is only validated for more than 40 years of age, and we should also do BMD in all the patients, adult patients who are initiated on glucocorticoid, more than 2.5. That practically involves all our patients. So this is the same thing. Adults less than 40 years, we have to ask history of any other risk factors like alcohol, smoking, secondary osteoporosis. We have to do BMD test, that is DEXA scanning. The only difference is FRAX tool we will do for more than 40 years of age. FRAX we will not be doing for less than 40 years of age because this is not validated in this group. But FRAX is something which is easily available as compared to DEXA, so it's a very useful tool. Now coming to DEXA, so as previously discussed, we should practically do DEXA for all patients who are on this dose for more than 3 months. The additional recommendation is we should also do vertebral fracture assessment. This is a kind of screening of skeletal fracture at lower dose of radiation as compared to spinal X-ray, and this we can do with the same DEXA machine, only we have to put one software. So if we are doing BMD assessment using DEXA machine, we can ask for this vertebral fracture assessment. And so more than 40, so there are some differences in postmenopausal osteoporosis versus glucocorticoid-induced osteoporosis. Here we will be discussing GIOP. So in adults less than 40 years, we will take Z-score. Z-score is the standard deviation compared to the same age-matched reference population. Whereas in adults more than 40 years, we should take T-score. T-score is standard deviation compared to the normal healthy population. Now, osteoporosis is defined as T-score less than equal to minus 2.5, and low bone mass is defined as Z-score minus 2. One important thing is DEXA is an important marker of prediction of fractures in adults more than 40 years of age. The baseline DEXA in less than 40 years of age doesn't give us any significant other than that if we follow up it periodically and if we see that there is decrease in the mass, that is important. But the baseline DEXA do give us important information for more than 40 years of age. Now another important thing is so there are two systems which are mostly used in India. One is Hologic and one is Luna. Different centers are using different machines. The important thing is make sure that when we are doing serial assessment using DEXA scanning, make sure patient is doing it on the same system, because Hologic cannot be compared with Lunar and vice versa. We have softwares to convert this, but that is not very reliable. So make sure patient is following the same DEXA system. Now coming to FRAX. FRAX is freely available thing on, you will get it online. So you just have to put the clinical markers and you will get a score. So FRAX we can calculate without doing DEXA and with DEXA also. Even without DEXA, supposedly if we don't have facility of DEXA, if we are doing FRAX, that itself is very important tool. So when we will fill all these, so FRAX is only for more than 40 years of age. When we put all these denominators, we will get something like this. So we will get the 10-year risk estimate of major osteoporotic fracture and 10-year risk of hip fracture. And this value will help us to decide whether this patient needs treatment or not. We will be discussing in subsequent slides. So FRAX is very important. One important thing we have to remember is that as we see, the FRAX do take into consideration that glucocorticoid patient is on glucocorticoid or not, but it doesn't take into consideration how much dose of glucocorticoid patient is on. And as we have seen, the risk increases as the dose increases. So for that, we have correction. So remember, if patient is on more than 7.5 milligram prednisolone equivalent, in FRAX, whatever risk we are getting from FRAX, we have to multiply the major osteoporotic fracture by 1.15 and the hip fracture by 1.2, and this is what we get as glucocorticoid corrected FRAX score, which will be used for the treatment purposes. So management. So irrespective of patient is requiring specific anti-osteoporotic therapies or not, make sure patient is on the lowest glucocorticoid dose possible. Alternative treatments, if supposedly if we can switch the patient to topical as compared to oral, we should try to do that. We should make sure patient is getting enough RDA requirement for calcium and vitamin D supplementation. Do baseline calcium, vitamin D and supplement if patient is vitamin D deficient. Weight bearing exercise, again, whenever we are prescribing weight bearing exercises, we have to keep in consideration the underlying physical illness patient is having. We should advise patients to avoid smoking and excess alcohol, and we should tell fall prevention measures in all our patients. Now, some of these patients will require pharmacological therapy. Which of these patients will require, we will discuss in the next slide. So ACR guideline actually have categorized these patients based on FRAX, BMD, history of previous fracture, and the dose of glucocorticoid. This is slightly busy slide, but to make it simpler, we just have to remember FRAX scoring, the glucocorticoid adjusted dose, the risk of major osteoporotic fracture more than 10, the risk of hip fracture more than 1, or the BMD of more than equal to less than -1. These three values, if any patient has this or less than this, the patient should be treated with glucocorticoids. When we see the patient, the adults who are less than 40 years, this will be discussing in slide. So only based on FRAX and BMD, patients who are on 40 or more, patients of 40 or more years, they can be treated based on FRAX and BMD, but never ever only based on FRAX we are not doing for less than 40. Only based on BMD, we should never start the patient less than 40 years on treatment. So as I have told, if FRAX, major osteoporotic fracture more than equal to 10, or hip more than 1%, or BMD T-score less than -1, consider treatment. This is conditional recommendation. Whereas when it falls further, that is major osteoporotic fracture less than 20, more than 20%, hip risk more than 3%, and T-score less than equal to -2.5, this should be strongly recommended. Now coming to less than 40 years, only the patient who are required, so here the Z-score which we are considering is less than -3. Now, even if patient Z-score is less than or -3, if the patient is on more than equal to 7.5 milligram prednisolone for more than or equal to 6 months, then only we should start the patient on treatment. So as mentioned, the threshold is very high. Very few of the patients who are on who are less than 40 years will require treatment. One thing we have to remember, that in both the group, any patient who is requiring more than 30 milligram of prednisolone for more than 1 month, or cumulative doses of more than 5 gram per year, or history of prior fragility fractures, these patients, irrespective of FRAX, BMD, or any other risk factors, these patients are at very high risk of fractures, and they should be initiated on therapy as early as possible. So before starting these patients on therapy, make sure the patient is on optimal calcium, both through dietary and supplemental measures. And if patient is on vitamin D deficiency, that should be replaced, and the vitamin D values should be between 30 to 50 nanogram per ml. Now patient who are on moderate, high risk, very high risk, this we decide based on FRAX and BMD. There is not much difference. The only difference is, in moderate risk, the recommendation is consider treatment after discussion with, this should be a shared decision, whereas in high and very high risk, anabolic therapy should be considered as the first line of treatment, and these patients should always be treated. If we cannot give teriparatide, or if we cannot give IV zoledronate, at least we should give oral bisphosphonate. These, each and every patient who is falling in high risk should be treated. So the treatment approach should be early screening and initiation of therapy. The various options are oral alendronate, zoledronate, denosumab, and teriparatide. Once the patient is either on treatment, or even if patients who are not on treatment, they should be assessed via periodic VFA and BMD every 1 to 2 years. And once the steroids are stopped, if the patient is not at very high risk, that the patient did not have preceding history of fractures in last 1 year, and the T-score is more than -2.5, then we can consider stopping glucocorticoid with periodic evaluation. And the extra point is, whenever we are giving teriparatide and denosumab, these patients should not be stopped abruptly. This should be followed by bisphosphonate. So this should be discussed with patients beforehand. So now coming to our case scenario, the first female is postmenopausal women with a history of trivial trauma. So this itself makes this patient candidate for the treatment, and we will treat this patient. The other patient is 53-year-old male, which is more than 40 years. Patient is on prednisolone 10 mg for 4 months, which is more than 2.5 for 3 months. And the FRAX score at for hip fracture is 1.1%. We discuss anything more than 1% we should treat. So this patient also should be treated. The last patient who is less than 40 years, that is 25 years old, young female, although patient is on high dose of prednisolone, but because the Z score is -1, unless and until this patient cumulative dose reaches 5 gram, we will not treat this patient. However, we will follow all other precautionary measures in this patient also. So to summarize, glucocorticoid-induced osteoporosis is common. Yeah, I'll finish it off here. Any questions?
Thank you, Gupta. Dr. Gupta, very nice presentation, very informative. So what I understood from your slides are that most of our patients, rheumatological patients, fall under the group of less than 40 years. So in these patients, we are mostly confused most of the time. So according to this presentation, so we have to do the BMD because FRAX is not applicable.
Yeah.
And if it is less than -3 and the equivalent dose is 7.5 for more than 6 months,
Correct.
then only we have to start the treatment.
Correct.
And so I have 2 questions here. So what is the first line therapy we should start with? Like, because you said the bone formation defect is the main culprit here. So should we right away start with teriparatide here?
Yeah. So just to add to your point, one more thing is if patient is receiving 30 mg for more than 1 month, or patient with previous history of fragility fractures also, we should treat this patient. Now the guideline says that only in patients who are at very high risk, which is the latter which I just discussed, these patients, if we give teriparatide, teriparatide should be placed before bisphosphonate.
Less than 40 years we are talking about.
Yeah, yeah. So any patient in whom the growth plates are fused, we can give teriparatide. So if growth plates are fused and patient is at very high risk, we can give teriparatide. But if that also has to be shared decision making. The problem with teriparatide is supposedly you are stopping glucocorticoid and you want to stop teriparatide. You cannot stop teriparatide abruptly. So you have to give 1 or 2 years of bisphosphonate. Other thing is it is subcutaneous injection which patient has to take, and also cost is very high. So if all these logistics are met, then we can plan for teriparatide, or at least give oral bisphosphonates or IV bisphosphonates.
Point taken. And there are many children also who are on a very high dose of glucocorticoids because of their illnesses. So in that case, only supplemental calcium and vitamin D should suffice?
Yeah, so for children, the recommendation is if they have history of fractures or if they're complaining of bone pain, then only we should evaluate further. So if they don't have these things, then we will just give calcium and vitamin D supplementation. Now for children, we don't have any guidelines, so we treat case to case basis. So if we feel that patient is at very high risk, we can give bisphosphonates. Actually, teriparatide and denosumab is not approved in this age group, so we can try with bisphosphonate therapy.
Thank you, Dr. Gupta. Any questions by the audience?
I will have one more comment. And I think the take-home message for especially those who are treating patients of rheumatological manifestations like rheumatoid, that most of the time osteoporosis is a silent disease. It doesn't cause any symptoms. And when we are evaluating patients for painful disorders, we are only concerned about pain, and patient is also concerned about pain. And there are many patients who are on low dose steroid doing well, and we are monitoring other parameters for adverse effects of other disease modifying agents. But the message is that at every visit we should evaluate whether this patient continuously needs this much dose of steroid, because at some point of in future that patient is going to develop osteoporosis. So rather than evaluating, at the same time we should also reconsider the dose reduction.
One last question, ma'am. So there's one very pertinent doubt that first line treatment is optimization of calcium intake. And there are many patients who are suffering from renal calculi. So in those patients, what are the guidelines for giving calcium supplements?
Okay, so that's a good question. So whichever guidelines they state that for example, if you take postmenopausal ladies or these GIOPs, the RDA is 1000 to 1200 milligrams. Now the guideline states that it should be both dietary and the supplements. We know that supplements, there is increased risk of renal calculi, but that risk is very, very low. So so usually we don't think of that, but as you asked, if patient has pre-existing calculi and once we have ruled out that it is not because of any other reason like uric acid and all, we should try to give more dietary supplementations and we should give calcium. I mean, we should try to optimize diet first followed by calcium therapy. But we also have to assess the risk benefit. And there are studies which have shown that various like calcium carbonate versus other thing, but that is not, like that also depends on the feasibility, whether patient has availability of all those things.
Thank you, ma'am. Thank you so much. No questions? We close the session here.
Thank you.
Thank you for the wonderful session, ma'am. Now, I would like to invite our chairpersons to felicitate Dr. Pragya Gupta, ma'am. I would like to request Dr. V.S. Pai sir to felicitate our chairperson, Dr. Subodh Gururani sir. I would like to request Dr. V.S. Pai sir to felicitate Dr. Kamal Bhatt sir. Now proceeding to the next session, I am delighted to invite Dr. Ankit Jain sir, consultant rheumatologist and clinical immunology at Meerut, for upcoming lecture on a highly pertinent topic in rheumatology, difficult to treat rheumatoid arthritis. We welcome you, sir. I would also like to invite chairpersons for the session, Dr. Surbhi Vyas ma'am, Professor, Department of Radiology, AIIMS, Delhi, and Dr. V.S. Pai sir, Additional Professor and Head, Division of Rheumatology and Clinical Immunology, Department of Medicine, AIIMS, Rishikesh.
So let me thank Dr. Ankit for coming from Meerut to enlighten us on something which we see day in and day out. So rheumatoid arthritis is the bread and butter of a rheumatologist. And we see a lot of patients who do not respond to the routine therapy which we give. So let's hear from Dr. Ankit on how to treat difficult to treat RA. Thank you.
How does it move forward? From here outside. So thank you, sir, for the invitation, and it's wonderful coming to this holy city of Rishikesh. I'll start with my talk today. So we have a 45-year-old female. She's a diabetic. She's a hypertensive homemaker. She belongs to a lower middle class and has 2 kids to care for. She has seropositive rheumatoid arthritis for the past 2 years. She is under follow-up with a rheumatologist for the past 1.5 years. And she has received optimum doses of various DMARDs, including methotrexate, leflunomide, hydroxychloroquine, and steroids for optimum time around 6 to 8 months. Despite that, she continued to have a high disease activity. So we started the patient on tofacitinib 5 mg BD, and the patient continued this therapy for around 4 months. But still the patient continued to have moderate disease activity, though the patient was slightly better. So we thought ki it is not a worry. We switched the tofacitinib to the rituximab, and we gave full dose of rituximab 1 gram 15 days apart. We followed this patient after 4 months, and she presented to us with slightly better disease activity, but the disease was still active. So the question is what to do next. There are various options, combination therapy, or we can use another biologic like adalimumab. This is a common emotion which comes in the OPD chamber when such a patient comes. The patient is sitting in front of you crying in pain. The doctor is sitting in front of the patient thinking, scratching his head, what to do next. The patient says, doctor, I have been under your treatment for the past 1.5 years, and still I am having this pain. What to do now? So this is the classic case of difficult to treat rheumatoid arthritis commonly seen in our day-to-day practice, and it's a cause of concern in most of the times. So it is such an important topic that EULAR recently they have come up with criteria to define what is the difficult to treat rheumatoid arthritis. So basically they have given 3 criteria which needs to be fulfilled for diagnosing a case with difficult to treat RA. The first is that the patient should have been treated according to the EULAR protocol with combination DMARDs followed by at least 2 biologics or a targeted synthetic DMARDs, and the patient has failed both the treatment. But the caveat they have mentioned is that if the patient belongs to a poor socioeconomic status, even in countries in which everything is paid by insurance, even in those countries, patients with poor socioeconomic status, this criteria can be waived off for a 2 biologic. The second is that we should be able to demonstrate patient is having an active disease, which can be by the various disease activity measures like the DAS28 score, or there are clinical signs of active disease like their tender and swollen joints. We are not able to reduce the GI steroid dose beyond a certain limit despite all the therapies. There is rapid radiological progression of the disease, and apparently the disease is well controlled, but patient is still having problems because of the disease, like if the patient is having extraarticular manifestation like ILD or a vasculitis. And finally, the EULAR says that both the patient and the doctor need to understand that it is a difficult situation. So as I said, it is a headache for patient as well as the doctor. Difficult to treat rheumatoid arthritis is common, much more common as we had previously expected. The various studies, they point out the prevalence from around 5.5% to around 30%. Difficult to treat rheumatoid contributes to higher morbidity, mortality, and poorer quality of life. It bears a higher cost of therapy, and there is a loss of work associated with it. If we look at the characteristics of difficult to treat rheumatoid arthritis, the various studies indicate the socioeconomic status is one of the most important factors associated with it, because what they found that patients who have a poor status, they are not able to afford therapies, they are not able to continue therapy because of their situation, and they have poor support. So patients who have difficult to treat RA, they tend to have a poorer socioeconomic status. They tend to have more of comorbidities, and maybe comorbidities contribute to the D2T status, because many patients with comorbidities, they are not able to be given full doses of their DMARDs like methotrexate or leflunomide. It was interesting to see that patients with difficult to treat RA, they had lower methotrexate use as compared to their counterparts, and probably the reason is that these patients, because of their comorbidities, might not have been able to tolerate the higher doses of methotrexate or drug non-adherence. Then naturally these patients tend to have a higher glucocorticoid dose, and they have a higher seropositivity, And one important point which needs to be discussed in detail is the non-adherence, because non-adherence contributes to higher D2T RS status. Most of the studies, they have not looked at it, but the only study which has looked has said that it contributes highly to the difficult to treat status. If we look at the factors, so if we look at the factors which contribute to the difficult to treat RS status, comorbidity is one factor which is very important one. Comorbidities can interfere with the assessment of disease activity in patients with rheumatoid. Like for example, if the patient is having fibromyalgia or obesity, tender joint, swollen joint count assessment becomes a problem. Then in patient with osteoarthritis and damaged joints, in those patients, it is difficult to assess whether the pain is coming from the damage because in the joint or it is disease activity. Besides that, comorbidities, they affect the treatment of the patient. For example, a patient with diabetes, a patient with a chronic kidney disease, we are not able to give optimum doses of methotrexate. Patients with cardiac diseases, liver diseases, in today's world, this fatty liver and transaminitis is a big problem, because most of patients, they tend to have mild transaminitis probably because of the fatty liver, and most of our drugs like the methotrexate and leflunomide we talk about, they both are hepatotoxic. So we are really, our hands are tied when we have to treat such patients, and especially if they are difficult to treat, it creates more problems. Then patients who have hepatitis B, C infections, in those cases, before starting DMARDs, we have to start them antivirals, and their liver might be compromised to tolerate these drugs. So when such patients come in the OPD, what do we do? The first thing which I tell the patient is get the old record out, bring the file. We study it, we read it around, we find what are the drugs we have used in the patient, what drugs which have caused problem, what drugs are left which we can use, if there is any drug which we can modify the dose, or some combination which we might use for this patient. EULAR came out recently with points to consider in patients with difficult to treat RA for their management. And the first point they say that they discuss is that we have to find out if it is the diagnosis of rheumatoid arthritis is correct or not. That is a very important pertinent point, because many diseases they are very close mimic of rheumatoid arthritis. And there is a whole list of diseases which can do that from rheumatology itself, and other diseases like infections, like infective endocarditis, viral infections, hepatitis B, C. So then we have Still's disease, we have myositis and lupus. They all can mimic arthritis, rheumatoid arthritis. So if the patient is not responding, we have to find out, there may be diagnosis is a problem. Once we are sure that the diagnosis is correct, we have to find out if the patient is actually having problems because of the disease activity or because of the some other thing. So for disease assessment, we can use our clinical judgment, but many times some comorbidities, like I said earlier, fibromyalgia and obesity, they interfere with assessment of joint counts and disease activity. In such situations, ultrasound can be very helpful, because they can point out any patients with active synovitis or pick up a power Doppler signal to suggest inflammation. Treatment adherence is fundamental to management of rheumatoid arthritis, more so for any chronic disease. And various studies have looked at it, and they have pointed that drug non-adherence is almost to the tune of 30 to 80% in patients with rheumatoid arthritis. And this is much more in patients who have a difficult to treat rheumatoid arthritis rather than the other counterparts. So what problems does it cause? Suboptimal adherence is associated with higher disease activity levels. Naturally, when the patient is not taking drug, the disease activity is high. And the more problematic is inappropriate treatment switches. Suppose the patient has been prescribed a methotrexate of 25 milligram injectable IM, and the patient goes home, does not want to take injections, takes only 15 milligram methotrexate, and comes after 3 months with all the joints which are swollen and tender. So we think that probably the patient is not responding to the drug. But when we ask the patient in detail, we find that the drug itself is not being given to the patient. So in such scenarios, we might inadvertently switch the drug without the actual dose being used. This leads to exhausting of existing resources and existing drugs for treatment for rheumatoid arthritis. So we have to be very careful in these patients regarding adherence, and it causes a reduced quality of life because of disease activity. So much so that EULAR came out in 2020 with the recommendation for points to consider in patients to assess for their drug non-adherence. So what they suggest is that all healthcare personnel involved in management of patients with rheumatoid arthritis need to reinforce the requirement to continue medicines, to continue the drug and adhere to the therapy, and find out if the patient is taking the medicine regularly or not. And if they find out some great signal, then accordingly they need to inform the treating physician. Then second is it has to be two-way communication with the doctor, with the treating physician and the patient, because unless the patient communicates to the problems of why they are not taking the drug, the treating physician will never know what is the problem. Then there are certain myths, like patients don't want to take injectable medicines like injectable methotrexate, or some have told them that this drug is not good for health. So in that case, they might not be, even if you write it on the prescription, they might not take it. So those factors we need to find out after in discussion with the patient, that why are you not taking a drug? And if possible, we need to convince the patient to take the drug, or else we might actually need to change the prescription, because anyways the patient will not take, and it will lead up to a difficult to treat rheumatoid. Then the treatment goal is to know what is the treatment goal for the patient is important. Suppose we are treating a patient who is a 70-year-old male who has a sedentary lifestyle, passes his day reading the newspaper, not doing much work. If he has 3 to 4 swollen joints with mild pain, it won't bother him. He is happy with that, his disease is better than before, and he is able to do daily activities. So even if the clinician thinks that no, you are having an active disease and you need to be treated well and you need to be started on biologics, he won't agree. And if you prescribe it, they won't take it. On the contrary, you have a 30-year-old female who is a teacher by profession, has to feed her 2 kids, get up early in the morning and get around with her daily business. If she has 3 joint involvement, and in the morning when she gets up, she is not able to cook food for her children, she is not able to make lunch for them, she will definitely say ki, even if I feel ki that disease is not much, but she will stand up and say, no doctor, I want a better treatment because I am not able to carry out my daily activities. So this patient definitely needs treatment. So this has to be decided by the patient himself, what does he want from the treatment. The adherence need to be discussed with the patient, like what are the advantages of it and what are the problems they are facing regarding it. Then we need to solve the problems, like many patients, they stay in a remote area and healthcare facilities might not be available there. They might not be able to take an injectable drug. So in those patients, we need to agree to their problem and then find a solution to it, like maybe we can use higher dose of methotrexate and split the dose in the day so that they can manage with the tablet without the injections. So adherence is important, and we need to talk to the patient, have a lengthy discussion regarding this, because this is the finally, adherence is the one thing which ends up giving a good result to the patient. Coming on to the pharmacological part of this D2TRA, suppose a patient fails one biologic, we need to change the biologic to another biologic with a different mechanism of action. And suppose the patient fails that too, in that case, if we are using a third biologic, in that case, the third biologic dose needs to be the maximum dose which has been used in trials, which has been found safe and effective for patients in the trials. So looking for pharmacological treatment options, we have a whole list of biologics which we can use. We have IL-6 inhibitors, the TNF inhibitors, we have the JAK inhibitors. Besides that, combination therapy can be used. We have combination synthetic DMARD combination with biologics. We have their combination with targeted DMARD, which we are using routinely. A combination of biologics with targeted synthetic DMARDs is a very gray area. There is no randomized controlled trial regarding this. There are anecdotal case reports in which people have used, and in special scenarios like complicated diseases like inflammatory myositis, MDA5 dermatomyositis, in which biologics have been combined with tofacitinib, but still it needs to be before starting therapy. It needs a lot of consideration and shared decision between the patient, and we have to assess the risk of infection in this patient before starting therapy. Combination of biologics is strict no at the present time. Recently, immunology has borrowed something from oncology, that is the CAR T-cell therapy. It is one of the future therapy which promises a drug-free remission in patient with autoimmune disease over a long period of time. Basically, what is CAR T-cell therapy? T-cells are taken from the patient, they are expanded, then they are transfected with a vector carrying a CAR gene. So once transfected, the T cell will express the CAR receptor on their surface. These cells are purified and then re-injected into the patient. Once inside the patient, they multiply and they bind to the antigen, the target antigen in the various immune cells, causes their apoptosis, leading to control of the disease activity. And since these are cells, they continue to multiply and they provide persistent control of the disease activity. This was a recent paper from NEJM in which they have studied a series of around 15 patients with difficult to treat autoimmune diseases like SLE, inflammatory myositis, and systemic sclerosis. They found that all of the patients were off immunotherapy, immunosuppressants during the course of CAR T-cell therapy. There were not much safety signals, and the therapy was tolerated well. So this is a very early study, but it might be a game changer in future and provide a solution to all the difficult to treat rheumatoid arthritis patients. There are a few other points which we need to consider in these patients, like comorbidities which impact the quality of life in patients with rheumatoid and cause symptoms like pain, like fibromyalgia and obesity. We need to consider their management also. Then there are diseases, comorbidities which limit the drug use, like patient with hepatitis or a cardiac disease. In these patients, these comorbidities needs to be managed so that we are able to treat these patients well for a rheumatoid. Patients who have a co-infection with hepatitis B or C, they need to be started on antivirals before they are put on biologics. Non-pharmacological treatment is important because it helps in management of fibromyalgia and osteoarthritis and improve the general well-being. Education should be provided to the patient so that they can decide for themselves what is the best treatment option for them and what is the best goal for them. And self-help groups can be helpful in such situations. So this is the algorithm that EULAR have proposed for management of D2T-RA. First of all, we have to find out if the patient satisfies the criteria. Once the patient is satisfied, we need to find out if the patient is having rheumatoid or if there is some other diagnosis which we need to consider. Once we are sure if it is rheumatoid arthritis, then we have to find out is the disease active or not. If we can take help of the ultrasound in this, once we know the disease is active, and then we need to do something about the treatment. First of all, the first thing which we need to evaluate is for drug adherence, because if adherence is not good, then treatment won't work. So if we find some problems in adherence, we need to solve those problems and see if the patient responds to that. If the patient is not responding, then we need to discuss the various treatment options available, including change of biologics, optimizing the drugs, switching from tablet to injectables. Along with that, we can use the non-pharmacological measures for treatment. So we live in India, we need to look about the Indian scenario. So in India, as we know, most of the patients pay from their pocket and there is limited healthcare coverage. And second is the healthcare insurance does not cover OPD treatment, and many of our diseases are not covered under insurance. So that is a big problem, and hence we have to devise our own methods, because whatever data comes from the West, that is insurance-based system, not an Indian system. So financial issues are one of the most important limiting factor in patients who are being treated for difficult to treat rheumatoid arthritis. Then conviction for treatment, many a time patient once improves, they tend to leave the treatment. That causes, there are various immunological phenomena associated with delayed treatment, which ends up giving a patient a diagnosis of difficult to treat rheumatoid arthritis. Then access to healthcare is important, because remote areas, they don't have access. Availability of rheumatologists is a concern, as such is a concern worldwide. In India also the same situation is there. Nutrition is important, because many a times, and because of poor nutrition, our patients, they are not able to, they are not being able to be given full doses of their DMARDs, and their other comorbidities like anemia, which may be cause of pain. Then complementary, the trust in the complementary alternative medicine is sometimes a problem, especially at the hands of unqualified practitioners, because the quest for a treatment which can cure their disease almost always limits our follow-up, and they tend to end up with the treatments which are not good for the health. And we end up having a patient with 10 years rheumatoid arthritis with a damaged joint, which we cannot do about anything. So what are the options we have considering our scenario? We have an option of a low dose rituximab. We can space our biologics. We can use injectable DMARDs, and we can optimize the doses of medicine which are being used. This was a paper from South, the Kerala group, Dr. Shinoy. They used low dose rituximab in patients with refractory rheumatoid as an add-on therapy to the existing therapy. They used only 500 mg the rituximab, and they found that the patient had good response, and their B-cell depletion was also better, good. So this needs to be evaluated further, but it's a good option in patient with difficult to treat RA, and practically we have used this regimen and it works sometimes. So this is and they found that it is very cost effective compared to the 2-gram dose which has been recommended by the ACR and EULAR. Then the same group, they did another pilot study of 100 milligram rituximab, single dose, and they found that the depletion, 80% depletion was there in B cells, and the DAS28 score was also improved during the 24 weeks of follow-up. So my take-home message is, difficult to treat rheumatoid is difficult for the patient as well as the treating doctor. Socioeconomic status is one of the major contributors for it. Treatment non-adherence is the fundamental issue which needs to be sorted out and needs to be addressed in the best possible way. Comorbidities need to be managed well so that we can optimize therapy. Treatment goals need to be discussed with the patient before changing changing the medications. And non-pharmacological measures can be helpful in managing comorbidities like obesity, fibromyalgia, and osteoarthritis, which might not respond to drug therapy. Thank you.
Excellent talk. So there's just one question. I, being probably the only non-medicine specialist, being a radiologist, so how frequently do you resort to imaging in patients of rheumatoid arthritis for MSK involvement?
Usually, ma'am, musculoskeletal involvement for X-ray we usually do it if the patient is having pain which is not responding to treatment, like especially knee joint. Patient is not able to walk because of that, and we are not sure if it is disease activity. In that case, X-ray might give just the picture that the patient is having a damaged joint, the cartilage is gone. There is no point escalating the drug, rather than send the patient for a physiotherapy or probably a replacement. Second is most of our patients, they have been taking steroids for a long time, either from a direct store or some unqualified practitioner, and they end up with a hip pain which is due to avascular necrosis many times. So any patient who presents with a hip pain with rheumatoid arthritis or a restricted movement, or if the patient is not able to walk, in that case, and the knees are okay, in that case hip X-ray is important. Then third, another common problem is patient who has been on steroid for a long time, many a time we have seen they present with a simple back pain, and that back pain is probably because of a fractured vertebra, and later during workup or clinical examination we find that the patient is actually having rheumatoid arthritis and the back pain is only because of the side effects of the drug. So at that time we get a radiology done for a spine.
Your experience on secondary osteoarthritis developing in large joint rheumatoid arthritis?
Very common. Ma'am, one clinical thing which we commonly see in, patients have been having arthritis for around 10 years. So they started developing knee pain. For that they took treatment from a local doctor. So initially the patient only had synovitis which used to respond to their treatment. They forgot, they never knew that they had a hand joint involvement because they used to take drugs from a local doctor and from a guy from a shop that would have steroids. So after 10 years when the joint is gone, that time the patient comes to us with a knee pain. And at the look of it, you'll always say, ki, oh, this is knee osteoarthritis, nothing else. But when you go into detailed history for a long time, get the investigations done, we find many a time this patient actually had a rheumatoid arthritis. And when you give them some treatment, they improve. And then you again, in the second or third visit, when we ask them, ki, did you have any hand pain 5 years back or 10 years back? They might just come up with a history. At the starting I had some pain and then I took medicine and since then I have no pain. So large joint, many a time, most of the patients, they present with large joint damage also.
Thank you, Ankit, for a lucid talk. So, is there any way we can predict that a particular patient coming to you in the OPD can be a difficult to treat RA?
Sir, people have looked at that. Many studies have been done. There is nothing conclusive has come out, but a few distinct points which they tend to be more prominent is, if the patient is having very high joint count at the onset, very severe disease activity at the onset, high DAS28 scores, patient not responding to initial burst of steroids and high dose and DMARDs, and then again poor socioeconomic data, that is one of the predictors who develop difficult to treat rheumatoid arthritis. So there is nothing conclusive as such, but from experience and from whatever conclusion they could draw from the limited studies, these are the common factors which we see. Seropositive rheumatoid also is more chances to be difficult to treat.
Yeah. So suppose somebody has these risk factors. So what is your take on upfront usage of combination DMARDs versus using anti-TNF or other targeted synthetic DMARDs right away upfront?
Sir, upfront still patient, these indicators are only we can debate them, but they are not conclusive. There is no recommendation, no clinical guideline regarding upfront use of TNF inhibitors or upfront use of targeted synthetic DMARDs in patient with arthritis with severe disease. So upfront, definitely combination therapy has to be started, conventional DMARD therapy. Another point is the cost of therapy also increases with any of the other drugs. So that point taken, initially we start that. But if the patient, in the second or third visit at 3 months, we see if the patient is, DAS28 has not reduced much, the tender joint count has not reduced much, the steroid dose patient, still we are giving 10 milligram omnacotil to control the disease. Daily she says she has to take non-steroidals. Those are indicators in which I usually prefer to either switch to a biologic or preferably a targeted synthetic DMARD like a tofacitinib. So those patients, they tend advantage, I feel, this is not from a guideline, but from clinical experience, what we feel, once we start tofacitinib a little early in these patients, the cumulative steroid dose we are able to reduce, and many patients who have been treated this way, we have been able to get them off steroid within 6 weeks, whom we were able to reduce from 15 to 10 in 3 months. They tended to have come off steroid within 6 weeks. After that, then it's a question becomes, do we want to continue all the 3 drugs together for a long time? So that is a very gray area that individual clinical judgment has to be used. What I personally feel we can try and reduce the doses gradually, every 3 monthly to 4 monthly after clinical assessment, and see how it goes. If the patient flares, then definitely he needs that much. If does not flare, we can gradually withdraw. So that is spacing, and we can do that.
So the other thing we look at in difficult to treat RA is patients with fibromyalgia. The disease is totally controlled, but the patient has pain all the time. pain all over the body. So that's something which you have discussed already, which needs to be taken care of. And one more thing would be hypothyroidism, which can be associated, which needs to be taken. Any questions from the audience?
Hello, good afternoon, sir. I have a question. So, sir, in patients, like we see in OPDs, some patients do come with very few tender and swollen joints, like maybe one tender joint, one swollen joint, and a mild elevation in ESR and CRP. So, the score comes to be in moderate range. So, in those cases, patient is on very low dose glucocorticoid, like 2.5 mg with a combination DMARD. So, in those cases, do we have option for increasing the DMARDs or any biological? So whether to call that patient as a difficult to treat RA and to increase, that patient is happy with a low dose glucocorticoids. So should we increase at that point of time our DMARDs to achieve a remission? So what should be the clinical practice?
So the guideline says low dose bridge steroids, which has to be stopped as soon as possible. So if the patient is already still continuing 2.5 milligram steroid, and as the madam pointed out, even 2.5 is not good for the patient. So the target is to stop the steroid completely. So if the patient is not being able to stop from the steroid, then we have to escalate the DMARD dose. And the definition for difficult to treat rheumatoid arthritis is patient has to be treated with at least 2 conventional DMARD in their optimum doses for adequate amount of time. And if the patient fails that, then we have to treat the patient with biologic. And finally, if if with that also patient is not responding, we can continue steroids up till 7.5. If it is more than 7.5, then we should switch the patient to biologics. But this is the guideline. But in clinical practice, personally, I do not like to continue steroid. If the patient is needing only 2.5 milligram of steroid, I'll continue to escalate till the patient is off steroid.
Okay, thank you, sir. Sir, one more question, sir. Like, sir, patient is already on long-standing rheumatoid arthritis, on long-standing methotrexate with Lefno. So, patient was in remission, but however, he has come with mild deranged renal liver functions, and we have ruled out it is persistent, and we have ruled out other causes of all elevation of ALT and AST, and we have done a fibroscan also, and that is also showing mild moderate amount of liver fibrosis. So and patient now is in flare, so what should be the treatment options at that point of time?
Rituximab.
Okay, thank you, sir.
So regarding your first question, Pratibha, single joint, you can give an intra-articular.
Yes, sir.
That would help the patient actually. Any other questions? So thank you, Dr. Ankit. Thank you for a wonderful session. Thank you.
Thank you so much, sir, for such an insightful session. Now I would like to request our chairpersons to felicitate Dr. Ankit Jain. I would like to request Professor Ravikant sir to felicitate Dr. Surbhi Vyas ma'am. I would like to request Dr. Mukesh Berwa sir to felicitate Dr. V.S. Pai sir. Heading to the next session, it is my pleasure to invite Dr. Vikas Agarwal sir, Professor, Department of Rheumatology and Clinical Immunology, SGPGIMS Lucknow, for the enlightening lecture on skin and lung involvement in systemic sclerosis. Sir will be joining us via online platform. I would also like to invite chairpersons for this session, Dr. Girish Sindhwani sir, Professor and Head Department of Pulmonary Medicine and Critical Care, AIIMS Rishikesh, and Dr. Riti Bhatia ma'am, Associate Professor, Department of Dermatology, AIIMS Rishikesh. Ma'am would also be joining via online platform.
So, we have the online mode ready?
Yes, sir.
Oh, Dr. Vikas, can you hear us?
Yes, very much.
Yeah, thank you. And Dr. Riti is also? She is yet to join. Yeah, so next session, this session is on systemic sclerosis involving the lung and skin, and it's going to be very interesting to see how do we monitor and manage lung involvement. That is my area of interest. So without taking much of time, I would request Dr. Vikas to proceed with this talk.
Actually, I'm trying to share, but I don't know whether I can share my screen. Just a minute. Yeah, Abhishek. Yes. Yeah, I have clicked that. It's showing Chrome tab window and the entire screen. Yeah, but share is not coming actually. It is disabled. Just a minute. Let me see. It's not working. Yeah. Yes, yeah, yeah. Please do, please do. Yes, please do. Thank you. I'm sorry. Should I start? Hello. Yeah.
Yes, Dr.
Can you
Vikas,
see?
please start.
Yeah, I
It's
can see.
visible.
So who will be forwarding my slides? Oh, okay, thank you. Very good evening to all of you, and my apologies for the technical glitch. I couldn't upload my slide on the screen, so I have to get it uploaded from AIIMS Rishikesh only. I thank Dr. Pai and Dr. Ravikant for their kind invitation, and my again apologies for not being able to be there physically because of cancellation of my leaves due to neck inspection at SGPGI, which is going right now. May I have the next slide, please? Disclosures are none. Next slide, please. Yeah. So systemic sclerosis is a rare chronic autoimmune disease which is characterized by endothelial dysfunction manifesting in form of vasculopathy, which clinically present as Raynaud's phenomenon or digital ulcers or scleroderma renal crisis, and followed by widespread fibrosis affecting skin as well as various internal organs and various autoantibodies. It's a rare disease, and so there are a lot of genetic predispositions well known, which actually predisposes an individual towards systemic sclerosis. Next slide, please. Before we embark on the pathophysiological aspect of or clinical manifestations of systemic sclerosis, one need to understand the pathophysiology of the disease. In very early phase, patient may present with puffy fingers only, not even Raynaud's phenomenon. And this actually represents a stage of capillary leakiness, which occurs because in genetically susceptible individuals, when they are exposed to some kind of an environmental stimuli in form of a viral infection or some kind of exposure to chemical or oxidative stress, the capillaries become leaky due to endothelial damage. Once capillaries become leaky, there is endothelial cell activation, which leads to activation of all the cells of innate as well as adaptive immune system. And one needs to concentrate especially on typically type 2 helper cells, M2 macrophages, B cells, and dendritic cells. Next slide, please. Okay, I didn't see any change in the slide. Can you go to the next slide? Okay, just before that, first, previous slide. Yeah. So what happens? Once there is an immune dysfunction, lot of type 1 interferons, interleukin 6, and transforming growth factor beta are secreted. Now, what happens because under the influence of these, there is a lot of endothelial cell undergoing a process called as endothelial to mesenchymal transitions. Also, if there are any epithelial cells in the vicinity, they also undergo a process of epithelial to mesenchymal transition. So, and lot of resident fibroblasts which were quiescent initially because of the stimulus now becomes activated and gets converted into a myofibroblast. Now, myofibroblast is a key cell which causes the manifestations in systemic sclerosis in form of widespread fibrosis. And it is the main reason why you tend to have skin fibrosis, lung fibrosis, cardiac fibrosis, or fibrosis in the intestine or the kidneys. Next slide, please. So if we really see, inflammatory conditions are the backbone of the pathophysiology of systemic sclerosis. So one should be able to control the manifestations if we can have some kind of a immunosuppressive or anti-inflammatory therapy available. So let's look at the evidences which are available in the literature, whether immunosuppressive drugs help in scleroderma or not. Next slide, please. Next slide, please. Yeah. So this is a observation study on 326 patients across multiple centers in Europe and North America, where it was realized that patients who were receiving methotrexate, mycophenolate, or cyclophosphamide, as compared to the patients who were not receiving any kind of immunosuppression, then there was some kind of benefit in the skin scores of patients who were receiving immunosuppressants. Just a food for thought that yes, probably immunosuppressive therapy is effective in preventing fibrosis in the skin of systemic sclerosis patients. Next slide, please. Then comes this landmark study in 2006 in New England Journal, Scleroderma Lung Study. Here, authors have actually targeted the interstitial lung disease of systemic sclerosis by using cyclophosphamide and compared it with the placebo arm. In this particular study, it was realized that patients who were receiving cyclophosphamide, they had less fall in forced vital capacity percentage predicted decline as compared to those who were receiving only placebo. Next slide, please. So here you can see the fall in the patients who were receiving cyclophosphamide was only around 1%, whereas the fall in the placebo arm was 2.6% predicted FVC, clearly showing that the fall there is some kind of effect of cyclophosphamide was there as compared to the placebo arm. Next slide. So not only that, there was improvement in almost 50% of the patients in the cyclophosphamide arm as compared to only a quarter of patients in the placebo arm. Whereas only 50% patients worsened in the cyclophosphamide arm, whereas 75%, almost 75% patients worsened in the placebo arm. Next slide, please. So clearly showing that though cyclophosphamide has a significant benefit as compared to the placebo, but the effect was modest. And not only that, it also had an improvement in the skin score as compared to the placebo arm. But one needs to consider the risk of serious side effects which was there with the usage of cyclophosphamide. Next slide, please. So there comes the next study, which was scleroderma lung study part 2, where mycophenolate was compared with the cyclophosphamide, thinking that mycophenolate will be equally efficacious but less toxic as compared to the cyclophosphamide. And this hypothesis was proven right. Next slide, please. When the results of this study were seen, that the effect was almost similar and the toxicity was much less. So mycophenolate becomes a sort of a better substitute for treating interstitial lung disease in systemic sclerosis as compared to the cyclophosphamide. Next slide, please. Then came this very landmark study where from the group of Dr. Parasar Ghosh at IPGMR Kolkata, they compared head-to-head cyclophosphamide versus rituximab in patients with systemic sclerosis with interstitial lung disease. And next slide, please. And it was realized that patients who were receiving rituximab, they had a better improvement in forced vital capacity percentage predicted as compared to the cyclophosphamide. And not only that, the 6-minute walk distance was also better in patients who were receiving rituximab as compared to the cyclophosphamide. Next slide. So they concluded that rituximab, previous slide, yeah, rituximab is a safe and effective alternative to cyclophosphamide in primary therapy of skin and lung manifestations of systemic sclerosis. Next slide, please. Then came this another study, tocilizumab in systemic sclerosis with the name of focused trial. In this particular trial, the primary aim of the study was to see whether tocilizumab improves the skin score, modified Rodnan skin score at week 48. And the secondary endpoints were other parameters like improvement in forced vital capacity percentage predicted and others. So let's look at the data of this study. Next slide. It was realized that the modified Rodnan skin score was no different between the tocilizumab arm and the placebo arm. However, patients receiving tocilizumab had a better improvement in the lung functions, stabilization of the lung function. Very few patients, they worsened in the tocilizumab arm as compared to the placebo arm. So it was concluded from this study. Next slide. Though the primary endpoint was not met, however, the secondary endpoint, that is forced vital capacity percentage predicted, suggests stabilization of the lung functions and some benefit in patients who are having an inflammatory background of disease at baseline when they were initiated on tocilizumab. Next slide, please. Yeah, but one need to consider the risk of sepsis in patients, Indian patients, because our environment is not that healthy as of West. And whatever little experience we have at SGPGI of usage of tocilizumab in patients with systemic sclerosis and other conditions, we have found that sepsis remains a major concern. And most of the patients, they do not mount any kind of septic response, clinical septic response in form of temperature or anything. They just suddenly came with either breathlessness or hypotension, which is very life-threatening at times. Next slide, please. Then this came a very important study, census, using nintedanib in patients with interstitial lung disease of systemic sclerosis. Nintedanib is a small molecule tyrosine kinase inhibitor which affects PDGFR, FGFR, and other tyrosine kinases. And it was initially approved for treatment of idiopathic lung fibrosis. But when it was applied to patients with systemic sclerosis, ILD, or patients of rheumatoid arthritis with ILD, it was seen that there was some benefit with that. So with that, this study was aimed, and it was realized that the annual rate of decline in the forced vital capacity was lower in patients with nintedanib as compared to the placebo. though the results were not that great, but still FDA approved this molecule for the treatment of ILD of systemic sclerosis. Next slide, please. Then this another study was there where people have used abatacept in patients with systemic sclerosis. Next slide. And again, the primary endpoint was actually modified Rodnan skin score improvement, and the secondary endpoints were others like physician global assessment or quality of life or force vital capacity percentage predicted improvement. Next slide. So it was realized that patients who were actually having not much benefit was seen, but as far as skin scores are concerned, however, there was some improvement in post-hoc analysis when CRIS scores were applied. Next slide. So it was concluded that the abatacept does not have much influence on the improvement in the skin scores, but it does have some improvement in patients who have got inflammatory type of phenotype. Next slide. So most of these studies were actually concentrating on the lung, which is a major manifestation and a major cause of morbidity and mortality in patients with systemic sclerosis. But this molecule, romilkimab, which is a bispecific immunoglobulin G4, and it neutralizes both TGF-beta and IL-13, IL-4 and IL-13, was tried out in patients with systemic sclerosis, and the primary endpoint was improvement in modified Rodnan skin score. And this is a phase 2 trial data, and as can be seen that it significantly has improvement in modified Rodnan skin score in patients who had received romilkimab. So it was concluded from this study. Next slide. That it statistically significantly improve skin scores in patients with systemic sclerosis as compared to the placebo. Next slide, please. This is a sort of a SCOT trial and ESTIS trial where myeloablative autologous stem cell transplantation has been carried out for severe systemic sclerosis patients. And the primary endpoint was global rank composite score, which is a paired kind of a complex scoring system. But one can just understand the scores which are in minus suggest poor scores, whereas scores which are in plus, they showed improvement. Next slide, please. So it was compared autologous BMT with cyclophosphamide. Cyclophosphamide was given monthly 750 milligram per meter square for 12 months, and autologous transplantation was carried out at baseline only. As can be seen that patients who had received autologous stem cell transplantation, they did very well as compared to cyclophosphamide arm. As far as mortality is concerned, there was 11 deaths in cyclophosphamide arm, whereas 6 in the autologous BMT, and the scores in the skin, the lung, and other parameters improved drastically in patients who have received the autologous BMT. Next slide, please. So it was concluded that at 54 months, almost 4.5 years, the myeloablative autologous bone marrow transplant significantly improves outcome in patients with systemic sclerosis.
Dr. Bukas, you are not audible.
Yeah, Abhishek, the slides are not moving. Okay, can you move to the next slide, please? Yeah, next slide, please. Yeah, so very recently in July 24, EULAR guidelines have been published, and they also recommend usage of either nintedanib, mycophenolate, rituximab, or cyclophosphamide for patients with interstitial lung disease. And also for skin fibrosis, not many drugs have been recommended, but there was some improvement which was seen in earlier trials with rituximab, mycophenolate, or tocilizumab. So these molecules can be tried out in patients who are having progressive, rapidly progressive skin fibrosis. Am I exceeding my time limit, or should I call it a day here, or should I continue?
Sir, please continue your presentation for another 5 minutes.
Okay. Can we move to the next slide, please? Yeah, so this was a study which we have initiated in 2008 on tadalafil, which is a phosphodiesterase 5 inhibitor for treating Raynaud's phenomenon, difficult to treat Raynaud's phenomenon in systemic sclerosis patients. Next slide. We realized that while this trial was effective for resolving the manifestations of Raynaud's phenomenon, but in addition, we also saw some additional improvements like, next slide, improvement in skin scores of various patients and improvement in the hand functions, suggesting that there may be some kind of antifibrotic action. Next slide. So Mohit is my first PhD student. He did this study. He cultured fibroblasts from the skin of systemic sclerosis patients. Next slide, please. And then treated these fibroblasts with various combinations of phosphodiesterase inhibitors. He used 3 phosphodiesterase inhibitors, sildenafil, zaplinase, and tadalafil. All had shown that as compared to the that black bar or that black column, which was basically fibroblasts treated with TJ beta, which is pro-fibrotic, all the other bars are showing a reduction. They all are actually in various dosage and combinations of PD5 inhibitors, clearly establishing the fact that PD5 inhibitors as a family or a genre of class has an antifibrotic effect in fibroblasts treated with TJ beta. Next slide, please. The data, that was a gene mRNA expression, and here we are showing the protein SMAD and the phosphorylated ERK pathways, which is representing both canonical as well as non-canonical pathways, which are the predominant pathways stimulated by TJ beta, and all are showing a good response with phosphodiesterase 5 inhibitors. Next slide. We did another study with Sakir, who was my DM student at that time, and he took 24 patients of systemic sclerosis who were tadalafil naive. 12 received, in addition to standard of care, tadalafil, and 12 continued to receive routine care like calcium channel blockers or ARBs for treating Raynaud's phenomenon and other symptomatic treatment. He did skin biopsies at baseline at 6 months later, and we look at the expression of 4 gene biomarkers in the skin biopsies. Next slide. So both the groups were comparable. Next slide. We can see that patients who had received routine care plus the image on the right side is showing that they also received tadalafil, and the skin scores clinically they reduced from 22 to 13, whereas in the placebo arm or the routine care where they didn't receive any tadalafil, the skin scores increased from 15 to 19 at 6 months. Next slide. Skin scores dramatically reduced by more than 5 in 10 patients in the tadalafil arm, whereas only 3 patients showed improvement in the routine care arm. Next slide. And when we looked at these 4 gene biomarkers like thrombospondin 1, SIGLEC1, interferon inducible gene 44, and cartilage oligomatrix protein, it was seen clearly that patients who had received tadalafil had shown a better improvement, reduction in these genes as compared to the ones who were receiving standard of care. And there they have shown that these proteins were increasing in nature. their gene expression was increasing as compared to the ones who had received tadalafil. Next slide. So it was concluded that phosphodiesterase 5 inhibitors have antifibrotic effect in systemic sclerosis. They block not only both canonical and non-canonical pathway, but in a clinical trial also they showed improvement, and the 4 gene biomarkers improved significantly. Next slide. So the take-home message for my presentation is that there is a complex interplay between vasculopathy, inflammation, and fibrosis in systemic sclerosis. Some of the fibrotic manifestations can be countered by using anti-inflammatory or immunosuppressive agents. However, benefits are modest at the best as of today. But if you can identify vasculopathy early and can treat it adequately, then the chances of having improvement in fibrosis later on can also be there. And as of now, we generally don't combine, but there is a need for combination of immunosuppressive drugs with antifibrotic drugs to treat patients with systemic sclerosis who have got widespread fibrosis. Next slide, please. So this is my acknowledgement of all the my collaborators who collaborated with me in the clinical trial on Raynaud's phenomenon. Next slide. And these are my laboratory students who had actually done various work, especially Mohit, who established the primary fibroblast cultures in my lab, and based on that only we have actually been able to have some idea about understanding of the fibroblastic reactions in patients with systemic sclerosis and other fibrotic conditions. Thank you. If there are any comments, questions and suggestions, everybody is most welcome.
So thank you, Dr. Vikas, for a very nice description of lung and skin involvement, and with some evidence backup of how to manage lung and skin involvement. Any pressing questions? If there are no questions, we have another activity in the hall going on. So we'll thank Dr. Vikas again for this presentation, and we conclude this session. Thank you.
Thank you so much, sir, for joining us. Up next, we have an interesting session on imaging in rheumatology. I would like to request Dr. Surbhi Vyas, ma'am. Okay. For the next session, I would like to hand over the mic to Dr.
First of all, like to thank the organizing committee, especially Dr. Ravikant sir, for giving this opportunity to celebrate International Day of Radiology here. I thank our Honorable Director ma'am, Dean ma'am, Handu sir, DDA, and entire faculty and other senior residents, our JRs, technicians for joining us for International Day of Radiology. 1895 is the day when Röntgen discovered X-ray. And every year on 8 November, we celebrate the International Day of Radiology. So we will be celebrating International Day of Radiology. I request Dr. Anjum ma'am to please with our Director ma'am and Dean ma'am and DDA and Handu sir to please cut the cake for International Day of Radiology. Dr. Ravikant sir, Dr. Surbhi, Dr. Namrata, please join. And our department faculty also. Please come for cake cutting.
Thank you so much, everyone. For the next session on imaging and rheumatology, I would like to invite Dr. Surbhi Vyas ma'am, Professor, Department of Radiology, AIIMS, New Delhi. I would also request the chairpersons to join us on stage. Dr. Anjum Sayyed ma'am, Professor and Head, Department of Radiology, AIIMS, Rishikesh, and Dr. Sonal Saran ma'am, Associate Professor, Department of Radiology, AIIMS, Rishikesh.
So the topic that I've been given is imaging in rheumatology. But before that, I would like to express my sincere thanks to all the organizers for such a wonderful gathering, a dual gathering plus a celebration on International Day of Radiology. My heartfelt congratulations to all in the Department of Radiodiagnosis at AIIMS Rishikesh. So encompassing the entire gamut of conditions that we see in rheumatology and its imaging would not be possible, but we would try and at least encompass the MSK manifestations and its imaging during this talk. So the most important manifestation that comes with rheumatological disorders is arthritis, and when we look at the classification of arthritis, inflammatory arthritis forms the bulk of abnormalities that we have in our clinical practice. Apart from that, crystal deposition disease, primary synovial pathologies like pigmented villonodular synovitis and infected arthritis are the other conditions. In this talk, we would restrict ourselves to inflammatory arthritis, crystal deposition disease and infective arthritis, and we would see cases and snippets from our day-to-day practice. When it comes to what imaging modalities are being used, we have 4 basic imaging modalities in the form of radiography, ultrasonography, CT and MRI, each having its own pros and cons. Radiography is the first and the foremost that is used as a baseline investigation, but it has low sensitivity. It is said that at least 40% loss of bone has to be done before we can see the manifestations as osteopenia in a radiograph, or a significant amount of erosive disease has occurred before it can be seen on radiography. So it has a low sensitivity. However, there are features like soft tissue thickening, effusion, rarefaction of the bone and erosions. These are the ones which can be seen in established cases. Ultrasonography is a very important modality. The fact that it is accessible to all, it has no radiation, it can be repeatedly followed up, makes it a very versatile and attractive investigative modality. Apart from that, the fact that we can do joint injections, we can do aspirations and various other guided procedures also makes it a very versatile investigation. CT is a cross-sectional modality, and it is the modality of choice when it comes to diagnosis of erosions and primary bony pathologies, and it has a specially important role when it comes to diagnosis of crystal deposition disease by means of dual energy CT. MRI, by its excellent soft tissue resolution and the ability to diagnose marrow edema, which is most of the times the first and the only manifestation of arthritis, makes it the gold standard of evaluation of arthritis. So overall, the indications of imaging are to help in establishing a specific diagnosis, determining the extent of disease, detecting complications like ankylosis, abscess formation, pathological fractures, sinus formation, progression and response to therapy, and finally guiding interventional procedures. So let us start with the first subgroup of abnormalities, which is the small joint polyarthritis. Let us have a case scenario. This is a 32-year-old female with painful hands, and what we see here is a relatively normal looking radiograph. There are no signs of arthritis. There is no soft tissue thickening, there is no osteopenia, there are no erosive changes, and the joint space is maintained. But when we look at the corresponding MRI, we can appreciate an area of focal marrow edema in the head of the third metacarpal, which is seen as this hyper intense or bright spot in the MRI image. This is actually corresponding to an area of erosion. In addition, there are other small erosions which can be seen in the joints of the small joints of the wrist. So this is a typical example of an early rheumatoid arthritis where radiograph is absolutely normal. The patient comes with pain and the MRI can reveal abnormalities like this. The other manifestations that can be seen in RA are tendinopathies and deformities, which are more seen in the advanced disease like this. So here is a radiograph which shows extensive changes not only in the wrist joints of both the hands but also in the metacarpophalangeal and the proximal interphalangeal joints. So this is the typical distribution. Apart from that, the ulnar styloid process and the radioulnar, the distal radioulnar joints are also the affected ones. The corresponding MRI shows extensive synovial thickening. Apart from that, the enhancement and heterogeneity of the synovial proliferation with extensive changes of marrow edema makes it a typical form of advanced manifestations. There are other deformities that can be seen in rheumatoid arthritis, which are usually seen late in the disease process. These are ulnar deviations and the ulnar dift, the hitchhiker's thumb, the swan neck and the boutonniere deformity. The similar kind of deformities in the form of dorsal subluxation of the metatarsophalangeal joint as well as the fibular displacement at the MTP joints are other manifestations that can be seen in the lower limb. Not only the small joints but also the large joints can be involved. So we can have erosions in the odontoid process. There can be atlantoaxial dislocation in the form of increased predental distance. There can be global changes in the form of reduction of joint space as well as erosions in the knee, the hip. MRI in this scenario helps in identification of other complications. So here is an example of rice body formation with extensive synovial fluid and bursitis in the shoulder joint. The other manifestations in the form of cervicomedullary compression because of disease at the odontoid process and the CV junction can also be very well seen on the MRI. Ultrasound in RA has a very important role because in day-to-day clinical practice as well as for disease progression, it can be done in the OPD setting. The features that can be seen on RA are synovial proliferation. So now synovial proliferation, a normal synovium, it only measures between 1 to 2 millimeters. However, a proliferative synovium with presence of vascularity are the hallmark features of arthritis in rheumatoid arthritis. There can be erosions which have to be seen in two orientations to ensure that it is actually a true erosion and not a pseudo erosion. Apart from the bony manifestations, we can see the proliferation of synovium and thickening of the tendon sheath in tendinopathies. There can be just simple fluid with presence of synovial thickening and it shows vascularity when we put a color box. The presence or absence of vascularity also helps in identification of activity of disease in addition to just the thickness. Here is another example of an inflammatory arthritis where we have a 48-year-old male with painful swelling of hand and feet and stiffness of back. Now the abnormality that can be seen in the radiograph is different from what we saw in rheumatoid arthritis. It is the distal interphalangeal joint which is involved and what we have is the pencil and cup deformity. We can clearly see that the bony density is maintained. And because of the back pain, the patient underwent MRI of the sacroiliac joints and we can see involvement of the right sacroiliac joint suggestive of sacroiliitis. So this is an example of psoriatic arthritis where the classical features are marginal erosions and pencil and cup deformity. The distribution is different from rheumatoid arthritis because here the PIP and the DIP joints are involved. Apart from that, the ulnar styloid process as well as the interphalangeal joint of the first digit is also involved. The other features are fuzzy bony proliferation, ankylosis, periostitis, dactylitis, which can give rise to a sausage disease, sausage digits. Acroosteolysis can also be seen. In more advanced cases, arthritis mutilans and osteolysis can be seen. There can be asymmetrical sacroiliitis, as we can see in the index case, but it usually progresses to a symmetric disease. The other abnormality in this group is reactive arthritis, where we have a triad of arthritis, urethritis and conjunctivitis. The hallmark feature here is enthesitis. So it is seen as abnormal bony proliferation and irregularity at the site of the enthesial attachments. So here we have the attachment of the tendoachilles. Here we can see on the MRI area of marrow edema as well as cortical irregularity at the site of insertion of the aponeurosis. So severity and frequency wise, when we say, the lower extremities are much more commonly involved than the upper extremities, and in the lower extremities the small joints of foot, the calcaneus, the ankle and the knee are involved commonly. The disease can be initially unilateral and asymmetrical, but as the disease progresses, it usually goes to form bilateral symmetrical involvement. The next group is the crystal arthritis. Here is the typical example of crystal arthritis, that is gout. What we see here is punched out large juxta-articular erosions with an overhanging margin, and these are typically described as rat bite erosions. These are because of urate crystal deposition. These are negative birefringent crystals. In addition, there can be joint effusion. The important thing to understand, despite the such large erosions, the density of the bone is preserved and the joint space is preserved. There can be large joint involvement also, like atypical involvement in the form of sacroiliac as well as large joint involvement. Ultrasound has a very important role because it shows features like irregular cartilage, the fuzzy outline of the cartilage, the double contour sign of the cartilage, the soft tissue as well as the bursal thickening, and the hyperechoic foci, which are seen at the sites of classical involvement. And when the patient presents with swelling, an ultrasound probe can be put at the same location, and we can most of the times differentiate these hyperechoic tophi in a case of doubt. CT in the form of dual energy CT is a very useful adjunct because it gives us an idea of the overall involvement of the disease as well as the disease burden. Here color coded maps are generated which can show these green colored urate deposition crystals which are seen as these large boulder shaped areas in the lower limb as well as in the large joints of the hip and the knee as well as in the sacroiliac joint, and the normal CT image shows these areas of erosion. So this is the typical areas of involvement in a gouty arthritis. A similar disease is pseudo gout, which is because of the calcium pyrophosphate deposition disease, where the involvement of the upper limb and knee is common. In the upper limb, it is the metacarpophalangeal joints as well as the wrist joint which are involved, and typical manifestations are calcification of the TFCC, the calcification of the intraosseous membrane, as well as chondrocalcinosis that can be seen in the knee. So these are the typical manifestations. So from small joint, we go to the large joint, that is the axial skeleton. In axial arthropathy, the commonest manifestations here are like sacroiliitis because of inflammatory bowel disease related, which is characterized by bilateral disease. Again, it can be initially unilateral, and the disease usually starts with just simple marrow edema, and it progresses with erosions and fluid within the joint, which can cause a widening of the joint space, and later we can have sclerosis and ankylosis as can be seen in this case. Here is another example of an axial spondyloarthropathy, which is a 50-year-old male, known spondyloarthropathy. Typical manifestations, anybody can diagnose this as ankylosing spondylitis. We have the typical bamboo-like spine, squaring of vertebral bodies, the dagger sign of the interspinous ligaments. In addition, we have Anderson's lesion in the spine also. So this is a typical manifestation of ankylosing spondylitis. In the sacroiliac joint, there is usually a symmetrical sacroiliitis with erosions and sclerosis. In the spine, there can be shiny corner signs in early disease, which manifests as the MRI findings of hyperintensity at the end plates. Spondylodiscitis can give rise to the Anderson lesion. And in addition, we need to remember that the costovertebral and the facetal joint involvement are the ones which most of the times may not be seen in radiographs, but can be seen very well in MR or CT if and when done. We can also see the absolute sclerosis and ankylosis as can be seen in this case. So these are the typical manifestation of ankylosing spondylitis. MRI is definitely superior to radiographs and CT because it can help in early diagnosis. Why? Because it shows these manifestations of marrow edema which can be seen in the early phases as well as the complications like Anderson's disease. The next subgroup is the infective arthritis. Let us look at an example. Here we have a 22-year-old male with a high-grade fever with swelling at the elbow. According to the clinical history and the local signs, we know that this is an infected arthritis, especially when there is no prior history of inflammatory arthritis. On the radiograph, we may not see bony erosions or periosteal reaction in the early phases. What we can just see is the moved fat pad. So the fat pad is moved away from the joint, both anterior and the posterior fat pads. But when we do an ultrasound, we can see this large area of fluid accumulation in the synovial capsule, and we can appreciate these areas of vascularity. So this is an example of pyogenic arthritis. Here in the early stage, the only manifestation is just a simple joint effusion, which later progresses to cartilage destruction, which can be seen better on the MRI. There can be subchondral bone destruction as well as intraosseous abscess formation, which are seen as these hyperintense areas peripherally enhancing with central non-enhancing areas. So these are typical appearance of intraosseous abscess. There is usually a thick, shaggy kind of an enhancement, which later progresses to a frank necrosis and lysis of the bone. This can be compared with this scan, which is of a 48-year-old male who has come with pain and swelling of the left hand. And what we see, this extensive area of destruction with multiple areas showing synovial proliferation and edema, which is involving the skin and subcutaneous tissue as well. This is a typical example of a tubercular arthritis, where in the early disease we can see osteopenia and irregular erosions and effusions which lead to a widening of the joint space, as can be seen here. As the disease progresses, the joint becomes disrupted and we have subluxation and dislocation, and eventually it progresses to progressive ankylosis. CT is helpful because it shows the extent of involvement, and MRI, as can be seen in the next few images, show involvement. The CT and MRI show the extent of collections as well as bony destruction. The MRI of large joints can also help in identification of extent of involvement. So here we have an example of mild changes of tubercular involvement of the knee. We have just this shaggy enhancement of the synovium in the knee joint, and this is an example of a more extensive disease in the form of extensive marrow edema, intraosseous abscesses, enlarged lymph nodes, as well as this synovial proliferation and fluid in a case of tuberculosis of the large joint. In the spine, there can be abnormalities of and deformities of the orientation. So they can be gibbous deformity, they can be vertebra plana, there are thin soft tissue or thin walled collection. These are typical examples that we see in our day-to-day practice of a long segment involvement of the spine, which is the classical manifestation of a port spine. Tuberculosis can involve the sacroiliac joint, and this becomes a diagnostic dilemma, especially when we have unilateral disease in the early phase of inflammatory arthritis. The hallmark change that helps us differentiate tuberculosis from inflammatory arthritis is the involvement of the surrounding soft tissue. In the classical teaching, we learn that unilateral disease is more likely to be because of infected arthritis rather than bilateral disease. So we have to take into consideration that even inflammatory arthritis in the early stage can give rise to a asymmetrical or unilateral involvement. But this soft tissue edema and the involvement of the surrounding soft tissue, the muscle and collections which are extending beyond the confines of the joint capsule, these are the features which help us in identification of tubercular involvement compared to inflammatory arthritis. Here a few words about brucellosis, because this is a very close differential of tubercular joint involvement. There is usually a history of contact with cattle, and the imaging manifestations are very similar to that of tuberculosis. We have spondylodiscitis, we have sacroiliitis, and we have osteomyelitis. In patients who have had a contact with TB with cattle and non-response to anti-tubercular therapy, a serology with positive confirmation of IgG and IgM helps us in identification of this disease. There can be other atypical infections which can give rise to an imaging appearance very similar to tuberculosis. So, is this TB or not? What we see here is involvement of the left hip joint as well as the iliac blade. There are areas of sclerosis as well as areas of erosion and lysis which is seen to progress. Now, this patient was on anti-tubercular therapy and we can see progression of disease with continued loss of bone both in the hip joint as well as along the iliac blades. These are the corresponding MR images where we can see this large extent of involvement. Now it is involving the gluteal muscles also, so there are extensive collections in the gluteal muscles also. There is sequestrum within the bone, so there is extensive changes. So this was actually a case of osteoarticular mucormycosis. So this is an invasive aggressive fungal infection, and usually the patients who land up with osteoarticular mucormycosis, they have some form of immune suppression either because of steroids or immune suppression therapy or a condition like chronic granulomatous disease. The source is a direct injury and inoculation by mucor. Imaging differential, as I said earlier, is tuberculosis, but not all large confluent collections and extensive involvement are because of tubercular infection. Aspiration of the pus, which leads to the diagnosis of black discharge with demonstration of fungal hyphae, clinches the diagnosis, which was done in this scenario. So to summarize, clinical presentation, alignment, the bony abnormalities, loss of cartilage, involvement of the soft tissue in the form of synovium and extrasynovium abnormalities, as well as distribution. These are the features which help us in diagnosing various type of arthritis and differentiating between them. So if we have a decreased density, we should think of inflammatory arthritis. In degenerative joint disease, because of disuse, there can be a reduction in density, but in metabolic diseases, typically the density of bone remains normal. Erosions are present in inflammatory arthritis and are usually poorly defined, but in metabolic bone diseases, they are usually sharply defined erosions. Periosteal reaction in the form of lamellar periosteal reaction can be seen in both inflammatory as well as infective arthritis. When it comes to distribution, the typical distribution of RA is metacarpophalangeal as well as the interphalangeal joint. In psoriasis, it is the interphalangeal joint, especially the distal interphalangeal joints. The PPD, which leads to abnormality of the metacarpophalangeal joints with hook-shaped erosions, and gout, where large joint, especially the first metatarsophalangeal joint involvement, is the typical. So when it comes to approach, if we have a patient of arthritis, we should see first whether it is monoarthritis or polyarthritis. If it is monoarthritis, our differential diagnosis has to be in terms of infection, degeneration, or crystal induced like gout or pseudo gout. If it is polyarthritis, then we'll have to look whether it is a chondral predominant abnormality, and if the age is also corroborative, then we have to think of osteoarthritis. If it is a synovial predominant disease with joint effusion, marginal erosions, and uniform loss of joint space, then we have to think of rheumatoid type involvement, where we have conditions like rheumatoid arthritis, SLE, and systemic sclerosis, or variants with asymmetrical or large joint involvement, in which scenario we should think of ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and enteropathic associated arthritis, which forms the bulk of conditions. So this is the kind of approach that we follow in our day-to-day practice, and thank you for a patient listening.
Thank you very much, Dr. Surbhi, for that wonderful lecture. The images were brilliant. A lot of them are spotters, so radiology residents, I hope you were paying attention. And any questions?
Thank you, Dr. Surbhi, for an excellent presentation, and I'm really, the collection of cases that you have is just amazing. And that brucellosis case, and rare in fungal infections and that all.
So that is because of our rheumatology MDT that we conduct at AIIMS.
Okay.
So it is all thanks to that.
All right. So if there is any question from the audience. So basically, ma'am, if suppose there is monoarticular involvement, we always have this dilemma whether it is infection or it is an early stage of any inflammatory arthritis. So what I learned from your talk is if suppose the inflammation is extending beyond the confine of the joint and there is collection, then we have to think about infection.
Yes. And definitely when the patient comes to you, it is always a good idea if we are even doing a CT or an MR or an ultrasound, just to ask the patient what is like the presentation. So if it's like a short duration presentation, or if the patient has been having similar kind of instances of joint swelling, so you would get an idea of what is happening. If the joint and the overlying skin is actually red, swollen, acutely inflammatory, or it is like an indolent thing and the patient says कि हाँ मुझे तो होता रहता है, फिर ठीक हो जाता है, फिर हो जाता है. So talking to patient, I think, is a lost art, which I would like to reiterate here to all the residents. Do not forget to ask your patient whenever you are doing any kind of investigation. Please ask the patient what is wrong with him or what is the period of abnormality that the patient has been experiencing. Most of the times you will get an answer. But yes, to differentiate between inflammatory and infective arthritis, any abnormality which goes beyond the joint, beyond the synovium, it is more likely to be infective rather than inflammatory.
Right, and presence of lymph nodes also.
Yes, as I showed in the tuberculosis case, yeah. So popliteal group of lymph nodes were enlarged in this scenario. So yes, that also is an indirect indicator.
And ma'am, one more thing, like, we think about this Sappho syndrome. Is it like common in India, or
it is actually very common?
We are not able to diagnose it.
Yes, we are not able to diagnose, but if in suspected cases, if these patients undergo a PET CT, most of the times you would see the classical appearance of bilateral medial clavicular involvement. So it is not as uncommon as it is made to be. It is, we do see cases, yeah.
Okay, thank you, ma'am.
Thank you.
Thank you so much, ma'am, for such a wonderful session. Now I would like to request our chairpersons to felicitate Dr. Surbhi Vyas, ma'am. I would like to request Dr. Namrata Gaur ma'am to felicitate Dr. Anjum Sayyed ma'am. I would like to request Dr. V.S. Pai sir to felicitate Dr. Sonal Saran ma'am. Thank you so much everyone for joining us today. Thank you.